So list is ready, right? Yeah.
I'll do it. Yes, sir.
Now we'll start with the quiz. Sorry for the delay, just for 30 minutes. Anyhow, we'll try to cope up with the time. So I just ask each one of you to introduce yourself. And almost 25 teams came for the quiz. And among them, 4 teams scored well. Can you all switch off your mic for a minute? Yeah, among them, 4 teams scored well and they entered into the final round. So I request every one of you to introduce yourself and your name and from which college you people are. Yeah, thank you.
Hi, Dr. Kamini from Apollo Hospitals, Chennai.
Hi, this is Dr. Sudarshan from Apollo Hospital, Chennai.
Dr. Kailash from Mayot Hospital, Chennai.
Okay, thank you. So they are team A, right? Yeah.
Myself, Dr. Asmita from AIMS now.
Okay.
Hello, myself Dr. Ravi Kumar from AIMS now.
Okay.
I'm Dr. Jwala from AIMS now.
It's on. Okay, team B is from AIMS Nagpur. Yeah. So I ask team C to introduce yourself.
Myself Dr. Pranav from MMC Chennai.
Okay.
So Dr. Aravind from Madras Medical College.
Dr. Raja from Madras Medical College.
Yeah. Welcome team C from Madras Medical College.
Dr. Yashendu from SGPGI Lucknow.
Dr. Puru.
Okay. So team D is from Sanjay Gandhi, Lucknow.
So let's start the quiz. So welcome to the quiz on pregnancy and kidney diseases. So we have 4 teams. And we have 5 rounds. And definitely the quiz master's decision in the rounds will be final and binding. So let's move on to the round 1. I'll explain to you how to proceed. So the first round is Chronicles of Care. To understand the present, we must walk through the paths of the past. So it's a question on the history. So each direct question, I'll start from team A. So each direct question will carry 10 marks. If the question is passed, it will be worth 5 marks. There is no negative marking. Okay, so let's start with team A. So you have to identify this personality and his contribution towards nephrology. Your time starts now.
Jeremy Chapman.
Wrong answer. Team B. Team C.
Baylis.
Team D.
Brenner.
Yes, that's the right answer. So what is his contribution towards nephrology? what is his contribution towards nephrology?
We are reading his textbook.
Yeah, other than that. So team D will get 5 points. So he is Barry Brenner of the Brigham and Women's Hospital. He is the author of well-known Brenner and Rector, the kidney textbook, and Fetal Origins of Kidney Disease, the Brenner's hypothesis. So states that individuals with a congenital reduction in nephron number have a greater likelihood of developing adult hypertension and subsequent renal failure. Okay, now your direct question to team B. So this is a milestone in the field of obstetrics. You have to identify this milestone and the famous personality. Actually, there is another image also. You just have a look at this image. This is a milestone in the field of obstetrics.
Louis Brown, IVF.
Yeah, right answer. So it is Louis Brown, the first IVF baby, and that is Sir Robert Edwards. He is a British physiologist. He received Nobel Prize in Physiology in 2010 for this. So team B will get 10 points. So next question to team C. It's an important event in obstetric nephrology.
Edith Helm.
Yes,
First
it's a right.
kidney.
Yeah. But another thing is, you have to tell me who it is and what is the milestone.
Edith Helm, first kidney transplant patient delivered baby
Yes.
in 1956.
Yeah. And who was the donor?
Twin sister Wister.
Yeah, Wanda Foster. So
Wanda Foster.
fine. So team C also gets. These are the twins, Edith Hem and Wanda. So this Edith Hem was the first female transplant recipient who delivered a baby. So this is Edith Hem and Wanda Foster, identical twins. And another thing is she was the one who survived for the longest time after getting a transplant. So next question is for team. So they will get full points. Then next is team D. The direct question to team D. Identify this pioneer in the field of obstetrics in India. I'll show you another image also. The time starts now. I think question has to be passed to team A.
Muthulakshmi, Dr.
Wrong. You are close actually. It's not. Team B. Team C. Okay. So actually, Muthulakshmi Reddy was no. It's not the answer. She was one of the pioneers in obstetrics, but she is another lady. She is Dr. Jerusha Girard. She is the first woman MD in obstetrics and gynecology. She received Padma Shri in 1966 by the Indian government. She is a pioneer in maternal health and founder member of FOXY. And another thing is, in 1994, the International Astronomical Union named 2 Venetian craters. Actually, there are only 3 females from India. These Venetian craters were named under her. Okay. So can we have the scores now after the round 1? Now we'll move on to round 2. So this is a round of clever clues. So teams will, I'll show you 3 clues for each question. If you crack a clue and then you will go to the final question. Okay. So if you answer the question correctly with the first clue itself, because you have to pick up what I mean, if you pick up by the first clue itself and answer the questions subsequently, you will earn full 30 marks. And if it is with the second clue, it is 20. And if it is with the third clue, it is 10 marks, right? I'll pass the question if you don't answer by the third clue, then the team will get 5 marks if they answer. Okay. So now the direct question to team A.
Time.
Okay, shall I go to the second clue? Third. You want to try?
Mycophenolate mofetil.
Yeah, that's the right answer. But you have to answer the subsequent questions. So can you explain the features?
The drug is MMF.
Yeah.
Usually causes the triad of ear, mouth, facial abnormalities, and M4 tetrad. Cleft lip, cleft palate.
Yeah, okay. Eye, any abnormalities? Eye abnormalities? Included, okay. Okay, so what is the safe period for contemplating pregnancy after stopping the drug?
Six weeks to 3 months.
Yeah, okay,
Starts-
6 weeks to 12 weeks. Yes, that's a correct answer. So they will get 10 marks. So now the direct question to team B. So this is the... So they can have charge anomaly like phenotype. Okay, now direct question to team B. A 35-year-old mother with hypertension and proteinuria detected during the first trimester of pregnancy. I'll give you a, this is a cut section of an umbilical cord. Next clue I'll move to. So this was the antenatal ultrasound. This is the image of the anomaly scan of the baby. Actually, it's mentioned also. Okay, fine. Mother had a symptomatic UTI during the pregnancy. Team C. You want to try? Okay, team D.
Single umbilical artery,
Yeah, that's correct. Then,
fetal hydronephrosis.
yeah, that's also correct.
What was the third question?
Third clue was mother had symptomatic UTI during pregnancy.
Reflux nephropathy.
Yeah, okay, that's correct. So we can give them 5 marks. So it is an isolated single umbilical artery that is associated with renal malformations, and that is most commonly associated with the VUR. Then that is, if a VUR is there in mother, it's a familial disorder. Infants also can have. The antenatal USG was showing a fetal hydronephrosis. Okay. So the direct question to team C now. So I'll go to the next clue.
Neonatal lupus, congenital heart block.
Yeah, that's correct. And you have to answer the question. So that clue was mother was on an irregular treatment for a chronic disease for which she was on immunosuppression. So the questions are, what is the diagnosis that you have already told. So what percentage of newborns will develop complete heart block?
1 to 2% will develop complete.
Okay, 2 to 5% will have. Any intervention can reduce the risk for that.
HCQ.
Yeah, that's right answer. So team C will get full marks, 10 points. Sorry, 20 points. Okay, now direct question to team D. You want to answer?
If we answer wrong, then we can move to the next clue.
If you answer now, you will have to answer the question. Otherwise, you won't get it. What is it? You cannot change it. You cannot change the answer. Your time is over, actually.
Next.
I'll go to the next clue.
Acute fatty liver pregnancy.
Yeah, that's right. That was microvesicular steatosis, okay, of liver in liver biopsy. So the third clue was this. So what is the incidence of AFLP in pregnancies?
It is
Okay, the second question, what is the incidence of AK in AFLP?
8 to 10%.
No, it's even more. What is the pathogenesis of AFLP?
It is an autosomal recessive disorder characterized by deficiency of LCH AD enzyme.
Okay, I can maybe it's around 50 to 60% in most of the studies, this incidence of AKI. And so I can maybe give you, you had answered the second clue, right? So I can maybe give you 15 marks. Okay, 15 marks. So now moving on to the round 3. So this is a clash. Yeah, you can have the scores.
In round 2, Apollo scored 10 marks. B team from AIMS Nagpur didn't score anything. And MMC team scored 20 marks and SGPG team scored 20 marks.
So now this is a different kind of round. So where there will be 4 regions. We'll ask you to take a lot. Based on that, each team will get a topic, region in the sense a topic. So there is no passing between the teams, no negative marks. Totally there will be 5 questions. Each question will carry 10 marks. So each team can gain maximum of 50 marks in this round. Okay. So the regions are preeclampsia, pregnancy and RRT, pregnancy AKI and GN, and renal physiology. Okay. So you can take the lot. Can you... So can you just read out the topics that you got?
Renal physiology.
You got renal physiology. You? RRT. Okay. Yes. Okay. So we'll start with preeclampsia. Okay. So the first set of questions will be there for...
Just want to know which team is having preeclampsia?
Team D.
Okay.
So you have to score Team D.
Yeah, that's what.
Okay. So the first question is, the term preeclampsia was derived from the Greek word which means, what is the meaning of that word?
The timer is running.
Seizure.
Wrong answer. I'll go to the next question. Which of the following is incorrect regarding preeclampsia? At least 150 minutes per week of moderate intensity exercise, sufficient to raise the heart rate, reduces the rate of preeclampsia without adverse events. Preeclampsia is complicated by AKI in around 1 to 5% of cases, and the most common cause is ATN. Calcium supplementation is protective of preeclampsia in high-risk women. In pregnant females with gestational age of less than 32 weeks, a uric acid level of more than 4.9 mg per deciliter correlates with fetal risk. So which is the incorrect answer?
C.
Wrong. Which of the following maternal factors is or are, there can be multiple answers, found to be a risk factor for preeclampsia?
Smoking.
That is found to be risk factors. Okay, is wrong.
IVF.
You are telling something.
IVF.
Okay, that is partially correct. You can give 5 marks for the question. So then, next is 25-year-old pregnant lady presented with new onset proteinuria with a PCR of 7 grams and hypertension at the time of delivery, consistent with preeclampsia. Postpartum, the proteinuria persisted at 6 months after the delivery, exceeded around 2 grams. Albumin and lipid profile was normal. She was evaluated, it was negative, she was having negative serologies. She had a normal BMI and was a non-smoker and had been previously normotensive. Because of this proteinuria, a kidney biopsy was performed. So the question is, which one of the following renal lesions has been most commonly associated with a history of preeclampsia?
FHES.
Yeah, that's the right answer. You'll get 10 points. So next, last question. Which extracorporeal therapy was found to be useful in treating preeclampsia? You have to tell me the full name. Time is over. Time is up. Let's go on to the answers. So the meaning of eclampsia is lightning. Okay. So the second question, it was like the uric acid at 32 weeks. It should be like, if it is more than 4.94, it will confer a risk.
So calcium is protective usually.
Yeah, calcium is protective.
Without magnesium maybe.
And high altitude and IF are risk factors.
I think these markers are extensively discussed yesterday. KR and HLA-C and smoking.
Smoking also is protective. Then the last one is the FSGS, that is right for them. The fifth question is dextran column apheresis for SFLT1 removal. Okay, so now let's go on to the second set of questions.
So what is the total score for them in this round is 15 marks.
Okay.
Out of 50.
So now let's move on to the next set of questions. Pregnancy and RRT. Who received it? Okay, so now your questions. Question 1. So children of women with renal disease used to be born dangerously or not at all? Stated a paper from Lancet in 1975. But before that itself, the first successful term pregnancy in a woman with ESRD on hemodialysis, it was reported by, and you have to tell me the year also. Wrong answer.
Is your mic on?
I'll move on to the next question. So which of the following is or are true in patients on hemodialysis? Beta HCG is a middle molecule and is elevated in non-pregnant individuals with ESRD. Being on dialysis does not affect the initial phases of embryonic development. Assisted reproductive techniques are encouraged in patients with ESRD. Papa can be used as a non-invasive marker for screening of Down syndrome in patients with ESRD. Maternal polyhydramnios due to fetal solute diuresis should prompt more intensive dialysis than in the mother.
E.
There can be multiple answers.
E. A and E.
Which one?
A and E.
Okay, you are anything. Okay, fine. I can give you partial, it is not fully correct.
A and T is your answer, right?
A and E.
A and
E.
A and T.
A and E.
A and T. Okay. Fine.
Okay, we'll go to that. Next question. A 32-year-old female on PD presents at 18 weeks of gestation. Which of the following are true in this situation? So the risk of small for gestational age babies may be higher on hemodialysis than PD. Conception rate is reported to be lower in PD patients and in pregnant patients. On PD, incidence of peritonitis is increased. PD can be resumed with small dwell volumes after 24 hours of LSCS if performed extraperitoneally. A weight gain of 500 grams per week should be assumed while considering dry weight in third trimester of pregnancy.
B and D. And D.
It is partially correct. We'll come to that. Okay. Regarding kidney transplantation and pregnancy, which of the following are incorrect? Donors tend to experience higher rates of preeclampsia and gestational hypertension, similar to those with higher BMI, diabetes, and pre-existing hypertension. Approximately 5 to 8% of pregnant women produce HLA-specific antibodies to paternally inherited fetal HLA antigens. Low birth weight and premature births are common in more than 50% of pregnancies. Pregnancies in kidney transplant recipients have high risk of IUGR and high risk of CS. Yeah, okay. The last question. The first scientific reports of the results of extended daily dialysis in pregnancy came from the Toronto group. Based on the available evidence, HDF in pregnant individuals is superior to hemodialysis. KT by V can have fallacies if used for measuring adequacy of hemodialysis in pregnant individuals. Rapid aneurysmal dilatation of native fistula is reported in pregnancy.
One.
Okay, you have noted the answers, no? Okay, now we'll go to the... No, you have to tell me only one answer.
Your time is up.
Okay, it will take us one. Okay. So the first answer is Confortini et al. From Italy in the year 1971. Okay, they have published the first case report, international case report. The second answer is actually the one that is shown in bold is not the answer. The other one is the answer. It is true. The beta HCG is a middle molecule. It is elevated in non-pregnant individuals. Being on dialysis does not affect the initial phases of embryonic development. The fifth option also is correct. The other two, assisted reproductive techniques are not usually encouraged in patients with ESRD. And this PAPA cannot be...
They answered A and D as the answer.
So maybe you can give A, B and E.
So how much mark? So basically...
Maybe we can give 5 marks. 7.5. 7.5, yes. So the next question. What was your answer?
The answer by them is B. D and E. That was their answer.
B, actually in pregnant patients, the on PD incidence of peritonitis is not increased. It's not increased. PD can be resumed in patients and after LSCS also if it is done extraperitoneally. So you can give them 5 marks. So this is, I think they have answered, right? So you can give full marks for them. Okay. So next question was, their answer was...
Wrong. Actually, they told the first scientific report.
Yeah, it was from the Toronto group. Actually, based on the available evidence, HTF is current evidence, it is equivalent to hemodialysis. Okay. So now we'll.
Total score in this round is 22.5 for team B.
Okay. So now we'll go to the next set of questions. Renal physiology. Who got that? You got. Okay. So moving on to the first question. Which of the following is incorrect about calcium homeostasis in pregnancy? There is an increase in calcium and phosphorus absorption from the gut. Serum ionized calcium remains unchanged during pregnancy, but total calcium level decreases. The urinary calcium excretion is reduced as a method of conservation by the maternal kidneys. Calcitonin increases during first trimester, and there is an increased production of PTHRP by the placenta.
C.
Yeah, that's the right answer. We'll go to the answers.
So just tell the options.
Yeah, fine. Okay. So what is this?
Hydronephrosis.
Yeah, but something pertaining to pregnancy.
Maybe physiology of hydronephrosis because of...
Okay, that is not the question. Okay. So, which of the following, there will be multiple answers, is or are incorrect about the hydronephrosis of pregnancy. Ureteral dilatation of up to 20 millimeter on the right and 8 millimeter on the left is consistent with physiological HDN. The dilated collecting system can hold 200 to 300 ml of urine, promoting urinary stasis. Ureteric dilatation is usually distal to the pelvic brim. Absence of ureteral jets at uretrovesical junction detected by color Doppler excludes physiological HDN.
C and D.
C and D are saying incorrect. Right? Okay. Go to the next question.
So, which of the following is incorrect? Plasma aldosterone in a pregnant woman is reported up to 8 to 10 fold higher than non-pregnant individuals. Progesterone is a key mediator for enhanced NO signaling in pregnancy. Renin is released from the ovaries and residue of the uterus. In preeclampsia, placental RAS is upregulated, but systemic RAS components are lower.
4.
Okay. The volume of kidney in pregnancy increases by
30%.
Okay. All of the following act as natriuretics in pregnancy except
Epithelial sodium channel.
Okay, we'll go to the answers now. The first one is C. The urinary calcium excretion is actually increased in patients, in pregnant ladies.
So their answer is correct.
Correct. They'll get
10
full
points, right?
10 points, yes. The second question, what was their answer?
They answered C and D.
They have answered C and D. Yes. Okay. Ureteric dilatation is usually distal to the it is usually proximal to the pelvic brim, and absence of it won't completely exclude physiological HDN.
Okay,
Actually, yes. So, what was their answer?
So they answered option number 4.
Actually, answer 1 and 2 can be taken, but 4 is definitely that is.
So 0 marks for this question.
This they have answered.
Yeah, they are getting full 10 marks for this.
This also they have answered.
So they scored 40 this round of 40.
So next one is pregnancy with AKI and GN. So a 36-year-old gravida 4 para 3 with history of chronic hypertension and history of preeclampsia was admitted at 30 weeks of gestation for management of headache and blurred vision for 3 days. Admission BP was 160/100 with a pulse rate of 94 beats per minute. She was started on magnesium sulfate and labetalol, and BP gradually improved to 138 and 84. 3 days later, her BP decreased to 130/80 with a pulse rate of 58, but she became lethargic. Her eGFR was 18 ml per minute with a urine output of 1.5 liters per day. Physical examination was significant for decreased deep tendon reflexes. So what is it?
Max self-toxicity.
Yeah. So this is the question. All are true except in mothers with pregnancy-related hypertension, intravenous magnesium is more effective than phenytoin or diazepam for preventing eclamptic seizures. Infants born to mothers receiving magnesium can develop hypermagnesemia. The next appropriate step in management for this patient is to start hemodialysis. Supportive management, including IV calcium, gluconate, IV fluids, and diuretic, should be continued.
Option 3.
So what we should do?
Delivery. We have to deliver the.
Actually, okay, we'll go to that. So next question. 32-year-old woman was referred to the Renal obstetric clinic for evaluation of a kidney disease. Which is or are, there can be multiple answers, is a recognized indication for renal biopsy? Isolated proteinuria with a PCR of 320, asymptomatic proteinuria with non-visible hematuria, episodic visible hematuria, symptomatic nephrotic syndrome after 32 weeks of gestation, unexplained deterioration in renal function before 32 weeks of gestation.
E.
Okay. A 28-year-old lady, 1 week postpartum, presents with severe flank pain. She is evaluated and imaging was done. What does it show?
Cortical necrosis. RVT.
No, you can answer only once. Okay. Then fourth question. A 26-year-old lady had an uneventful pregnancy and had a full-term normal vaginal delivery at 39 weeks. Over the next 48 hours, she noticed markedly reduced urine output, progressive swelling of feet, and worsening shortness of breath. Her BP was 170 over 100 millimeters of mercury. Serum creatinine was 4. Hemoglobin dropped from 9 to 6. So platelet count was 35,000 and peripheral smear showed 5% histiocytes. Adam TS13 levels were found to be normal. What is likely to be her renal outcome? Likely to recover with plasma exchange, usually good, 75% ESRD, recover with anti-CD20 monoclonal antibody treatment.
75% ESRD, option C.
Okay. So fifth question, which is not a correct statement about pregnancy-related TTP? Von Willebrand factor levels and Adam TS13 activity reduces up to 30% pre-pregnant levels by near term. TTP presents usually around 20 weeks of gestation up to 48 hours postpartum. Once TTP under a hematological remission, prophylaxis with aspirin is recommended for patients based on fetal maternal risk. For antibody negative TTP, there is almost 100% risk of recurrence, which is incorrect.
Option C and D.
So we'll go to the answers. The first is the next the answer is because urine output is there is no need for dialysis. We can continue with conservative management. So answer is they have answered. Okay, they'll get 10 points for that. And this also I think they have answered. It is other than that, all are like we can manage without a biopsy. The CT may show a acute renal vein thrombosis actually, but you had answered cortical necrosis. That's why I could not entertain that. This is right, 75% ESRD. It is looking like atypical HUS. The last answer is A. The other ones actually these are correct. Okay. So how many? 30 marks. Okay. Now we'll go to the round 4. This is a direct questions to each team from team A to. Can we have a total score? Okay. So now we'll go to direct questions. 4 questions will be there to each team. So this is about trials and some acts. Each question will carry 10 marks. If it is passed, 5 marks, no negative marking. So which of the following is false? PRESIS is a multi-center blinded prospective study consisting of 2 cohorts where the ratio of SFLT1 and PGF was measured in pregnant ladies hospitalized with a hypertensive disorder. If the ratio is more than 40, it indicates a higher risk of preeclampsia within 2 weeks in women hospitalized with hypertensive disorders, and with a ratio with a positive predictive value of 80%. The women with a ratio less than 40 had a 5%, less than 5% chance of developing preeclampsia within 2 weeks. In March 2023, FDA has approved this for risk assessment and clinical management of patients, pregnant ladies with preeclampsia.
Option B.
Okay. So here actually answer is coming here. So what you answered is correct. So which initiative from sorry, actually the slides have something has happened. Nothing. I actually answers are coming in between, so I thought just I'll see this next 1 second. So they will get full marks. Team A. So Team B, which initiative from Government of India aims for zero preventable maternal and newborn deaths? It was discussed yesterday. It was shown in the slides also. No, wrong answer.
Pradhan Mantri Suraksha Yojana, PMS.
No. Team D.
Suman. Maybe Suman program.
Yeah, that's the right answer. Suman Yojana. So what is it? Any idea? It's a pregnant women to take care of pregnant women for zero expense in delivery. It is Swasthya Matritva Ashwasan. Okay, yesterday it was shown in Gomati Madam's slide actually. So the pregnant ladies will have zero expense delivery and C-section facility in case of complications at public health facilities. So for dignified and respectful quality healthcare, Government of India has brought out this. So they'll get 5 points. So now the direct question towards Team C. You have to just name the trial. A multi-center open-label RCT comparing induction of labor versus expectant monitoring for gestational hypertension or a mild preeclampsia between 34 to 36 weeks of gestation. What is a trial? Just name the trial.
Hippitat.
Yeah, that's the right answer. Hypertension and preeclampsia intervention trial near term. Hippitat trials, yes. So direct question to Team D. The upper limit of abortion was extended to how many weeks for a certain categories of people, including minors, and the amendment was made in 2021 MTP Act. So
20.
What did you tell? Answer?
20 weeks.
Wrong answer.
28 weeks.
Wrong. Yeah, that's the right answer. So they'll get 5 points. No.
Someone said 28 weeks, we can explain it.
Okay, ma'am. Actually, if a medical board is there contributed for a particular reason, then it can be even after 24 weeks it can be done and constituted.
For non-salvageable anomalies which are not cannot survive at all.
So now we'll go to round 5. Actually, this is a rapid fire round. Each team will have 5 questions, direct questions. You will have 5 seconds to answer the question. And if you finish within 90 seconds, you can go back to the questions as well. Okay. So we'll go to the rapid fire round. Wrong answers will have negative marks. That is equal negative marks. You'll get a negative 10. So team A. One minute.
Plus 20 minus 10.
Yeah, plus 20 minus 10. So the new set point of plasma osmolality in pregnancy is
270.
Okay, that's the right answer. Lethal fetal dose of X-ray. Legalization of abortion in India was done in. Who reported the percutaneous kidney biopsy in first percutaneous kidney biopsy in pregnant patients?
Diekman.
After successful renal transplantation, it is generally advised to wait for how many months planning for pregnancy?
6 months.
So the answers are, the first one is correct, 270. The second, lethal fetal dose of X-ray is 100 to 500 milligray. Then legalization of abortion in India was done in 1971. Diekman, that is correct. After successful renal transplantation, at least 10 to 12 months, 1 year should be there. So they got 40. Actually, it is, which one? They told the question number 1 they have answered correctly. Question number 4 they have answered correctly. Yes. Okay. Now direct question to team B. Abortion was legalized first in which country? Pass. GFR has a diurnal variation and is 10% lower at midnight compared to the afternoon. True or false? Okay. The normal level of serum creatinine in pregnancy is lower than baseline and ranges between.
0.5.
Full Pious model is a prognostic model for. Gestational diabetes occurs in what percentage of patients with renal transplant? So we'll go to the answers. So abortion was legalized in Soviet Union in 1920, the first country to legalize it. That is, the second answer is true. So that was correct. The normal level is 0.5 to 0.8. Okay, we can take it. Full Pious model is a prognostic model for preeclampsia. You are told 8%. I cannot. It's a wide range. Okay, I cannot take it. Okay, maybe I can take it. It's okay. Fine. $80 marks. Now direct question to team C. The bipolar length of the kidney increases by
1 to 1.5 centimeter.
Yeah. Okay. Most common acid-base abnormality in pregnancy.
Respiratory alkalosis.
In females with renal angiomyolipoma, pregnancy is protective and cause regression of the lesion. True or false?
True.
Which antihypertensive used in pregnancy worsens postnatal depression?
Methyldopa.
Pregnancy is associated with increased expression of aquaporin 2 and excessive water retention. True or false?
True.
Okay. So team C, the first answer you have answered correctly. Second one also respiratory alkalosis. It is false. Actually, it will increase in size. It will rupture. It can cause bleeding. Okay. The fourth answer is right, methyl dopa. The last one is also correct. So they'll have a, how much? 70 marks. Okay. Now direct question towards team D. Most common type of kidney stones in pregnancy.
Calcium phosphate.
Okay. Incidence of AK in HELP.
Ten to 20.
The reported incidence of immune TTP is more common in pregnancy than congenital TTP. Next question. MMR of India has declined to what is the current maternal mortality rate in India in 2020 according to the report, Union report. Okay. Early onset of ovarian hyperstimulation syndrome occurs how many days after administration of ovulatory dose of HCG?
Six weeks. 30 days.
And one, okay, only one answer you can have. Okay, now we'll go to the answers. The most common kidney stones in pregnancy is calcium phosphate. That's right answer. Incidence of AK in HELP. What was your answer? 10 to 20. Okay, we can take it as correct. Okay, 10 to 20. Okay, fine. It's okay. 10% they have told. Then, what was the third question? What was the answer? They didn't answer. Okay. Fourth also they didn't answer. Fifth one they answered as 6 weeks. It's wrong. It's 3 to 7 days. So what is the score?
30 marks.
Okay. So that's the end of the session. Can we have the final score?
Team A has scored 90 marks. Team B has scored 117.5 marks. Team C has scored 140 marks. And Team D has scored 75 marks.
So the first place is Team C. Can you just stand up? From MMC, right? Second place, AIMS Nagpur. And third place, position? Apollo. So thank you very much. So I'll just, I had some tiebreaker round also. I'll just show the, I thought in case if it is required. So can you identify this personality?
Swan How.
Yeah, that's correct. She's, who is she?
Women health and kidney involvement. Pregnancy and CKD, kidney involvement.
Yeah. She was a pioneer in, she is a nephrologist. She was a pioneer in CKD. Actually, when she worked, when she started her work, she was people thought that pregnancy is not possible in patients with CKD. But, and another thing is, she had worked in transplantation also. And she herself was a donor, kidney donor. She received a kidney, and that was what she was, a humanitarian and a philanthropist. Okay, that's all. Thank you so much.
So, hello. So I just want to inform, yesterday almost the participation for the quiz was really great. Almost 70 plus residents have come, and almost 25 teams have appeared for the prelims. And out of 25 teams, we selected these 4 teams, and all
actually
of them
it was very narrow. Most of the people it was very narrow because of the start questions. I told you, because of that only actually I could select you.
Yeah. So it was tough for us, but we did it in a very genuine way. And I congratulate all the residents who come from all over India to participate in the quiz. And we congratulate all the 4 teams. And we will be announcing the prize, and we'll be giving it sooner after the next session. And the prize distribution for the yesterday's paper session and the poster session is going on. It will be announced after the first talk. Yeah, thank you. Thanks for participating.
We shall now start with the first academic session of the day. The topic is on fertility issues and contraception in CKD and renal transplant patients. This session will be chaired by Dr. S. Gomati, Professor and HOD of Nephrology at Government TD College, Alapura, Dr. Lata Chaturvedula, Professor of Obstetrics and Gynecology at Jipmer, and Dr. Sukanya Govindan, Consultant Nephrologist at Mehta Hospital, Chennai.
Our speaker for the session is Dr. Anand Chellappan, Assistant Professor of Nephrology at AIIMS Nagpur, who will address the topic. He did his MD Medicine from Jipmer and DM Nephrology from SGPGA Lucknow and started the Department of Nephrology at AIIMS Nagpur. He is also a GlomCon faculty and an editor of the prestigious ISN newsletter. We request you to...
Thank you.
Very good morning, and thanks Srijit for giving the opportunity to chair this session. I think as was asked in the quiz also, we always think CKD patients can't conceive. But yes, they do have some fertility issues, and we have seen the infertility sort of related with renal disorders. More, of course, pregnancy-induced renal disorders are more common than patients with renal disorders conceiving. We always have a dilemma. So I think you will take through, and PCOS also we do come across quite often. And with the renal disorder, I'm sure you'll take us through what actually is not true, what we are thinking as obstetricians. Please go ahead.
Thank you, respected chairpersons, and a very good morning to all the audience here. I feel immensely grateful for having had this opportunity to talk in front of you. My experience and my team's experience is very minuscule compared to the chairpersons here. So I think I would learn more from you. But then I would definitely take you through the journey of women's health. I'm a strong advocate for women's health. So with that, I start this presentation on fertility issues and contraception in CKD and kidney transplant patients. So this was the case given to me. So I'll take you through the case. It's a 32-year-old nulliparous woman and hypothyroid who underwent ovulation induction using letrozole and clomiphene and presents with these features: abdominal pain, distension, oliguria, and AKI. And the ultrasound shows bilateral symmetric enlargement of the ovaries with multiple cysts and ascites. Now, thanks to the Jipmer team for making our job easier by giving us learning objectives for the talk. So I would restrict myself to these fertility concerns in CKD, issues related to artificial reproductive technology, contraception in CKD, and a small kind of a bridge to the next session, navigating fertility and contraception. How do we strike the right balance? So I would be focusing predominantly on the pre-pregnancy issues, not on the pregnancy and the post-pregnancy issues. So fertility concerns in CKD. When we talk about fertility in CKD, most of us have a dissuasive or a negative approach, and we feel that pregnancy may not be successful. But then there is this popular quote from a Jurassic Park movie, right? So the person says life finds its way. So it's not always negative. I would like to start this talk by bringing hope into the picture as well, not just the negative aspects of fertility in CKD. So some statistics which are very important, difficult to estimate. There are not large studies to tell us what is the fertility rates in CKD transplant population. But then when you see the green box, it's data from the UK registry. There's a similar one from the Italy as well. So the national conception rates is around 79.1 to 79.5 per 1,000 women per year. But then in the dialysis population, it's just 1.4, and in the transplant, it's almost like a 10 times higher. It's 7.6. So if you take the numbers, it's 1:10 compared to the general population in the transplant recipients. The birth rate or the conception rate compared to 1:100 in dialysis population. So I'll take you through what's the normal physiology. We all know this. So there's GnRH coming and acting on the anterior pituitary, releasing the FSH and LH, acting on ovaries to cause ovulation, and we have this mid-cycle LH surge, so which results in ovulation. So what actually happens in ESRD or CKD, as it progresses, we tend to get this kind of a picture. There's an elevated prolactin level. This is because of a decreased clearance. This has an inhibitory effect on the hypothalamus, leading on to decreased FSH-LH, and of course anovulatory cycles are common. Apart from these, our patients have peculiar issues. Some of them are receiving drugs which can also interfere with fertility, like cyclophosphamide. I'm sure this must have been discussed in the lupus sessions as well. So these are certain issues why these people tend to have low fertility rates. So the normal cyclicity of the menstrual cycle is affected in the CKD population. So that's what is indicated here. Now, summing up the factors causing poor fertility in CKD. So these are some of them which we have already discussed. The abnormal sex hormone levels, loss of cyclicity, and there are also abnormal endometrial morphology, reduced ovarian reserve, and reduced libido and sexual function. There are also male factors, but I would limit myself to the women factors in this particular presentation. Similar factors as that of the women. And very important thing is the patient-provider relationship factors. How many of us do talk about fertility and contraception to patients with CKD? Very little. So if you see this study, this has been done in Canada, a survey among nephrologists and nurse practitioners, less than 1/3 reported discussing even menstrual irregularities and fertility with their patients on a regular basis. If you see other data, it's hardly once or twice a month that we discuss with a patient in the OPD. So however, nearly half of the patients report that, half of the respondents reported that these topics were desired by the female participants. So we understand the importance of discussing these issues and the negative impact it could have on them. So this is another study which looked at the role of nephrologists and nurses of the dialysis department providing fertility care to CKD patients. 88% of the nephrologists advise their female patients not to become pregnant, and these are the percentages across the different stages of CKD. Of course, we know the underlying concerns behind advising not to become pregnant, but is that the only way out? That's what we would discover in these subsequent slides. So coming to that's about the fertility issues. Now, how do we preserve fertility in a woman with CKD? There are limited number of strategies. So some of the options are intensive hemodialysis, kidney transplantation, medication management, and artificial reproductive technology. Right. So some data here. So intensive hemodialysis helps in bringing about the normal menstrual cycles. It increases pregnancy rates and return to eumenorrhea, and it's believed to be more in hemodialysis twice as that of PD. And this study showed that dialyzing 21 to 48 hours each week led to a conception rate of 15.6 versus the lower conception rates in dialysis patients, which is roughly around 1.5 to 3. Now, this is the situation in kidney transplant patients. Post-transplantation, it takes nearly 5 to 7 months for cycles to normalize and a woman to start having the menstrual cycles if she was amenorrheic before the transplantation. So it does improve the HPA axis, and there's a significant reduction in the LH, FSH, prolactin, and increase in estrogen and return of menses and ovulation. But then, not all transplant patients are equal. So it depends upon the course following transplant that decides how a patient would perform. So this is another research study which showed that there's a significant improvement in the eumenorrhea status prior to transplant and post-transplant, almost a 50% increase following transplant. Now, there are not many studies, there are just few. I've tried to quote them. So these were some of the strategies to preserve fertility. The other is a very important, relevant thing to our day-to-day practice is medication management. And one of the important medications we see is cyclophosphamide. So it causes dose, duration, and age-dependent reduction in the ovarian reserve. So it's generally advisable to avoid it in young women who want to conceive, and lower doses and shorter durations are generally favorable. Now, what are the strategies for fertility prevention in them? So we can go ahead with oocyte or embryo cryopreservation. These are not very uncommon technologies. These are now available at most of the IVF centers. Ovarian cortex cryopreservation. Like, for example, if a patient comes with a flare, we don't have much time to wait for all this. So to go ahead and do an ovulation induction and collect the oocyte. In that case, we can do ovarian cortex cryopreservation or resection of ovary and whole ovary freezing. Of course, these have not been done in large scales. These are just a few options which have been mentioned in literature. And of course, the LH releasing hormone agonist throughout the course of cyclophosphamide therapy can also be used to preserve fertility in patients who are receiving cyclophosphamide. So some facts and figures regarding cyclophosphamide based on a study which was done in the past. So 50% of women older than 32 years had a problem with the menstrual cycles resulting in amenorrhea when they received a cumulative dose of 8 grams. And this number increased to almost 90% when the dose was 12 grams. Just shows us the importance of the dose and also the age of the patient. Whereas a childhood or adolescent patients even can tolerate a dose up to 10 to 15 grams. That's what's been found previously in the studies. This is another study which looked at young women with SLE and who are possibly on the NIH regimen with monthly doses of cyclophosphamide, 0.5 to 1 gram per meter square, and they had given 3.75 milligram of leuprolide. And the primary outcome measure they wanted to see was primary ovarian failure, which they defined as 12 months of amenorrhea and an FSH level of more than 40 milli-international units per ml. And they found that the ovarian failure was 5% in GnRH treated group versus 30% in the control group. Another study which now looked at not as the ovarian failure but at the marker which indicates the ovarian reserve, which is AMH, the anti-Mullerian hormone. And as we see in this picture, there's a significant difference in the group which received cyclophosphamide alone versus the group which received cyclophosphamide with GnRH analog versus the one which received neither. Again, in a group of premenopausal SLE women who had received cyclophosphamide and leuprolide, and the leuprolide was given 10 days prior to cyclophosphamide. So that sums up the first part of the presentation on fertility issues and how do we preserve fertility in women with CKD, some strategies and to manage these patients. Coming to the second part, renal issues related to artificial reproductive technology. Now, what I found nice was the term medically assisted reproduction rather than artificial reproductive technology, which was used by the Italian guidelines. I don't think it's an entirely artificial procedure. It definitely involves a human to make it successful. So that's one thing which I noticed, and it's appreciable. So there are two types of medically assisted reproduction. For nephrologists, this is not a totally known area, so I would just sum up the basics. Grade 1 is IUI and grade 2 is IVF embryo transfer, and ICSI, that is intracytoplasmic sperm injection. Now the difference between the two is a grade 1 is a kind of a milder one where you are looking at a single follicle which matures and the ruptures, and there's a conception after we do an IUI, and that's how it's grade 1. And grade 2 is we stimulate multiple follicles together so that you get multiple follicles which you can actually aspirate and go ahead with an IVF. You can fertilize it, even cryopreserve the embryos. So that's how it is. So grade 2 requires more stimulation and possibly would portend a higher risk. So a basic of IVF cycles, there are various regimens all throughout the world. So what currently is being followed is minimal stimulation techniques. So we use LH, FSH to stimulate ovulation. So these are called the agonist cycles, and then we give a trigger shot with HCG to cause the ovum to release. So there's another viewpoint where we give antagonists as well, GnRH antagonists towards the end of the cycle, so that there's not over maturation of the follicles. So these are called antagonist cycles. So multiple different regimens are there which are being in practice these days. What's depicted here is an antagonist cycle. So various drugs are used for these purposes. FSH, LH and HCG are used. So the purpose is to stimulate more follicles and then retrieve them by transvaginal aspiration, and then in the lab the IVF is the fertilization is done, and then these are transplanted into the uterus. They can also be cryopreserved. Now the complications, the two major complications which we should be worried, especially in the renal population, is one is multi-gestation, that is multiple gestation. There's a likelihood of multiple gestation when we go for IVF, and this portends a higher risk in patients who have CKD compared to the general population. And the other is the most feared one is the ovarian hyperstimulation syndrome, which I would be talking to a little bit in detail. Now the fair incidence of mild OHSS, which is just the ovarian enlargement and a few minimal symptoms, is around 1/3 of the cycles. Severe OHSS is not a very common feature in the general population. It's characterized by capillary leak. So what basically happens is when we stimulate these follicles, there is a release of angiogenic factors which actually gain access into the circulation, causing a capillary leak phenomenon. So it's usually a localized capillary leak. These patients present with ascites, but then when it does spread to the circulation in large amounts, it results in a systemic capillary leak syndrome. So with its own consequences, that's what is indicated here. So release of vasoactive mediators, predominantly VEGF, and increased vascular permeability, third spacing, and hepatic and renal impairment. Because of this volume removal, there's hemoconcentration which can result in thrombotic episodes. Now, whom should we be concerned for all this? Patients with prior history of OHSS, PCOS patients, increased antral follicle count, AMH levels. I'm sure the gynecologists see these things prior to the IVF or the MAR procedures, but for us it's good to know. So IVF cycles using GnRH agonists compared to antagonists, and if conception occurs in the cycle, more so if it's a multiple pregnancy. Now, I will not go too much into detail. This is a classification proposed by the RCOG, and it classifies it into mild, moderate, severe and critical OHSS. The case that's given to us is also possibly a case of ovarian hyperstimulation syndrome with enlarged ovaries and ascites and tense abdomen. So these are of two types depending upon the time period at which it happens. The early one happens in the first 8 days. It's because of the HCG trigger that we give, and it's because of the excessive ovarian response. And the late one is one which happens beyond 9 days. It's a little bit more concerning. It's because of the endogenous HCG production. Once pregnancy starts, that itself starts producing HCG. So that's a reason for the late OHSS. So elevated hematocrit, hyponatremia, hypoosmolality can give you an indication that possibly this woman might be heading into ovarian hyperstimulation syndrome. But then don't generalize it. There are a lot of differential diagnoses to all these. So these are pelvic infections, pelvic abscesses, and appendicitis, torsion, bowel perforation. So it's good to keep our eyes open and be vigilant and look for the other causes. And it's not a default diagnosis in a woman who has undergone IVF. Now, AKI, what could be the possible mechanisms? The logical mechanism here is a capillary leak with a pre-renal AKI, which if it persists, goes on to acute cortical necrosis or acute tubular necrosis, depending upon the severity. Now, the ascites also causes intra-abdominal hypertension and abdominal compartment syndrome, and ureteric obstruction can also happen as a result of this ovarian enlargement. There are case reports from literature where the ovaries have enlarged to such an extent that they have compressed on the ureters, causing hydronephrosis and AKI. Use of nephrotoxic medication, these are recommended by RCOG not to be used during these cycles, but then if these are used, which are common for prescriptions for pain, they can result in acute kidney injury. And while aspiration of the oocytes, we could inadvertently damage the vessels, and there could be retroperitoneal hematomas, ureter can be damaged. So these are some of the etiologies. So some selected case reports from which have been previously published. The first one shows us the MR picture of a bilateral enlarged ovaries with hydronephrosis. Same cuts here showing the compression of the ureters. And the second was is a case of cortical necrosis published in the Indian Journal of Nephrology. Now, how do we manage? So the management is definitely not a simple task. And this is an area which again reinforces the need for multidisciplinary care. It's not just the obstetrician or the gynecologist's job, but it's also equally the job of a physician and the nephrologist also in a severe case to pitch in and manage. So simple mild to cases can be managed on OPD basis. NSAIDs should be avoided, and since there's a risk for thrombosis, thromboprophylaxis may be provided. And paracentesis can also be done to reduce abdominal hypertension, and a daily review of the symptoms has to be done. If you're managing on the outpatient basis, the IVF clinic should definitely call the patient and find out what are their symptoms, and if possible do a hematocrit monitoring on a regular basis. And rising hematocrit could be an indication that it's time to reassess. So these are some of the red flags which I've mentioned. All of us would recognize these are red flags in most of the critical conditions: oliguria, tachycardia, hypotension, and raising abdominal girth and hematocrit. Now, how do you manage severe cases, critical cases? It's better not to go for OPD management. It's better to admit and manage. And fluid replacement initial stages can be guided by thirst, but then subsequently crystalloids or colloids can be used. And paracentesis has also been recommended in few indications to reduce the abdominal compartment hypertension. Surgery in selected cases with the required expertise can be done. How do we prevent it? A good risk assessment, and IV albumin at the time of oocyte retrieval has also been shown in one of the Cochrane reviews that it can reduce the incidence of these complications, and dopamine agonists like cabergoline and avoidance of nephrotoxic medications. So the incidence is more in grade 2 medically assisted reproduction, and we know the reason behind it now, that we stimulate more follicles, there's more chances of ovarian hyperstimulation happening in grade 2 medically assisted reproduction. So is there any data? Not much. This is one of the systematic reviews which has been published, which assessed 84 fertility treatment cycles in 68 women. And some important points: preeclampsia, multifetal gestation, lower gestational age, and low birth weight was more common when these women went ahead with artificial reproductive technology. So yes, there are things to worry here. So what are the suggested practices? The Italian guidelines give this statement is to avoid multiple pregnancy if we are advising them on these technologies, and check weight and blood pressure. A rapid rise should suggest a possibility of ovarian hyperstimulation. Use prophylactic aspirin or heparin. Avoid intradialytic heparin, especially before the ovum retrieval, 12 hours before and 24 hours after, and cautious low dose stimulation. What they say is a 30% lower dose of these gonadotropins, which can be used in CKD population to reduce the incidence of ovarian hyperstimulation. So coming to the penultimate section is on contraception, the why, when and what. Again, not a topic that a nephrologist frequently discusses, but then it's very important. Just look at this State of World Population report. Pregnancy is a right, it's a human right, a right of a person, but then nearly 121 million unintended pregnancies occur every year, and nearly 60% of them end in abortions. This actually represents a global failure to uphold a basic human right. So do women even have the right to decide their pregnancy? Is a thing which sparks up in our mind when we see this report. So global prevalence of CKD has been steadily increasing. We can't avoid it. 1 in every 10 is having a CKD now. So it's uncommon that we may not notice a CKD woman asking for a medically assisted reproductive technology, or a CKD woman coming up with pregnancy. So it's up to us to manage it, accept it. This is the future, and we need to also learn how do we manage these situations. But why is contraception needed? We talked a lot about fertility and the importance of it giving hope. But yes, contraception is also essential because of these teratogenic medicines. A lot of them are on teratogenic medicines. I don't have to explain all this. All of us know it. ACE, ARBs, MMF, rituximab, all these are usually withheld or not given. Adverse outcomes, flares, immunological diseases can flare up, and there can be a progressive decline in the renal function during the course of pregnancy. And all said and done, fertility is low in CKD and all those. Fertility still is there, and women do conceive, and we need to acknowledge this fact. So whom do we advise? When do we advise? When do we advise them in the OPD? Right? So it should begin in the early CKD stages. Don't wait for stage 4, stage 5. Begin early. Right? Spark a conversation. Women want to talk about it. It's not like it's because of our negligence that we don't talk about it. But then studies have also shown that they are happier if their issues are brought up during counseling. But again, in the right sense. Dialysis patients should be advised to delay conception if transplant is an option. And glomerular disease patients who are not in remission, at least 6 months wait is advised in lupus nephritis, and switch to non-teratogenic medications immediately after delivery. If a CKD woman delivers, use this as an opportunity, because a subsequent delivery can have more complications. So use this as a time point to advise them on contraception. That's one important time point. Even though they have crossed this pregnancy, the next may not be as fruitful as this. Kidney transplant recipients, as Swati had already told, it's at least 1 year and after transplant, but then it comes with a lot of clauses. The patient should have stable graft function, proteinuria should be less than 500 milligram. So these are some of the things. So not all transplant patients have a very good fertility and uneventful course. It again depends on how they are actually faring post-transplant. And kidney donors and those with uncontrolled hypertension and those on teratogenic medications. Now this is the guideline. There's a UK guideline. There's a recommendation by the Italian Society. So it says that you offer it to all patients who are of the reproductive age group and those who have contraindications for these. Now what is the gap? So 30% of the patients, as per the USRDS data, never received any pre-ASRD nephrology care, and the discussion seems not to be a priority during a nephrology visit. National survey, only 46% of the nephrologists counsel female patients regarding contraception, and the QRGN survey of adult nephrologists, more than 65% of the respondents lacked confidence in managing women's health issues, including menstrual disorders, preconception, pregnancy management, and menopause. So there's a large gap that has to be filled in this aspect. So broadly, we all know these temporary permanent measures of contraception from our basic trainings. So I would not be going into details of these. So these are the basic classification, the barrier methods, estrogen-free contraception and estrogen-containing contraception. Just the important points here: estrogen-containing contraception, the caution word is thrombosis risk and hypertension, and can also worsen proteinuria in CKD patients. So the preferred ones are actually the progesterone-containing pills. This is what is recommended by the UK Renal Association, is to use a progesterone-only pill or a progesterone subdermal implant, or the progesterone IUD system is the possibly a preferred contraception in these patients. I just take 5 more minutes of your time. So coming to the other contraceptive measures, emergency permanent termination, nothing different from that in the general population. These can be used, and the failure, the point to note here is in the initial 3 months, even following tubectomy or vasectomy, we need to resort to other contraceptive measures. Now the WHO gives a way to assess the eligibility for contraception, and it grades the various contraceptive measures, and this is possibly an useful algorithm to decide on contraception in CKD patients. Now SLE is another cohort where also we generally tend to avoid estrogen containing combined oral contraceptives. There also progesterone containing contraceptives, IUDs, are a preferred option. Now postpartum lactation, again progesterone containing and copper IUDs are preferred. Now organ transplant, depending upon the course following transplant, the contraception can vary. Complicated patients, progesterone only pills, progesterone implants, and these are under the category 2, and new IUD is not advisable because of an increased chance of infection in the first 2 to 3 weeks following IUD insertion. And an uncomplicated solid organ transplant can initiate any of the methods, and combined oral contraceptives are category 4. Now, just a final few slides. Again, this is not a hardcore theory, but it's more of, I would say, the summing up the thing. This was a paper in 1975 published in The Lancet, which was also talked about in the quiz, which said that, which talked about the nihilism against pregnancy in women with CKD, right? So if the doctors have their way of counseling, then the pregnancies may not occur in CKD. But are we talking about patient empowerment versus primum non nocere? Something that we need to think here. Pregnancy is something, it's an autonomous decision, and even a normal pregnancy is not associated without risks. So it's something which we need to think. I'm not saying advocate this over the other, but then it's a balanced approach. A beautiful paper by Dr. Piccoli's group. I'm sure the next talk would be something which we would all be looking up to. So I would not be talking much on these. So striking the right balance would be to ask the patient, discuss her priorities and doubts, discuss reproductive freedom, start with hope. Don't give all the negative inputs in the beginning itself. Start with hope. Discuss risks extensively. Plan to mitigate the risks if you're going ahead with pregnancy and fertility planning in these patients. Define the best timing. Review the the ongoing drugs is extremely important. Evaluation fertility options if appropriate. And this is another approach which Dr. Piccoli's group has given in the recently published paper, which I found very nice and possibly also useful in our day-to-day counseling. Use a case-based scenario to counsel your patients. Don't thrust them with a lot of statistics saying this many percentage will be stillborn, this many will be having preeclampsia. Give them a case-based approach to what it is. Give the best case, intermediate, and the worst case. And something which I also came upon in this book by Morgan Housel, which says there are some patterns which never change. We all appreciate stories have a better impact rather than statistics. So that's what even we have seen our day-to-day practice. Tell them scenarios, explain them scenarios while you're counseling them. So that's possibly a way. Rather than saying no to pregnancy and fertility in CKD, an informed decision would possibly be a more balanced approach to how we think and approach this issue of fertility and contraception in CKD. Thank you to Jipmer, Dr. Srijit sir, and Dr. Premada ma'am, Sabari, and the department is, I think I was a master of ceremony for the first update, and I'm really grateful for the opportunity that sir has provided, and thank you so much for being a lovely audience. And thanks to the chairpersons. I would be keen to learn more, because this is more of a learning thing, preparing for this presentation rather than telling which is the way around. So open to the...
For this wonderful presentation.
Thank you.
In fact, it was a very lucid presentation. In that in a busy schedule in our OPD, we don't find much time to counsel these patients regarding the pregnancy and contraception and all those things. I think even if you are busy, you should spend a fraction of your time for counseling these patients, because an unplanned pregnancy definitely can adversely influence the even the early CKD. See, nephrologists always say that it's not advisable to become pregnant. That is because we are concerned about our pocket. Because following pregnancy, even if it is a mild over a period of time, they can push the patient into ESRD. That is our major concern. Next thing is what I want to tell is what about the donors? Because women are really generous. They are donating kidneys to their beloveds. So, what is the...
There is a risk of hypertension and preeclampsia in donors. So the contraception option has to be given to these women as well.
And they have to complete their pregnancy, family before donation. That is also...
Yeah, if that's the option is there, that would be a preferred approach compared to those who have completed the donation.
Nothing, just in our cultural practices, we usually discuss contraception in the who are married and all that. But being a pediatric nephrologist, I do come across children or young adults and adolescents who have lupus or have early CKD. We do not culturally discuss contraception with them. I think that's not correct. And beyond 13 years or so, you should have a talk with the child or the girl separately, and also advise them about if they are to indulge in sexual practices, that they have to understand what is contraception and why they should not be going ahead without contraception. So I think that is one more thing that we never discuss at all, even in a scientific forum, but I think it's very, very appropriate that we all understand it and do it in a sensible and a sensitive manner.
Yeah, I think it's not about who does it. It's a combined effort. That's what I would say. To bring life into this world, it needs two people, right? And it's not like the nephrologist or the gynecologist will do. It's a combined effort, and it's high time where possibly our society should also work towards having obstetric nephrology as a combined effort to counsel these patients in a systematic manner, so that we could avoid such situations. Especially immunological diseases, we do counsel before we start them on cyclophosphamide or MMF. We are counseling. counseling. But then extending it to the CKD spectrum is also equally important. And a liaison with the gynecology obstetrics department is extremely important so that this can be systematized and be done in a more organized fashion. Though we are running busy OPDs, I think it should be prioritized because neither can we ignore CKD. The number is now 1 in 10 of the population. Neither can we ignore the fact that the fertility rates have dropped significantly and the number of patients going for medically assisted reproduction is definitely going to increase in the past. Just giving a striking figure, one of the striking figures is the world will reach the replacement, will go below the replacement population level by the end of this century. That is, we will be struggling to have children. So that's what is predicted. We talked about population explosion, but now there's a population implosion which is actually coming in front of us. So today we are talking in terms of avoiding pregnancy, but there will be a time where we actually look up to pregnancy and would want to preserve fertility. So I think it's an important thing that a liaison between these streams should be done, and it should be prioritized over most of the other things because this is what gives life to this world, and as I say, actually it's extremely important, and that would solve most of these issues.
Thank you, Anand. I wanted to put in few points from gynecologist point of view.
Yes.
You correctly brought about prevention in PCOS. Usually, I mean, for assisted reproduction, it's not artificial, it is now assisted reproduction. Yeah. So in that we actually use only antagonist cycles, that the follicles are, that's one thing, and usually these patients undergo frozen embryo transfer to prevent OHS. And when we talk about contraceptive counseling, you brought in about pills. Copper T is a very good option, and with insert in postpartum. Oh, that's a very good option. And Government of India gives it free of cost, and dipomedroxyprogesterone, that is also free of cost, which can be used for these patients. Just wanted to bring in that.
Yeah, thank you so much.
Thank you.
Thank you so much.
Mirena is there, but it's not free of cost, so patients who can afford it.
Because you brought up the question of kidney donors. We have had few donors who conceived after donation. I think primarily it depends upon the age of the woman. We have had donors in their late 20s, absolutely no issues, not even hypertension, no proteinuria, nothing, everything went absolutely well. Because I think these were wives who donated to their husbands, and they were quite young. So I think it's not that donor we should be afraid. We were afraid. Actually, first pregnancy in the donor was 6 months after donation. So we were really worried, and we realized that we need to advise contraception to these people at that point of time. But then, at least I think there were 3 again, quite offhand, but there were more where the pregnancy in the kidney donor went absolutely smooth, no issues whatsoever. Probably because the donors were all very young.
Thank you, sir, for that wonderful presentation. I like the term that you used, reproductive freedom. That was very inspiring to a young nephrologist. The question I had to ask is, recently when I did I was not noticing it before, but recently when I did the rounds in my dialysis unit, I found that some of my young dialysis female patients whose native kidney disease was, one was lupus and other was ANCA, they were having regular, so I never thought they were having cycles, but suddenly I noticed it because the dialysis technician was giving heparin-free dialysis. So I was thinking, why you are giving heparin-free? She is having her periods. So I told that is not required, but I realized that few of my young dialysis patients are actually having regular cycles. I have never discussed contraceptions with them. So are they actual regular cycles, or are they anovulatory cycles? How can I differentiate, and when should I advise them contraception?
Again, see, it depends upon the cyclicity of the periods that the woman is having. If somebody is having a regular cycle, I would, I don't know how we could actually differentiate. We could use possibly the hormonal tests to estimate.
But
that
we
can be
don't
done.
really use a woman who's having regular cycles. We presume that they have, ovulatory cycles. Another thing is you can ask their symptoms. Many of them talk about the discharge they have during around the time of ovulation. It will be profuse, watery discharge. That is how it is because of the estrogen effect, peak of estrogen. So that is one way. And we presume that these patients are ovulating, so better to advise contraception. Even anovulatory cycles, it's not that all those who have, PCOS, usually it's anovulatory. Not that all those who have such cycles will not ovulate. They may be having irregular, they may ovulate. If you look at PCOS patients, at least only 30% of the patients actually come with infertility. Rest of them do conceive on their own. So contraception is a good thing. Another thing you look at it is when you're giving contraception, I'm talking about PCOS cycle without, you can give combined oral contraceptive pills. That is also fine, but whatever it is, they require contraception. It's not that they cannot conceive. That we have to keep in mind. And we have seen patients with renal disorders who have not been counseled, they have become pregnant, and invariably they send back to us saying that termination of pregnancy. And that I think we should avoid. I feel if it's not now, it's never, at least in our situation. So all those things we have to keep in mind, and we should counsel them about contraception.
Thank you for bringing up that point.
Hello sir, great talk sir. So my doubt is, you just mentioned about HT versus PD. The fertility rates are better with HT versus PD. So why is that?
Maybe because of the, again, not many large studies here. The more, the duration of hemodialysis and removal of the solutes possibly helps in normalization of the cycles. That's what's been shown, but not extensive data here. So especially the nocturnal hemodialysis programs with prolonged duration sessions up to like 35 to 48 hours, there you achieve possibly a better clearance and resumption of the cycles. That's what is believed.
Thank you, Dr. Anand, for the wonderful session.
Thank you.
We request the chairpersons to present the memento to our speaker.
Really nice to see Anand back here. I remember you now, and Sukanya, who's been our postgraduate.
We request Dr. Srijit to hand over the mementos to the chairpersons as a token of appreciation. We'll have a brief award session now. Over to Dr. Sabri, sir.
So before that, a few announcements. We do have the certificates in the counter for all the delegates and the faculties. I request everyone to collect the certificates. And I'm happy to announce that Tamil Nadu Medical Council has awarded 3 credit hours for this CME. And the certificates will be mailed to the mail ID that you have registered by the Tamil Nadu Medical Council. So a short award presentation ceremony. Yesterday, I think we received almost 20 abstracts related to pregnancy and kidney disease. And among that, we have selected 3 for paper presentation, and that has been presented yesterday. So 2 papers have been selected for a travel grant and best paper award. So that will be announced now. So Dr. Deepa from Alappuzha Medical College. I request Dr. Srijit Parameswaran and Dr. Priyambada ma'am, Professor of Nephrology, to hand over the prizes. The next one is Dr. Yashendu Sharda from Sanjay Gandhi Postgraduate Institute of Medical Sciences. Now we had an interesting quiz session in the morning. So I request Dr. Swati and Dr. Karthik to join with us. So the first prize, the winners will be getting a cash prize of about 15,000 and the runners will be getting a cash prize of about 10,000. The certificates will be emailed to them, and I call upon the runners AIMS Nagpur to come to the stage to get the check. So I call upon the winners from Madras Medical College.
Sir, can you please join us?
We had actually 16 posters today, and 2 posters will be awarded. We will announce the poster results after this session. And the rest of the participants from the quiz will be getting a certificate that will be mailed to your email ID. Thank you.
Moving forward to our next session on pregnancy in chronic kidney disease. Our chairpersons would be Dr. Gauri Dorairajan, Professor and HOD of Obstetrics and Gynecology at Jipmer, Pondicherry, Dr. P.S. Priyamvada, Professor of Nephrology at Jipmer, and Dr. Sabrinath S., Assistant Professor of Nephrology at Jipmer.
Our distinguished speaker for this session is Dr. Georgina Piccoli, Professor from Le Mans, France. She completed her UG and PG at the University of Torino, Italy. She then set up a nephrology unit in the San Luigi Hospital. Her areas of interest include diet and pregnancy, quality of life, and ethical aspects of nephrology. She has authored over 200 papers indexed in Medline. We shall now be moving on to the presentation.
Come over.
I just want to go to the back.
Thank you.
Thank you.
Thank you so much, Amin, for the care.
Thank you. Thank you. Okay.
It's a pleasure to be with you, even at a distance, and it's an honor having been invited in this fantastic seminary on pregnancy and kidney. I am Georgina Piccoli. I am an Italian nephrologist, but I've been in France since 8 years, and I started my interest in how this pregnancy started with 2 pregnancies. 5 years This is my team, Massimo Giorgiani, working with me here in France. Fertility is an obstetrician working in Italy, and Gianfranco Calvillo is my half-sister that was 7. None of us has been So I have been challenged by this case creatinine is already slightly high, and underwent a kidney biopsy that found IgA nephropathy. She was started on antiproteinuric majors, but she defaulted to treatment and was lost to follow-up. But 3 years later, she presented again with hypertension, always proteinuria, and a serum creatinine that was even higher than 3 years previously, and she was pregnant 14 weeks and wanted to continue pregnancy. So, young woman, hypertension, lost to follow-up, no counseling, moderate progression, and at 14 weeks, she has proteinuria, hypertension, and presumably CKD stage 3, 3B, all depends upon the body size. So, what to do? Well, this is what I would like to share with you, the theory and the practice, starting from counseling, and then going through the round trip from CKD to pregnancy complication, and from pregnancy complication to CKD, and noticing also something that we have to think about after this complicated journey about the children. There are also a few pragmatic management points that are actually the core of this decision. So what's the practice? It's a very new specialty. And it started not so well because even on great journal like Lancet and great experts tended to say, do not have children if you have work. However, reproductive health is very broadly defined in capability to decide if, when, and how often to do so. Is a well-acknowledged right. So, when we consider the fact that the exchange only recently, it's not surprising to understand that our knowledge on women's health as adult nephrologists is relatively low, as this nice study shows. But it's not just because we are used to see older people, because the same problems are shared by pediatric nephrologists. So we have to be honest and to think that we have to learn more, and a meeting like this one is very important in this regard. So counseling may be done in different ways, whether before pregnancy, as everybody says should be done, but at least in our experience, less than half of women actually undergo the pre-gestational counseling. And there are very many barriers to pregnancy in CKD. Psychological, fear of risks, sexual dysfunction, that will adaptation of pregnancy, so this is not a problem. Low availability of preconception counseling is a very, very important problem. We can face counseling in two different ways. We can face a word-based counseling that underlines the importance of the progress this woman can have, and starts from the worst case scenario. Such a counseling is very informative of risks, may protect physicians from rather important criticism and legal actions, but may make leading pregnancy that hell may scare them and put them in a very bad mood. On the other hand, what we try to do more often is a success-based counseling that may help to understand that there is always a best case scenario, but it's not for everything. It's not treatment against CKD, but it's something that can give hope and even hope and put people in a better mood towards compliance. On the other hand, it may lead to underestimated risks. The best case scenario is perfect one. Everything's fine, baby born term, near term, no need for hospitalization, ICU, and CKD is safe. This is almost a rule in CKD1 without hypertension and proteinuria. But as soon as we go higher with CKD stages, hypertension and proteinuria, we have more open intermediate scenarios in which the baby is born preterm but does not go so badly, and some special care, and maybe the kidney function worsens, not in a dramatic way. But there is always, and we have to worry about it, the worst case scenario in which the baby dies in utero and or the mother needs dialysis and over a very preterm baby is born and does not survive. So, the reason why we prefer to work with scenarios is the fact that we have no magic number on each of these items. Probability of a newborn baby, that's also very much on the availability of care. A full-term baby, that's more about the maternal situation. Development abnormalities that are not just congenital, that may also be linked to very early preterm delivery, and possibility of preserving the kidney function. We know these are risks. We know they increase for CKD stages, but we have no number quantified. There was an attempt to define mildly increased risk, moderately and highly increased risk, blood pressure in highly increased risk is called control, proteinuria is over 1 gram, eGFR is less than 60. Actually, this is the case of our patient, but things are not so simple. It's very different if she was not treated for hypertension and becomes hypertensive, or if she has a resistant hypertension. So the conclusion of this paper was that everybody can make it, but there is a higher heterogeneity of the disease, and we have to admit that our knowledge is limited. Counseling is advising on risks and chances, and there are some things that we cannot modify, like age, ethnicity, social status, and then the presence of some of the diseases. So before giving an idea to this young woman of which are her risks, we should know something more about what did she drop from the lab, why did she come back? What does she do in life? What is her social status? Is she taking any medication? Do we have some data in the last follow-up period? How is her certain albumin to her proteins coagulation? So let's look a bit to the reference data back and forth CKD and complications. We know that about 3% of women in childbearing age have some form of CKD, even if those who have severe CKD are much less common, are not so exceptional, and very often pregnancy is the moment in which we discover it. Which are the main risks for the mother? Maternal death, rare, very rare in high-income countries, but not so rare in low-income countries. CKD progression, this is a problem in CKD, in advanced CKD. Immunological flares and transplant rejections are always possible, but probably less frequent than in the past. But abortion, stillbirth, and prenatal death are relatively common in advanced CKD stage, especially the younger stage. What about the baby? They are often small or very small, but more than the actual size. What's important is their centile, where they grow restricted, exposed to hypoxia during pregnancy or not. The good news is that we do not have an increased number of malformations except those who inherited their disease. And we will speak later about the baby's health. So, small babies are not alike. Babies who grow over their normal line are probably outcome, independently from the weight, from babies that started well and then had a flattening of the growth curve. Risk of all adverse pregnancy outcome is increased. There are a few systematic ratings that in the end they just say it's risky. But it's very difficult to say how risky in which stage. This is why I'm showing you some data from our group. At that point there were about 500 patients in this large cohort. Now we have more than 1,000. And as you can see, all the risk for the baby, preterm, pelvic preterm, cesarean section, and small for gestational age baby increase going up with CKD stages. And the same is for the mother. The latest stages have a higher risk of further inheritance. But let's look at one outcome. Early preterm delivery before 34 gestational days. In our population, the risk in the low risk pregnancies is about 1%. It rises to 3% in all patients. Stage 1, without hypertension, without proteinuria, nothing is treated. But this is more interesting. If stage 1 has hypertension or proteinuria, the risk is about 20 times higher. And if we deal with stages 2, 3, 4, 5 without hypertension and proteinuria, the risk is the same. While if we combine higher stages, hypertension and proteinuria, roughly half of them and we are without hypertension. But let me just underline that the risk is not just limited to CKD stage hypertension and proteinuria, because even kidney donors have a high risk, and even patients with early casts, nothing is trivial. And this is the last paper we recently published on the top of cohort on teen international that shows that even having an interstitial disease or having a history of acute nephritis, is associated with a shorter gestational time. It's not a disaster, but we have to take care of that too. And of course, if we have patients with more, what does it mean in terms of risk of preterm delivery and preeclampsia? Well, we consider that there is balance in transportation, highly impaired palpation. But even when the placenta starts well, having kidney disease will change the balance and increase the risk of preterm delivery, like early term delivery, and that what if they combine? This is a nice study on IgA nephropathy with station that tells us that if we are lucky and a patient has a non-complicated pregnancy, the risk of progression is low, but if her pregnancy will become, we have to take even more attention, to the evolution of pregnancy. So, in this case, to be able to answer to some of the questions, we should know, is she taking any medication? Hypertension without treatment is different from hypertension. We have some data on the lost to follow-up period. If she had a higher circadian, let's say 2.1, and now it's 1.8, this is a very good prognostic sign that bad prognostic sign. How is her serum albumin or proteins, ovulation? Albumin may be even more important. So, to summarize this first part, CKD is always a risk factor for adverse pregnancy outcomes for each stage. The reduction in tumor tissue is associated with high risk, so don't forget major ultrasounds, and always progressively increase in stages in the presence of proteinuria and hypertension. But let's not give number. We have no number. We have to admit that we cannot quantify that. We hope to go towards a good pregnancy outcome. The first fundamental issue in dealing with high-risk pregnancies is control. Frequent controls are the basis, and this is one of the very few attempts to try to give a minimum that was done by the Italian Society of Nephrology some time ago, stage 1 at least monthly, up to weekly in advanced CKD states. And this is also modulated by the presence of proteinuria. In our case, we will see the patient at least every 2 weeks, and by hypertension or a history of urinary tract infection. And these same recommendations were taken by the study group who tried to put some ideas together in the management of nephritis in pregnancy. So, in this case, hospitalization would be probably a good idea if severe hypertension or markedly reduced albumin levels or severe edema are found. Stepwise correction of hypertension, nutritional management, assessment of fetal health should be started. Discussion on the possibility that dialysis may be needed in pregnancy, and after that assessment, we would probably suggest her on monitoring of blood pressure and weekly controls at least on fluid. About hypertension, I will not get into the subtleties of hypertension control, and I will remind you that if we have two journals, pregnancy hypertension and hypertension pregnancy, both could be the factor on this issue is because this actually is a problem. Hypertension is classically defined as blood pressure over 140/90 on two occasions at 4 hours apart. I wonder how many of us have 24 hours with our pregnant patients in our office, and it's related to pregnancy after 20 weeks. It's so simple. I would suggest reading this fantastic scientific statement of the American Heart Association that was coordinated by Vesna Garovich, who is one of the best experts in kidney in pregnancy. And she reports the classic definitions, but also reminds that the thresholds since 2017 were lowered by the American College of Cardiology and American Heart Association. And now diagnosis of stage 1 hypertension is about 130 or 80. And this is particularly important in pregnancy because theoretically blood pressure in physiological pregnancy should go down, so the threshold should be lowered. So in any case, blood pressure is crucial, and we have to be aware that even if we do not correct, it's the basic thresholds are high in pregnancy. The CHIPS trial in 2015 showed that more aggressive treatment was, if not of benefit, at least not harmful. But more recently, in 2022, the TAP trial defined the fact that actually lower blood pressure improves pregnancy outcomes, and these conclusions change attitudes beyond the chronic hypertension issue, setting new goals for hypertension treatment in pregnancy. And this is important also in CKD, because in CKD, all the guidelines, Italian guidelines 2015, 2022, most recent UK and German and Dutch guidelines, all set a lower blood pressure threshold, because it was not sound to keep a higher pressure in pregnancy as compared to what we would do in PKD patients. And the same ideas and the same definitions are taken by the group who wrote down some indications on the management of glomerular diseases in pregnancies. I will not go into details about the choice of drugs, because it's always the same old drugs of proved efficacy, and since we are all scared to add something new in pregnancy, we have a sort of old-fashioned series of drugs that can, however, change a little bit according to the circumstance. So, what to do? Well, first of all, try to be sure. 24-hour blood pressure monitoring when possible may help. Also, identifying the best moment in the day to start treatment. Start slowly. Consider hospitalization. Do not normalize one shot, because there is a wide variability of response, especially in pregnancy. Check frequently. Provide an easy contact, and check at least weekly in person or remote. Choose wisely. Overall, the advantage of alpha-methyldopa-labetalol and doxazosine is that they do not increase edema. Nifedipine and similar drugs may increase edema. Preferences are highly context sensitive. So, above all, use a drug well. What about low-dose aspirin? Well, this is something that has very low risk. That is very important in all kinds of high-risk pregnancies. However, the dose is not completely known. It may range from 75 to 130, 50 milligrams per day. It may start from positive pregnancy test to 12 up to maximum of 16 weeks. Someone stops them, some stop them before delivery, someone does not stop them at all. But we know that at least there is no disadvantage in stopping the aspirin if we think that delivery is imminent. So in our case, we should probably start aspirin at standard dose, the one chosen by the gynecologist, because 14 weeks is the limit, but we are still there. And what's very important is to control anemia. Check iron stores, regulate them if needed. B12 and folic acid, avoid anemia. This is very, very important. And avoiding anemia means iron. But about iron, we have so many different options, as you see in this slide. So our suggestion is, whenever possible, in this case, preconception, it's better to have the IV iron preconception than in the first trimester, in which even very much discussed. There is, however, there are some reports of fatal risk. In the second trimester is relatively safe up to 30 weeks, term after which a quota that is difficult to quantify goes to refuse. But don't forget vitamin levels are very important. Ours are CKD patients. Vitamin D is very important. And even if no study ever demonstrated that giving vitamin D to everybody has a good result, but at least deficit have to be corrected. Nutritional management is a very, very important point. The guidelines on CKD and glomerulonephritis suggest to avoid nutritional deficits, avoidance of excessive weight gain, avoidance of high protein diets, and much attention on food quality. That we experience, especially of Italian society, nephrology is very positive. Vegan, vegetarian, low proteins, relatively low, 0.8 diets, even supplemented with mixtures of amino and keto acids. These diets that are a little bit against the habit of giving more proteins to pregnant women were able to reduce, there are still some peaks, the increase of proteinuria and GSR during pregnancy in of high-risk pregnancies. And they were not at all detrimental for the baby. The incidence of small babies and of early and extremely preterm babies was significantly reduced in diet conditions. And there are several examples about these, even without, necessarily without supplementation. A plant-based diet, a vegan diet, may have relevant advantages, even if the same amount of protein. This has been confirmed in several studies, but in this patient who has heavy proteinuria, you might like to see this paper that is called in acids that has also dietary suggestions and a scheme that we use to different backgrounds. The idea is actually not widespread, but good enough to be integrated also in the Dutch guidelines for pregnancy CKD. So, to wrap up this part, in this case, check nutritional status, check albumin levels, vitamins and iron. Above all, assess your nutritional habits, avoid ultra-processed foods, consider that a moderately strict plant-based diet, eventually supplemented with alpha keto acids and amino acids, may be a good option to stabilize the kidney disease during pregnancy. The third last point that I would like to discuss with you is about specific approaches on glomerulonephritis. Always referring to this study with the regulatory team, I will not get into the details. Once more, we have different options beyond just a few drugs used, steroids, calcineurin inhibitors, iodine. Rituximab starts being an option, but everything is very slow and should be slow because we have considered the first input heart. And there are some very nice schema management of patients. This paper, which is analysis. But in our case, what should we do? First of all, we should check again the previous values. We should follow up proteinuria, seeing if it changes or not during pregnancy, especially once the pressure has been under control. We should consider the option of valves or not. We should consider the option of steroids. No choice can be undertaken without knowledge There is no secret recipe in the management of CKD pregnancy. Patients experience teamwork, strict control, normalization of blood pressure, low dose aspirin, nutritional management, and case-by-case discussion of the management of complex and immunological diseases. But before beginning, let me remind you that the journey is not finished, and we should take care of the children. Let us pay a tribute to our parents. And the number of nations are amazing. They mature relatively late. Up from 45. But there is a high heterogeneity of this population, and we cannot exactly know why. We know since 25 years that a woman's own birth weight and gestational age could relate a risk of metabolic retraction use of we have not to forget these things, especially with baby girls. So, what about the babies? Issues or risk of malformations of the babies or consumption? But children from mothers who are sleeping or behaving suffer from long-term effects of purity and lower weight. Children born too small should probably result in balancing. And thank you for your attention. I would like to suggest also like a history of paper 95 that shows in some cases and poses questions on today. And with these, I will try to answer questions. And thank you for
Thank you, Dr. Piccoli, for the excellent talk. Can you hear me? Dr. Piccoli, can you hear us from our end? So, looks like there's some issue with the connectivity. Dr. Piccoli is
Yes,
not.
ma'am. I think she's not able to.
Yeah, she is not able to hear us.
But she's able to see the video. We are
Yeah.
just checking it in a minute.
Yeah. Okay, let me know if she is able to come back. So basically, the point I wanted to emphasize is the trio of reduced kidney function, proteinuria, and hypertension is actually a big problem. So if you have one less, probably the outcomes are going to be better. Just because somebody has a kidney disease with a GFR of 45 does not mean that the risk is going to be high. The risk actually keeps on increasing when the other two accompaniments, that's hypertension and proteinuria, keeps on getting added. So probably someone with a tubulointerstitial disease with a GFR of 45 and someone with a glomerular disease with a GFR of 45, probably they are going to behave in completely different ways. And especially glomerular diseases, IgA nephropathy and lupus, as long as it's not remission, is going to be one of the biggest nightmares for the nephrologist, because this diseases probably kind of behave a little bit unpredictable, especially in scenarios like this. The patient was completely outside the loop and the patient has not had any control of hypertension or proteinuria, and landing in mid-trimester definitely is going to be a problem. And as Dr. Piccoli correctly said, there is no one-size-fits in a pregnancy and kidney disease, and each patient's options, treatment option decisions has to be individualized. So can she hear us?
We are trying to join with a Zoom link. We'll just see.
Yeah. Okay, just let us know. We'll wait for another 2-3 minutes, and if that doesn't work, we will wind up.
So as an obstetrician, I would like to bring out certain discussions. In this patient, we had a biopsy diagnosis. we may come across patients who do not have a biopsy diagnosis and we find them with edema, proteinuria and creatinine is high and may or may not have hypertension. So I want to know what are the trigger points for hemodialysis and what are the trigger points for empirical steroid or other treatment?
Of course, actually, somebody presenting with the proteinuria and pregnant, an unplanned pregnancy definitely is not an obstetrician or a nephrologist would like to deal with. So, and the problem is even the diagnosis of a nephrotic syndrome becomes problematic in the latter months of pregnancy because albumin is going to fall as a part of pregnancy, and proteinuria without a baseline proteinuria, interpretation of the proteinuria also becomes very difficult. So the usual approach we follow is we will try to get a serology, we will try to get a biopsy diagnosis possible because someone coming in the second trimester, probably that is going to be the early second trimester is going to be the safest time for a for a biopsy. So as far as possible we'll try to do biopsy provided the patient agrees to that, and if that is not possible, then again it's going to be in a gray zone. A positive PLA2R antibody is going to be of help. If it is positive, it's likely to be membranous nephropathy, and we'll get the antinuclear antibodies and complements. But again, all these things have fallacies. For example, in a lupus, even with an active lupus, the complements can be normal because generally pregnancy is going to elevate the complement levels. So a normal complement level does not rule out lupus. So if there is a serological diagnosis, we will treat accordingly. But when the serological diagnosis is not there, and if there is a strong index of suspicion of a nephrotic syndrome, then the possible, we don't really have much options as of maybe a trial of steroids. Probably towards the end of pregnancy, adding steroids is going to be a little bit of a problem. Sometimes you'll see that the edema paradoxically increases, and we will have to treat the complications of steroid therapy. And if there is a really strong suspicion of a nephrotic syndrome, the only way left out, I would say it's in a very, very blind zone. The only way left out probably would be add steroids and a calcineurin inhibitor and plan for a kidney biopsy. And if the creatinine is rising, probably we will have to be a little bit aggressive with immunosuppression, and it has to be decided on a case-to-case basis. And maybe if the creat is rising and probably the patient is requiring dialysis and all, maybe the best strategy is to consider all the risks and still go ahead with the kidney biopsy. It's going to be a very difficult choice in that scenario.
Of more things, since we are the ones who are in touch with the patient, patients are admitted with us in the wards, we are the ones who are looking at the investigations more often. So can you give some more direction towards how much rise of creatinine over how much time should I kind of get think that hemodialysis has to be triggered? One. Second, if you have a patient who is a known CKD, biopsy proven or not, but her creatinine and proteinuria, creatinine is stable, proteinuria is increasing, but hypertension is not getting controlled in spite of 3-4-5 treatment, what would be the next step for them? Would a salvage dialysis or any other immunosuppressant help in those cases? Because these are the routine dilemmas that we face when we have a patient with a known CKD, biopsy proven or otherwise.
Yeah, so let me take the situation one, a patient who is having CKD, but patient is not yet on dialysis, coming with a pregnancy. So most of the time, depending on the GFR, let us say the patient is having a very low glomerular filtration rate, the fetal growth is very likely to be compromised, and probably there is a chance that maternal, because of the urea, elevated maternal urea levels, there might be osmotic diuresis from the fetus, and maternal polyhydramnios might be there. So most of the time, see, there are no hard and fast rules when to initiate dialysis on a patient who is pregnant and who is not yet on dialysis. And obviously, polyhydramnios is going to be an absolute indication to start dialysis, but nobody would like to push the patient till that point when the patient develops polyhydramnios. So it's an overall assessment, overall condition of the patient, how the baby is. So for example, we are detecting growth retardation pretty early in the course, and if the patient has issues with volume control, hypertension control, then probably irrespective of the GFR, maybe even when the GFR is somewhere around 15 or 20, we usually would start on dialysis. And the second question was proteinuria, increasing proteinuria and hypertension.
Increasing hypertension, not getting controlled.
Okay.
creatinine being stable?
So what we need to keep in mind is all the maternal physiological changes happens in patients with kidney disease. So the maternal blood volumes are going to be maximum somewhere at the end of around 28 to 30 weeks. So that is a time when actually we will... That's a time when we will have a difficult time in controlling blood pressure. The problem is distinguishing it from preeclampsia becomes extremely difficult. So again, actually, there is no hard and fast test that will tell you that this is going to be preeclampsia or this is going to be the physiological accelerated hypertension. That can happen around 28 weeks, and probably a decreasing biophysical profile and a uterine artery Doppler which is showing absent diastolic flow. Probably we will be more tuned towards diagnosing preeclampsia, and appropriate obstetric decisions will be taken. And probably if everything is going on fine and still it's just blood pressure control and increasing proteinuria, in the absence of any other danger signals, probably an expectant line of management can be considered. But again, we need to keep in mind that at any point preeclampsia and eclampsia can develop in this patient. So it's not going to be an easy diagnosis. There is no single test that will tell you whether this is preeclampsia or not. It's the overall picture and the direction in which the patient and the fetal well-being goes that probably will help us to take the decision. Any questions from the audience?
I think she connected via Zoom, but I think there is some technical glitch.
Still she is not audible.
I'll ask her to talk. I think
you can actually ask her to add anything if she wants. Yes, sure, sir.
I'm a great fan of Dr. Piccoli. In the sense, I've been very ardently following all her commentaries and original articles and so on. I don't know how many of you will, I hope all of you will agree with me if I say that she has brought in a kind of a paradigm change in the concept of the entirety of the gamut of pregnancy and the kidney diseases, including kidney transplant. Lot of optimism, and positivity she has been successfully infusing into the scenario. As a group, we, the physicians and nephrologists, have been very nihilistic about pregnancy, even in CKD as well as kidney transplant and so on. And I used the word paradigm change in the concept, in the sense that, we are so much into evidence-based medicine, but here, this subject is one area where we have to move little away from evidence-based medicine. You have to go by the individual case-based discussion. That's what Dr. Priyabhata also was trying to explain in all her responses to the queries made. Evidence-based medicine applies very good in all other areas, but not here. Each person has to be perceived and analyzed on so many factors. And here, pregnancy is one area where that's what Dr. Piccoli has been mentioning again and again and again. It is not just purely a medical issue. It's not just a scientific and technical issue. There is a lot of the humanitarian considerations and ethical issues, and she applies the principle of bioethics here. In my presentation, I am going to use one of her slides, how the role of bioethics, the autonomy, the right of the mother-to-be to get pregnant or not to get pregnant, all those factors have to be factored in. It is not, she stresses again and again that it's not purely a scientific phenomenon beyond that. Thank you so much.
Thank you, sir. I think still the issue is not sorted out. Dr. Shabri?
Ma'am, just a minute. If it is, she's not able to hear, then I think we'll wind up the session.
Yeah, we can wind up this.
I had a patient referred from the assisted reproductive unit at 8 weeks of gestation, twin pregnancy, mild CKD noted, otherwise no hypertension or proteinuria. When the concern was discussed with the gynecology obstetrician, Madam said we will go for the reduction of pregnancy. it was fascinating and little bit disconcerting that we can put 2-3 embryos and we can take some of them back. So my question to madam is, this reduction, till how many weeks we can do it? You do it like you intention just aspirate it, or do you, what are the physiological consequences for this procedure?
So, generally the fetal reduction is advocated in pregnancies which are triplets or above, to reduce them to twins or singleton. The decision of reducing the twins to singleton is taken in situations where we know that twin pregnancy will worsen the situation, like CKD possibly. Yes, it is done. It can be done. It can be done up to generally 14th or 16th week, preferably done in the first trimester, because the effect of that also depends on the type of twinning. If you have a dichorionic, life is possibly easy, and any reduction in the first trimester works in favor of the other fetus. Doing it later than that could affect the other fetus as well. So it is usually done by injecting KCl into the heart of the fetus. That is the best method of doing it. The approach, of course, goes depending on whether you go transvaginal or abdominal, transabdominal. So those options are available. So yes, they are attempted in, especially in situations where, you know, for example, a woman has already had a preterm birth and you don't want her to carry a twins after an assisted reproduction. You might offer them that. But one needs to keep in mind that there could be a risk of an abortion of the other fetus as well. In monochorionic, it's not a good option because that would precipitate problems in the live fetus that remains behind.
So, if there are...
She is asking any questions from our end. I think she'll be able to speak to us. So we can type and send the questions and we'll be able to...
I think actually we give her a big thanks for being available. But I think actually it's a little too late and we can wind up. The bottom line is having a child is an exclusive choice of a woman. She is online. Okay, but she still... Dr. Piccoli, can you hear us? Okay. So she still can't hear us. So once again, thank her. So having a child is a woman's choice, and we have to respect the choices. And rather than discouraging the patient to have pregnancy, we should act as tools to help the patient in having the most successful outcome for the pregnancy. So thank you, Dr. Piccoli, once again for being with us. Thank you. Thank you all.
Thank you, ma'am. I request Dr. K. Kumar, HOD Nephrology, GH Pondicherry, to kindly present mementos as a token of regard to our chairpersons. Sir, please.
Moving forward to another interesting session, this will be on dialysis in pregnancy. Our chairpersons would be Dr. Karthikeyan B, consultant nephrologist at Kaveri Hospital, Chennai, Dr. Kapil Navin Sechpal, assistant professor of nephrology at Jawaharlal Nehru Medical College, Wardha, and Dr. Shravan Kumar Jogu, consultant nephrologist at Medicover Hospital, Warangal, Telangana.
We request the speaker for the session, Dr. Satish Balan, Senior Consultant Nephrologist at KIMS, Thiruvananthapuram, Kerala. He is a Jipmer alumnus and an acclaimed clinician and teacher. His areas of interest include transplant, genetics, and clinical nephrology. We request sir to start the session. Thank you.
So, good morning to all. I think we had a very nice session on CKD, setting the stage, next level of CKD, which we are going to see, that is patients who require dialysis and who are pregnant. So, again, as in CKD, the evidence base for this is very thin. So, we have to wade around the evidence and see what we can gather out of it. So, can we load my slides? think we are given a case initially, and that's about yes, it's not there here on my. Yeah. Case of a, I think, third gravida lady who had previous one live birth, one abortion, and has come to the unit with pregnancy. I think it was 12th week, and during that time she had a creatinine of around 4 milligram, and but about 18th week she went up to creatinine of 6.5, urea of 78, and she was initiated on dialysis at that stage. And till 30th week she was going on, and 35th week she developed uncontrolled hypertension, and after that she had to be taken for an elective CS and delivered. Postpartum, they tried to keep her off dialysis for some time, but she continued to be uremic fluid. So that's the base from which this case from which this presentation starts. Is it coming?
Which one's that? This one?
Yeah, that's one. Yeah. Okay. So the case is up there. It's not up there. Yeah, case is up there now. So you get just to, we said at 35 weeks they had uncontrolled hypertension, underwent elective CS, and after this, what happened was that she was restarted on dialysis, and she could not be maintained on conservative management. So what happens is that 10 years back, just over 10 years back, the patient CKD is creatinine 4, just like Dr. Gopalakrishnan was saying, if she had come to me and asked, can I become pregnant? I said, no, you cannot. It's too dangerous for you and the child. There's no question of pregnancy for the creatinine of 4. That would have been, but times have changed. So now the answer would be it depends. And it depends on a lot of factors. So what are the factors depends on? So first of all, you have to understand what are the complications that can occur in the mother and the child. Some of this has already been mentioned, but I'll go through it again just for us to revise what we are going to go through during this presentation. So first thing is the kidney function can worsen, proteinuria can occur, and you can go in for an end-stage first point. So as far as maternal problems are concerned, the underlying disease can flare up, especially lupus, IgA nephropathy, everything can flare up, and this can be a problem. And managing the disease itself can be a problem during pregnancy and may require termination at any time. Hypertension can occur and occurs more commonly at later stages, and they can go in for preeclampsia, eclampsia, and all that. And of course, need for dialysis, which is going to happen in the near future. These are the patients who are going to have, because they already have advanced CKD. The immunosuppression which you are giving, they can have problems due to themselves, infections and other things. So related issues to immunosuppression also have to be handled. And finally, many of these pregnancies do not progress to term. Term pregnancies are quite unusual unless there are certain conditions which are satisfied, which will come to. So all these factors are to be considered when the patient is going forward with pregnancy, and this is what the patient has to be counseled for. And there are fetal issues. The fetal issues are decreased fetal growth and IUGR and SGA babies, because they, again, even if they progress to term, it will be IUGR and small for gestational age babies. Preterm deliveries are extremely common in this group, and a high chance of intrauterine death. And if it's early trimester, then even early trimester abortions if the patient has come early. So all these things are possible, and these are what we are going to talk about to the patient. So what to do before starting dialysis? The first important thing is counseling, because without proper counseling, this is going to be a problem for both you, the mother, the parent, the family, everyone. Because finally they're going to say, we didn't know this was going to happen, etc. So proper counseling has been done. Counseling is a major endeavor, and ensure that without counseling you're not going to go forward with this. And the counseling should include, probably should be a team effort. You should have yourself, you should have the obstetrician, you should have the high-risk obstetrician. If there is a specialty in your unit of high-risk obstetrician, they should be there. The neonatologist, hopefully, and any other specialties which are involved in this management of this patient. All of them should come together and counsel in one session. That will be much better, and the patient and the bystanders, everybody, they can understand the seriousness. And who should be counseled? Ideally, the mother herself should be counseled, but In our situation, we have to counsel the entire family. It's not possible to counsel one person. Somebody else will come tomorrow and ask you, we never knew about all this, etc. So counsel the entire family, and if possible, even some other relatives who are not close by also, as far as include everybody, because everybody should know. This is going to be a village involved in this. It's not just one or two persons. Then explain about the maternal fetal complications that we have talked about. Then we have to explain about dialysis, the problems related to dialysis. You have problems with access, you have problems with bleeding, you have problems with infections, you have problems metabolic issues, volume status, everything, all about the dialysis related problems. The other issue is, what will be the problems if you don't do dialysis? That also you should explain, because they say, oh, then I don't want to do dialysis. So if you don't do dialysis, nothing is going to happen, you're not going to progress, you're not going to go forward. So dialysis, when it's essential, it is essential. There is no doubt about that. Pregnancy cannot move forward without dialysis. So pros and cons for dialysis and what can happen during dialysis has to be understood. And the need for intensive dialysis. So other things that just ordinary dialysis will not do. You have to do intensive dialysis much beyond what is being done for other patients with CKD. And you have to say that absence of renal recovery is the most likely outcome of this event. You're not going to recover. So you may need continued dialysis and you may have to plan for transplant in the future. So based on all this, you can give the option of termination. So at this point, are you going to terminate the pregnancy or are you going to continue? And the thing is that this should be a shared decision. So you cannot say, I can terminate, I'm not bothered, etc. No, it's you. If you are terminating, you can terminate. But if you are going to go ahead with the pregnancy, we are there with you to support you. That should be the attitude that we have in order to help the patient to go forward. And finally, you talk about the dietary requirements, the fluid management, because they may not be able to drink. But with intensive dialysis, you may know there is no dietary or fluid adjustment to the patient. They can take everything. So that's what we are trying to achieve today. And lastly, cost. If in the private sector, cost becomes a problem. And that has to be well understood. So after all this, you can think, once you counsel them properly, you can start dialysis. But what are the indications for dialysis in these patients? So the usual indications, what you all talk about, uremia, fluid overload, hyperkalemia, metabolic, this is all a crash dialysis. Patient comes to you in this situation, you have to start dialysis immediately. But what we would like is not this. It should be a planned dialysis procedure. So you have special indications for pregnancy. You should counsel patients when the bun goes to about 40. So sometimes some of the patients may not be nourished enough. A bun of 40 may not be achievable in these patients. So even a creatinine of about 3 or 3.5, or that's the time when you start counseling the patient that dialysis may be required. And once the bun goes to 50, you should start dialysis for these patients. So generally in nephrology, we do not have one particular target bun or creatinine at which we start dialysis. In pregnancy, we do. We have a bun of 50. It is time to start dialysis for these patients. The second thing is, if fetal growth is considered inappropriate, it may be an indication for dialysis per se. But again, this usually happens when things are already far gone. So usually by the time the bun has already gone beyond the extreme or the creatinine has gone above 4, and this situation when you start dialysis. So that requires, what type of dialysis will you do to these patients? So you have peritoneal dialysis and hemodialysis. In theory, both are the same. Patients have been done, have continued pregnancy, peritoneal dialysis, they have delivered, they have had good outcomes with peritoneal dialysis. So there is no difference as far as peritoneal dialysis and hemodialysis are concerned. Practically, it's not the same. So you can, patients who are on PD, if they are already on PD, then you can continue on PD. And if you look at the studies, there are only very few studies of patients on dialysis and on peritoneal dialysis as such. So you can see that these are two studies, two groups of patients. These are all the collected patients from 1983 to about 2018. And there are only about 36 patients who are either on CAPD or APD and have gone to conclusion. And you can see that most of them delivered preterm, but just preterm, not very big preterm, 34-35 weeks. Live births were 19/27 here, and in APD almost all of them delivered. But you had significant complications. You had hemoperitonitis, you had peritonitis, infective peritonitis, you had pain, and one patient, the catheter displacement, and they had to be taken for HD. But you had 16 patients in PD was initiated during HD. All of them are on CAPD. The PD was started about 10 to 29 weeks in these patients. And you see the dwell volumes are about 1.5 liters. And live births were very good. Actually, 14 of 16 underwent live births. And the thing I would like to say that the weight in these patients at delivery is 1.6 kgs. But in this group of patients, probably because they started on PD towards the later stage of pregnancy, they had reasonably good birth weight, 1.9 kgs. Again, complications were there, peritonitis, exit site infection in these patients. So how will you decide what are the pros and cons of peritoneal dialysis? So your pros are the better metabolic control because it's a continuous procedure. You have a better hemodynamic stability. Definitely that's an advantage for PD. Autonomy is better. They can go around, they can move around. We'll come to a little bit that the next slide. no anticoagulation, and preservation of residual renal function. So these are all advantages of PD which you have even in pregnancy. But the cons, infection risk is more, and we have already seen that in this small group of patients you had significant incidence of peritonitis. And non-infectious complication like hemoperitoneum is much more because the uterus will move around and interfere with the activity of the PD catheter. And catheter displacement, only one patient actually. If you look at all this, almost 50 patients here, only one of the patients had a catheter displacement. More IUGR and increased exchanges. So exchanges have to be much more. So autonomy in PD is already a query because this is a slide which I copied from Dr. Chaco Jacob when he was talking about PD about 20 years ago. And how can you have autonomy when this type of travel is like this and you want to do PD in a situation like this? And this is an electric train, remember. So that's a problem when you're talking about PD and autonomy. It's not actually that good. And in fact, hemodialysis may also offer adequate autonomy. But I have my own biases in that. So you have to take that into mind. So in pregnancy, what is the PD prescription? So first thing is that frequent clinic visits, at least once in 2 weeks. And you check the transporter status at the start of pregnancy. That is not going to determine what type of PD you are going to give, but that is going to help you make changes later. You check the residual renal function frequently, that at least once a month you check the residual renal function. You increase exchanges and maintain the fill volume. Early in pregnancy, same fill volume, you just increase the number of exchanges. You are doing 3, you do 4 or 5. Low glucose dialysate, so you don't want 2.5 or 4.25, just keep a 1.5% dextrose and try to maintain volume with that. You don't want too much of volume, so they will keep little bit of volume restriction. Keep bun below 50. KT/V is not validated in pregnancy, keep a bun below 50, that's enough. And in third trimester, you may have to reduce fill volumes. So that may be the thing, and you may have to switch to HD. In fact, in the studies which I have quoted, many of the patients had additional HD at the time of the last trimester. So HD may be coming to the picture here. So then we talk about hemodialysis. So that's about PD, what you can do with PD. But hemodialysis, the pros are less dietary restriction, less water restriction. Why I'm saying this? Because we are going to intensive PD for this patient, HD for these patients. Only fixed hours on dialysis, other times you are free. So you have adequate autonomy in HD also. And there is no abdominal filling, so you can feel comfortable, or much better. Imagine you already have a big abdomen because of pregnancy itself, and now adding to that another 2 liters of PD fluid or 1.5 liters PD fluid is not very comfortable. Nephrologists like HD better, so it's good for your doctor also. And the cons are worse metabolic control with this because it's an intermittent procedure. Again, that part is taken care of because it is much more intensive procedure doing. More hemodynamic instability that still holds for HD, whatever you are doing. Anticoagulation requirement is still there. Lower autonomy, I will contest that. But the need for venous access, absolutely, that's a problem in these patients. And what about the prescription? You have to change your hemodialysis prescription. So the first thing is higher dialysis dosing. So what is recommended is a minimum of 24 hours of dialysis per week. That means at least 4 hours a day, 6 days a week. And that will be minimum 4, maximum 6. And if you look at the best outcomes that this one of these authors here, this Hardinwich has the maximum number of good at full-term deliveries, babies more than 2 kgs in weight, no SGA, etc. And those outcomes are with 40 hours per week. That's a huge amount of dialysis, nocturnal dialysis daily for at least 6 days a week. And the target bun is less than 50. You can adjust your dose. So if you're doing 4 hours a day for 6 days a week and you're getting less than 50, that's fine. Keep that dose. Minimum heparin or no anticoagulation, that will be ideal, but you can use heparin. Heparin doesn't cross the placental barrier, but you want to avoid use of heparin as far as possible to prevent bleeding complications in the mother. And ideally, you try a SLED type of dialysis, low efficiency dialyzer, QB of about 250, QD of around 500, not really SLED, but towards the SLED spectrum of dialysis, if I would like to say that. And the recommendation use biocompatible membrane, but I don't think you're using non-biocompatible membranes nowadays at all. So that is really doesn't come into the picture. And use minimum ultrafiltration. When you're using daily dialysis, you don't need to do much ultrafiltration. That will help. But you have to increase your dry weight every week by about 300 to 500 grams. Note the weight of the patient, note the fluid status. You're very careful with the dry weight adjustments. You don't want them to be over-dialyzed and that filtered. And wherever possible, home hemodialysis is the ideal approach because you can achieve very good targets with home hemodialysis. Further, what will be dialysate sodium? You keep a dialysate sodium in the higher range, about 140. And you keep a higher potassium also, 3 or 4, 3.5 K or something. If you have, you can use that. You have to avoid hypokalemia. Again, you have to avoid hypocalcemia and hypercalcemia. So you keep a dialysate calcium about 1.5, magnesium about 0.5. Then bicarbonate also we keep lower because these people develop alkalosis because you're doing so much of intensive dialysis. So bicarbonate 25, that should be ideal. Not 28 to 32 as we're doing in our standard dialysis. And the blood pressure, avoid hypertension. The best thing is to keep your ultrafiltration to very low limits as far as possible. And target BP is 120 to 140 by 70 to 90. So that should be the range you keep the BP in these patients. And you avoid phosphate binders. Most of these patients will need phosphate supplementation because of your intensive dialysis schedule. So you don't need phosphate binders. But if you are using, don't use sevelamer, lanthanum. These things are not, they don't have any evidence in pregnancy whether it's safe or not. And you can use calcium containing phosphate binders if you want. But again, as far as possible, you don't need, most of the times you don't need them anyway. Keep a hemoglobin of 10 to 11, you dose your ESA. Usually you need a 50% increase in ESA levels, and you can use IV iron as far as possible. Obstetricians are already using IV iron in large quantities anyway. Then you monitor your BUN, creatinine, electrolytes, calcium, phosphorus, magnesium, hemoglobin every week. It's very essential to keep these monitored and keep them in a good range. You don't want any of these electrolytes to be too abnormal where you're going. And when you're doing dialysis, you should look at the other aspects. You should supplement vitamins, especially folate and B vitamins. Protein intake should be high in these patients, 1.8 gram per kilogram. They may need additional protein for the fetus in addition to this 1.8 gram per of. Then the body weight is calculated as a pre-pregnancy body weight, not the current body weight. And lastly, the nutrition is 35 kilocalories per day plus 300 extra kilocalories which you need calculating for the fetal needs. So that's a thing. But with all these things, what are the outcomes? So this is a study which was published from Mexico, a real life study, and they did, you can see that their average hours of dialysis per week was 14, and this was a study published in 2019 after Lodinist data published in 2014, and still they could do only this much. The number of patients about 30, and you can see that only 30% of them had miscarriages. Only 27, only about 30 out of 40 reached delivery stage, and most of them are preterm deliveries. Term deliveries, only one patient had term delivery. One of them preterm, early preterm was 19, extreme preterm was 5. So you can see the outcomes were not at all good, it was not very bad. But you can see the number of hours of dialysis was only 14 per week. And the author said, and the newborn birth weights were about 1.5 to 1. Maximum was 1.9 kgs. The thing is that even though these patients started on dialysis in almost the third trimester, they did not have good outcomes. That's because the dose of dialysis, they said they had an overstretched hemodialysis program. They could not do anything more than this. Maximum three dialysis per week, that's what they could do. And with that, the outcomes are very bad. But, so if you look at the outcomes, how does it work? So if you have, these are the tertiles of based on the hours of dialysis. If you're 0 to 20, only about 48% live births. If it is about 21 to 36, about 75% live births. And if it is more than 40, it's about 85% live births. So you can see that almost reaches normalcy. And this is another way of putting it, the same diagram. So the number of hours increases, the outcomes automatically start improving. So it all depends on how much dialysis you are doing. And this is a meta-analysis of multiple studies which I have done. Now this does not show the same thing. But again, each of the studies is highly heterogeneous. Luder's study was published in 2010, and there was about 52 patients, and you can see that outcomes are not very great in that. But their maximum, even though the hours of this thing were stratified in this, the maximum hours were only 24 in that. So it is not really a great study in that case. Whereas if you use this Hoardinage studies, then you can see that that is out here. Outcomes are much better in this, and when they were using 40 hours of dialysis. Again, you can see this is a comparison. I want you to see these two things here, and you can see the same Hoardinage study. This one is the Canadian cohort, and this one is the US cohort in the same study. Cohort had 18 hours of dialysis, and this had 40 hours of dialysis, and you can see the outcomes are far better. The amount of preterm was only about 0.4 in this, whereas almost all of them were preterm in the other study. So it makes a lot of difference in the number of hours. And this is a further representation of that. You can see that as the hours go, the proportion of SGA babies drastically comes down. So these are each one is one individual study, each circle in this diagram. Same diagram here also. And 40 is an absolute outlier. So your SGA babies come down to very low levels. So I think you have enough evidence to say that if you increase the number of hours of dialysis, you get very good outcomes in pregnancy. And to increase means you have to go to about 40 hours and keep a BUN below 50. That should be the target that you're trying to achieve. Apart from that, what obstetric care can you give these patients? You should screen for cervical incompetence and planned circulation, because it's very common in dialysis patients, and therefore by about 6 weeks or so you should start screening for that. You need a comprehensive anatomy scan at 18-20 weeks to look for anomalies, and probably should be repeating that a little bit later, because anomalies are also more common in this population. You need a weekly ultrasound after 26 weeks to assess the amniotic fluid, fetal parameters and fetal weight. So that should be every week. And placental ultrasound to look for length, thickness, insertion, and an umbilical Doppler at least once in 2 weeks after 22 weeks to qualify, because you cannot rely on other parameters. You cannot rely on renal function, proteinuria to find preeclampsia on these patients. So to diagnose preeclampsia, you may have to look at the placental parameters. You cannot even use an SFLT, PIGL, PLGF ratio, because this has not been validated in patients with this degree of renal function. So we do not know whether it is correct or not. And if you are giving magnesium sulfate, you have to give lower doses and monitor the magnesium levels and make sure that you don't get hypermagnesiemia on these patients. And plan a neonatal consultation early. Finally, what about neurodialysis modalities? High flux dialysis, I could not find any data on high flux dialysis. In fact, the recommendation use low flux anyway. So I don't think we should be using high flux in these patients. But online HDF, this has been tried. So in a few women at the SRD, there are one studies from Brazil, this Cruciligüe, and another study from Italy, I think, and they had successful outcomes. And lastly, there was a study with citrate dialysis, and what they did was they used citrate base, bicarbonate fluid, and the base is not acetated citrate. And this they use, and they found that they could reduce their anticoagulation requirements when you're using citrate as the acid in these patients. So again, you can see citrate when you're using it becomes more complex. What happens here, what happens in online HDF, citrate will help anticoagulation. You can use apparent free dialysis for these patients. But it's also converted bicarb. It's not completely apparent free. It is not that magic, because the amount of citrate used is much less. You're not using citrate as the alkali here. You're using citrate instead of the acid in the acetate, in the acid concentrate. And bicarbonate is used in the bicarb as such. So you may develop alkalosis because citrate gets further metabolized into alkali. And lastly, you may need monitoring of calcium, because when you're giving citrate, calcium can come down. Again, hypocalcemia can occur more frequently in these patients. You have to monitor for hypocalcemia in these patients. You also have to monitor for hypercalcemia, because you may be giving calcium in these patients. And both hypo and hyper can cause bone disease in neonates, so you should be very careful about that. Magnesium concentration used was 0.5, and magnesium was monitored in these patients. So if you are using a citrate, it becomes more complex. But again, complexity is what you have to get used to. So in course of time, we'll get used to it and probably will be able to use it much better. So finally, let's come back to our case. This case of 12th week of pregnancy had a creatinine of 5 milligram, 18th week was initiated on hemodialysis, and 35 weeks had to undergo elective CS. And even postpartum. So what could have been done? So this was a hypertension and preterm delivery. So what we could have done is a much more intensive dialysis schedule. This would have been taxing for the mother, for the staff, and if you have a unit which is already overwhelmed with dialysis, you will have problems in putting a 40-hour dialysis schedule for these patients. So that's a problem with these things. Then regular monitoring of umbilical Doppler and IUGR to assess for preeclampsia, because you could have diagnosed preeclampsia a little bit earlier. How that will help is a problem, because you may have to make planning. You can plan better, that's all. Careful monitoring ultrafiltration. One of the most important reasons for hypertension may not be preeclampsia. It may just be that patient is not ultrafiltered properly, and maybe there's a residual volume left behind. But still, the outcome was good for the fetus, and in course of time, mother will have to undergo transplants. So finally, to conclude, these are what we gain out of this presentation. With CKD in pregnancy, dialysis should be initiated on numbers. So BUN more than 50. We do not wait for uremia or symptoms of uremia to start dialysis unless the patient is crash landing on us. Then you have to intensive dialysis 24 to 36 hours a week, at least 5 to 6 days a week. I would prefer 6 days a week for these patients, and daily dialysis practically. If that type of dialysis, hemodialysis schedule, outcomes are more than 80% term deliveries with birth weight near 2 kilograms if this is followed, and that is excellent. Dialysis prescription should be tailored to meet the requirements of each individual patient, so you must be able to do that on a weekly basis for each patient. Nutrition, as I've already said earlier, obstetric monitoring should be optimized and should be much more carefully followed up. And newer modalities of dialysis such as online HDF appear to be promising in these patients. Thank you all.
Thank you, sir, for such a nice, wonderful talk on this topic, which is more challenging and complex scenario. I would say it is easy to manage a renal transplant with a pregnancy rather than patient who is on dialysis with pregnancy, because we have to manage the volume overload, hypertension part, as well as the electrolytes and acidosis management, alkalosis management, and all these things in patient with CKD and pregnancy. So another thing is, what I have one question. So like, what is about the risk of mortality in these kind of patients? Like,
yeah, maternal mortality is actually quite low. In most of the studies, at least the mother is taken care of, because if you are following the patient carefully, then you can avoid maternal mortality. Once in a while you do have, but it is extremely low, I'll say. We are more bothered about
studies on that, sir? Like,
no, there are these data which are there, almost no maternal mortality in any of these studies which have been published. We have seen, but in our own situation, we may have seen one or two cases.
We have seen some patients having.
But generally, that's because it's not planned. So these are all very planned, especially the Hodenish data and all are extremely planned pregnancies, and they are followed up very carefully throughout. In that case, I don't think you should be expecting maternal mortality. But those patients who crash land and then you start dialysis immediately, and that is going to be a problem there. And many of them do not follow what you are going to say. That's the other problem. You tell them to come for weekly, daily dialysis, they will not be coming. They will come again with pulmonary edema, and that is going to be a problem.
Yes, sir. Especially in our setting, doing dialysis 5 days per week is a very challenging task, I say. Like most of the patients, even sometimes they will do only twice weekly dialysis, even if you advise thrice weekly dialysis. So in that condition, we have to have a better counseling to the patients, and then we have to take it forward, I think. And about the vascular access, again, it may increase the chances of pulmonary edema, volume overload, cardiac dysfunction, all these things. So, what would you advise, sir, for vascular access?
I didn't speak of vascular access. So many of them you may have to initiate dialysis during pregnancy. So it will be usually a venous access that you are trying to reach. Venous access is perfectly good for dialysis in pregnancy. You put a perm cath and you can use that for dialysis. Some patients have created fistula during dialysis, and that have been there. But I have not had any personal experience there. But the studies have quoted that they have done fistulas in patients without many problems they have done. But I think they will be more comfortable with a catheter rather than a fistula.
Sir, thank you for the presentation. One question is, what is the role of newer anemia drugs like desidustat in pregnancy with dialysis? So, is there any validity or approval?
I think desidustat, in fact, there is no long-term data even in other patients. So, in pregnancy, definitely, I don't think we should be using that.
And one more is whether it is urea or bun, sir, which we should target for 50.
This is bun. Urea means will be double that, approximately 100.
Sir, one doubt, most of these patients who we initiate dialysis, they recover the renal function after pregnancy. They tend to become ESRD.
Yeah.
So what, according to you, are the pathophysiological causes for this non-recovery of renal function, and what can be done to avoid this?
See, the problem here is that many of these patients have underlying renal disease. They already have CKD to begin with. It may be some glomerular disease, maybe something else. Some of them may just have shrunken kidneys. So we don't know. So the chance that these people will recover is highly unlikely. I think if you say about 5% or 10% may regain renal function, some degree of renal function will get off dialysis. But the second point is that even if their baseline creatinine is only 4 or 5, pregnancy will probably finish off the renal reserve. So at the end of dialysis, they will not be able to recover renal function. So chance that they will recover, I will say, is only about 5% or 10%. Most of them will continue to require dialysis. So you will have to have a postpartum plan for them, whether they are going to continue on dialysis and when you are going to plan transplant, etc.
Any questions from the audience?
Satish, that was a very good presentation. I have one, I don't know whether comment. See, you spoke about magnesium sulfate. Luckily, these patients should not be requiring magnesium sulfate because they are being monitored very closely. But yes, sometimes in spite of antihypertensives, the BP may go up, we give prophylaxis. So even if it is, because they are on dialysis, we can safely give the first dose of magnesium sulfate, and now lower doses are available. That's what we are practicing in Jipmer. And many times we see that with one dose itself, they don't require further doses because of absence of knee jerk or something like that. So they should not go back with the idea that with CKD, we should not give magnesium sulfate at all. We have to prevent eclampsia. That is something very important.
Yeah, absolutely agree. Magnesium can be given, only you have to use lower doses. And like you said, with even one dose of magnesium, we find that they achieve a target of 5.5 or 5 or something like that, and then you don't have to give any further doses. Yes. Can't hear. Anish.
So with pregnancy now with hemodialysis is possible for those patients who are not considered, as like sir was telling earlier. But do we have data of those patients where the hemodialysis was done during pregnancy and long-term follow-up of how many patients actually survive for long? Now we are helping the mother to achieve the dream of having a baby, and if it is going to be with the results that the baby is going to lose the mother after some time, are we doing the right thing? So do we have any data regarding that?
Yeah, I think it's a very important point. So that's why I said the initial counseling, we have to talk about the postpartum issues. What are you going to do in the postpartum? Because delivering a baby and without a mother is going to be a disaster. You don't want to do that at all. Baby needs a mother. That's absolute thing. So you should have a long-term plan in place for this patient. Possibly you should have a transplant plan or a long-term dialysis plan in this patient. That is absolutely essential. And that should be planned out right at the beginning. So if it's a planned procedure, everything is discussed in the first counseling session itself.
I think if there is any option of transplant, the patient has to undergo the transplant first and then probably can.
She's pregnant now, no? So I don't think that will be the right time for the transplant. If it is possible, if there is a problem with transplant, we should do the transplant and have the pregnancy later. That will be ideal. So, yeah, and the age of the patient also. So, suppose already.
Thank you for the wonderful presentation. Do Indian data on pregnancy and dialysis patients, one, and two, because we presume that only 1/3 to 50% of the patients we start dialysis actually survive the next year. That is even from the free dialysis. Yeah, it may be different in some very good centers, and in very bad centers it may be even hopeless. So generally, if you take 30 to 50% will see the first year. So do we have any data on
I couldn't get any data, Indian data. Only anecdotes of what I have done one patient, and that patient survived to preterm delivery, and subsequently underwent transplant after that. Only one case. Other dialysis you do in pregnancy are all mostly AKI, recovering, all that. No? So, but CKD going to it is, I don't have much data on that. You have?
Yeah, we have around, I think, 12 patients or so, ESRD, who were on dialysis, remain on dialysis till delivery. And I think there is only one patient who had aborted during in the second trimester or so. Otherwise, but the patients were kept admitted in the nephrology ward or the obstetrics ward. They were getting dialysis 5 days a week and all. But largely they were not problematic. Of course, small for gestational age baby was there. They delivered earlier. But I was also surprised that the 12 of them went really well. But there were some patients who we faced this issue because they had problem getting dialysis after delivery. There were instances where they went home and the mother stopped dialysis and ended up in the casualty. All those things has happened. But then surprisingly, the pregnancy was largely, most of them required supplementation of phosphorus and potassium and all those things. But it went well. So looks like if it is planned and if the patient is able to afford and we are able to offer good amount of dialysis, monitoring is possible. Obstetrics was doing, I think, almost every 4 weeks a Doppler of the placental this thing and all those things were being done. If you do that, I think a good number will be successful. That's what I think.
Yeah, to add to that, I think Dr. Jodish from Ikra Hospital in Calicut, he presented in our nephrology Kerala meet 3 patients who had ESRD on dialysis, underwent pregnancy, and he dialyzed him in the intensive fashion, 40 hours a week, and he had the term deliveries in them. So, but like I said, the long-term follow-up after that, like Dr. Anish said, we don't know what's going to happen to them.
the access only.
Access.
There they have only good accesses are kept. Here we try to maintain all AV fistulas, even with flows of 500, 300. Whereas in Canada only good accesses are maintained, otherwise they are on tunnel catheters. So when we are doing that 6 dialysis a week here, the biggest problem is they definitely finish off the access. Technician makes sure the access is going
That is there.
So we had a patient in AIMS and we had to use a tunnel line. This was even before that. We had to use multiple temporary access to get her through the limits. So it is otherwise very easily doable except the access issue.
Access has always been the Achilles heel of dialysis.
If there are no other questions, we'll close the session. Thank you.
Thank you, Dr. Satish, for the wonderful session. We request the chairpersons to present the memento to the speaker. We request Professor Gopalakrishnan sir to present the memento to the chairpersons.
So now we'll announce the winners of the poster session. I request Professor Edwin Fernando, Dr. Abhiram Krishnan, Dr. Srijit Parameshwaran, and Dr. Priyamada ma'am to come on to the dais. So there are almost 15 posters which has been kept on the left side of the hall. So two residents, the Dr. Prasanna Babu from Stanley Medical College. He has presented a rare glomerular disease in pregnancy, that is fibrillary GN in pregnancy.
No, the posters were excellent. I learned a lot from the postgraduates today. But there is a way of presenting, and whatever you have done it over a period of time. You have the clarity. That clarity has to be conveyed. The papers were good, and the prize winner is mainly because of the way they communicate, and they actually, at least they made it clear to me. So all of you are winners, but they have been specifically selected because of the communication rather than the rarity of the case.
So the next poster which got selected for the award is Dr. Sunil Kumar Behra. He has presented an interesting case of diffuse cortical necrosis, Think Beyond Help syndrome from AIMS, Raipur. Thank you, sir.
A short tea break now. The tea is being served in the adjoining room.
the presentation pen drive, just have it in your laptop. Ma'am, presentation. Madam is not the ma'am, in the same way. you know the same thing will be there because the topic is very narrow. And if you want actually listeners to listen again and again, at least they get sense of this. At least they know there is a great history of
Yeah. Or you want to take on a center stage?
I think this stage will be visible.
Yeah, nobody's there.
Fine. I saw you like you will be reading in the library. I still remember.
My last time was 1 year senior to you.
No, ma'am, I 14 to 17. 14 I entered.
Joined.
14 I joined.
Vijay, you are there from 14 to 17?
Dishant was my age.
No, no.
I passed out.
Yeah, sir. Just share the photo.
I request all participants, delegates and faculty to please collect their participation certificates from the registration desk. I repeat, I request all the delegates to kindly collect their certificates of participation from the registration desk. Thank you.
Hello. Welcome back, everybody. The topic for the next session is on genetics and complement, unveiling the geneticist's role in suspected complement-mediated AHUS. Our chairpersons are Dr. Abhirami Krishnan, consultant nephrologist at Kaveri Hospital, Salem, Dr. Satish Balan, senior consultant nephrologist at KIMS, Kerala, and Dr. Karthikeyan M, assistant professor of nephrology at Jipmer.
We now introduce our esteemed speaker, Dr. Anup Rahul, Senior Clinical Geneticist and Associate Director at MedGenome Labs, Bangalore. Sir has completed DM Medical Genetics from SGPGI Lucknow with expertise in genetic lab techniques and prenatal and antenatal genetic services. He has several peer-reviewed research papers to his credit. Sir, please.
Thank you for the kind introduction. First of all, heartfelt thanks to Dr. Sabrina, the HOD sir, and the organizing committee for giving this wonderful opportunity. So Dr. Sabri asked me to justify this complement-mediated AHUS role of geneticist and genetic testing. So I think it's a challenge. 30 minutes is, let's see if I'm able to justify. So before I start, I just want to ask a open question to the entire house. Like on a scale of 10, how many of you are comfortable prescribing a genetic test, interpreting the reports? So all those who think they rate themselves above 5 can please raise their hand. Yeah, good, quite a good number. So that's real nice. So nothing to worry. There's a similar study I'll be just sharing. So disclosure, conflicts of interest. I'm a freelancer, basically private practitioner based in Pune. I have my own genetic center and I'm attached to MedGenome, and I'm doing reporting for MedGenome, the prenatal segment. The Sanger sequencing and the MLPA is all prenatal. I'm doing reporting for MedGenome. So this was a study I was quoting, all nephrologists from Australia. So 85% of them felt, okay, genetic testing is useful, but when it came to confidence in prescribing and administering and facilitating those tests, it came down to 23%, and they preferred a multidisciplinary renal genetic clinic, almost 57%. So nice concept coming up. So that was in 21 in Australia. And these were the various reasons that they quoted. Didn't know which test was appropriate. Genetic testing process was confusing. Test did not seem useful. Genetic test was not available, and so on. I think the scenario here is pretty similar. Genetics as a curriculum has not been imbibed medical curriculum. I have myself gone through that transition. After doing MD medicine, when you go on to do DM genetics, it's like after 12th you go for MBBS. That's a totally separate specialty. And these were the challenging aspects in patient management. What, according to the scoring, the nephrologist in Australia, they prioritized. Selecting the test, that was the biggest challenge. Then interpreting, identifying which patients to test, follow-up genetic counseling, discussing results, and so on. So today I'll just walk through the basics of genetics. My focus will be on TMA, particularly AHS, what tests to do, how to interpret, and a case to discuss. So when you talk of genomics, it is basically everything about the genome. We know this is a unidirectional flow of information, the central dogma of genetics, genome to proteome through metabolome, and it influences the phenotype. And in due course, there are certain factors like environmental influences and so on, which also govern the phenotype. So this is unidirectional flow. So entire genome is in the nucleus, 23 pairs of chromosome, supercoiled structure. So basically you pull out the thread from that chromosome, that's the DNA. So each of us have 2 pairs of DNA, one set of DNA coming from father, one set of DNA coming from mother. So one DNA is divided into 23 chromosomes. So just to simplify, when you are looking or interrogating the genome, at what all levels the genomic abnormalities could be. So this is important because there is no single test in genomics which will pick up all the abnormalities. Based upon the underlying molecular abnormality, you have to pick up the test. Otherwise, you end up ordering a test which is not going to pick up the abnormality that is actually there, and you end up getting frustrated, having a false negative report. So suppose you have a library in your study, day in and day out you are looking at that library. Just by looking at those books you can make out, okay, one book is missing. You know book number 5 is double the volume of book number 10. So this is like you're looking at the chromosomes. So just by looking at it, you identify, okay, is there an increase in number? Is there some change, major change that has happened? And the limit here is the optical resolution. So anything submicroscopic beyond that resolution will not be appreciated. So that is like size of 5 to 10 MB. So if you talk of genome, one DNA is like 3.3 GB data and the functional part is like 40 to 45 MB. So in that, anything submicroscopic less than 5 to 10 MB we cannot appreciate on microscopy. So karyotype has that limit. So next, let us look at each book in detail. Here we go through the pages, we go through the content, and we just make sure, okay, is the binding correct? Are the pages arranged properly, or are there any pages missing? Or some pages have come in from some different book and, you know, reshuffling has been there. So this is, I'm doing a mid-resolution examination of this library, and I'm looking at each book, but at a certain depth, not beyond that. I have not gone to reading it. I'm just looking at the page numbers and seeing the index and seeing that all books are okay. So these mid-resolution tests are nothing but tests like microarray, where you can interrogate the entire genome for copy number variations, deletions, duplications. Or if you want to look at a focused segment, then you can do FISH test or basically PCR based test and so on. And third, you read through the entire text. So this is like you look for abnormalities at the level of single alphabet, single word, single sentence, or entire paragraph or entire chapter, deleted, duplicated, reshuffling. So these are the kind of abnormalities. Now here I am reading through the text. That means I am looking at each nucleotide base pair in the DNA. So abnormalities could be from a single base pair to the entire gene, entire region of that chromosome, or entire chromosome, deleted, duplicated, rearrangement, whatever. So this I am looking at the DNA sequence. So this is the technology I am using here is next generation sequencing. So from left to right, it is low resolution, mid resolution, and high resolution. Now this doesn't complete the genomic abnormalities, the spectrum of it. There is something else. Now when you are reading, what else does matter? The punctuations, your exclamatory signs, your commas. So this is epigenetics. All those epigenetic marks on the DNA are also important for specific loci, specific genes. They have to be looked at by separate techniques. So you could end up like you have done all the tests, still the reports are negative, you are suspecting something clinically, but this is not the technology that you should have used. You should have used something to look at the methylations or epigenetic phenomena. So depending upon what abnormality it is, we have to choose the test so that it is able to pick up the abnormality that is there, and it's a spectrum. So from left to right, if you have to look at the chromosome numbers, aneuploidies, or gross structural rearrangements, karyotype, anything submicroscopic across the genome, cytogenetic microarray. If you have to look at specific genes or specific loci in those genes, I'll do either a NGS, that is a pan-genome test, I'll do a NGS, or focused if I have to look at, I'll do MLPA. And single nucleotide variant, something like I want to look at, say, abnormality for a sickle cell disease. In that case, I'll be doing a PCR based test or a Sanger based test. So this is a spectrum. These are the various tests from karyotype, FISH, PCR, triplet prime PCR, MLPAs, microarrays, Sanger, and NGS. So the beauty is appreciating the clinical diagnosis, the clinical information, whatever test other than genetic tests that have been done, synthesizing that data. What is the provisional diagnosis? Okay, then we link it. What could be the underlying molecular abnormality that is there, and what exact test or technique I need to use to find that abnormality. So in genomics, it's not about just the patient or what we call as the index case. It's about diagnosis, and at the same time we are using this information for benefit of the family. So the point here is we diagnose the patient, help in the management of that patient. It's a teamwork with that particular specialty. Here I'm talking with respect to nephrology. If anything that is found could increase the risk of having subsequent children with the same disease, then offering prenatal diagnosis or pre-implantation genetic testing if they are opting for IVF, and cutting down that risk in the next generation. So it's completing the circle for that family. So today the focus is on the TMAs. So basically, pardon me, I'm not a nephrologist, though I've done MD medicine. I'll be just concentrating on the genetic aspects and the tests for the discussion purpose. So based on the differentials that we draw for the TMAs, either it could be thrombocytopenia or Shiga toxin related HUS, or secondary TMAs that has been listed on the left, or it could be classical HUS which has a genetic predisposition to it. So if I have to rule it out, there are other means, other tests which I use. Sometimes there is a phenotype overlap and it becomes difficult. Particularly when I am talking of a TMA which where there is an underlying ADAMTS13 related abnormality, and at the same time the patient could have CFH related molecular abnormality. So there could be a phenotype overlap. So these could be the situations where confusion arises. So for TMA it is clear. It could be either due to underlying molecular abnormality in ADMTS13 gene or formation of antibodies that are there that can be tested for. If there is an abnormal serum homocysteine and there is a suspicion for cobalamin deficiency related HUS, then we can straight away go for gene which is responsible for this cobalamin deficiency, the gene which synthesizes that enzyme. Since the gene is large, it cannot be done on Sanger, it has to be done on NGS. So to combine this, if differentials have to be looked at together, we can do this by doing an NGS test which will rule out both the ADMTS13 and cobalamin deficiency for me. But if I have to look at AHS, now here comes the issue, because the underlying abnormalities for certain set of genes, it is the deletions, duplications or gene conversions that happen, and for rest of it, it is a single nucleotide variants which can be picked up by NGS. So not going through the definitions, the inheritance pattern here becomes important, because if you are having a patient with AHUS, there is a family history. In that situation, based on what pattern of inheritance is there in the family, we can delineate, okay, what gene I am dealing with. And once I am able to identify that particular gene, I know what test to go for, because certain genes it will be CNVs, for rest it will be SNVs, so the test will differ. So like here, predisposition for AHUS, so for these particular genes, C3, CD46, CFB, CFH and so on, these are typically inherited in autosomal dominant manner. Now there is something known as reduced penetrance. Now this terminology is important because this pathogenic or disease causing variant may be passed on from generation to generation, but the history of AHUS may not be there in the older person or related person, either the parents or grandparents. So that means the person may have the variant but may not have manifested with those clinical features. And for DJKE related, it is typically inherited in autosomal recessive manner. And again for CFHR1, R4, R4, these are the deletions. Again, the pathogenicity arises when both abnormal variants are inherited from either of the parents in the affected index. So these are the triggers that lead to HUS. Just rushing through. When it comes to genetic testing in HUS, about 22 genes have been listed. These are the common ones which I have listed here, and testing for them is primarily indicated as per recommendations. somewhere in microbiology or second year MBBS we have read about it. So in PCR basically you have primer probes which tie to a focused region of the DNA and amplifies that region of DNA with every cycle. So MLPA draws its principle from the PCR, but here the difference is you have two probes which are fitting exactly to each other on the target region, and then there is a step where these two ends of the probes get ligated, and this only happens when there is an exact match with the DNA, targeted DNA of interest. And once this ligation happens, after that the amplification of the probes happen, not the DNA. So even if there is a single nucleotide variation or any deletion duplications, this MLPA probes will not amplify. If there is a deletion, it will not amplify. If there is a duplication, you will get more number of probes. So this ratio becomes important. So this is how we look at the MLPA report. These are the ratio charts. You have the name of the genes and coordinates given on the axis. So normally the ratio should be at 1. If anything above it, anything above 1.5 shows that there is a heterozygous duplication. Anything that gives a ratio of 2, that means there is a homozygous duplication. Any ratio which comes to 0.5, between 0.5 to 0.7, it shows that there is a heterozygous deletion. Here it is a normal MLPA report where all the ratio for all the probes is at 1. So a word about next generation technology. So basically you extract the DNA from the patient, you fragment it by various methods, then you have a step of library preparation where you amplify and then you put it for sequencing. So this all is the wet lab part, and next is the dry lab part, which is equally important and more sophisticated, where you look at those reads that have been obtained, you align it to reference genome, and then you start looking for the variations. So this is a tedious task. It's like finding a needle in a haystack. So if you're looking at a whole genome report, so as I mentioned earlier, human genome, the size is 3.3 GB data. So if you're looking at whole genome, the data that is generated for whole genome is like 90 GB to 120, 125 GB. And in that you're looking for 1 bit or few bits of abnormalities. If you're looking at whole exome, the same data is like between 9 to 12 GB. So that is the complexity of analysis. And then there are various steps. Once you have the data, you put various filters like population frequency, whether it has been reported in any databases, general population database or disease specific database, or are there any publications or any functional studies that have been carried out. So various parameters, based on those you try to zero in on few variants that are of interest, and that's how the report is generated. And once you have those variants, you put them through this matrix. This is the ACMG matrix where we have various attributes. So based on various parameters that have been listed on the column in the column on left, like population data, computational and predictive data, functional data, segregation, so on, you try to figure out, okay, where does this attribute lie for that particular variant. So based on various attributes, we just do the scoring, and once you have done the scoring, then we classify which what is the classification, is it pathogenic or likely pathogenic. So if it lies in these two categories, that means it is definitely disease causing. Challenges arise when it is classified as uncertain significance. So that may be limitation because as of now it may be a novel variant for which data is not available, or there could be conflicting evidence that is there. So once you have variant of uncertain significance, in that situation further delineation for that variant may be required. And if it is reported as benign or likely benign, that means definitely this is not associated with the disease, and usually these are not included in the report. So in bioinformatics analysis, these are the various steps which go into identifying the variant. The most important is for these variants, the accreditation of lab, how much large the database is there, or any other databases to which the lab has access. That becomes very important because most of the variants have, as evidence shows, they have a propensity of being found in various geographical pockets or population databases. So this is a spectrum that we saw, we are only interested in those variants which lie in pathogenic and likely pathogenic classification. If there is a VOUS, always good to speak to the lab, get a data reanalysis done, and if possible a medical genetic consultation to see if anything else can be done further. So for HUS, so if we have ruled out ADAMTS and cobalamin related, and if based on further testing, if you are able to identify, okay, we have got a report which says it is pathogenic, well and good. If it is VOUS, then the most definitive way to dissect a variant of uncertain significance is go ahead for a functional study. So that is a limitation as of now, but there are labs which are coming up, so or even research projects can be taken up if you have a recurring VOUS in specific genes. And in the end, we combine all this data to identify whether the variant can be reclassified, is it of interest or not. So based on the reports, these genes and variants have also big relevance in correlations of the phenotype. So for example, for C3, variable onset presenting both in childhood, adulthood, and more than 60% affected individuals will develop ESRD, and so on, like CD46, mild acute episodes, complete remission, little effect on long-term outcome, and 60 to 70% remain dialysis free. So on, for each gene there are certain catch points which are important, which help in prognostication and disease management. Penetrance, for most of them it is around 50 to 60%. Of note, for DGKE gene, it is like complete penetrance. Like if you have the pathogenic variant, the person will manifest. So it's 100%. A red flag, particularly for those relatives who could be potential donors for kidney. Only those who do not have familial AHS related pathogenic variants need to be evaluated further. The point here is, otherwise, a healthy individual who has not manifested till now, if a live related renal transplantation for such individuals is done, this should be avoided, as the disease onset can be precipitated in these healthy individuals. So just to share one of the reports so that you have a feel like how it goes once you order a test. So this lady, 43 years old, presented with high grade fever, erythematous rash over limbs, pedal edema, dyspnea, and was treated as rickettsial fever. But once her laboratory workup was done, it revealed leukocytosis, thrombocytopenia, hemoglobin of 9.8, CORP-C of 22.7, platelet of 82,000. Urea was on the higher side, LDH was elevated, C received 3 cycles of plasmapheresis. This is when the treating hematologist, he suspected HUS and ordered a test that was clinical exome. So please remember, next generation sequencing tests as these as of now have limitations because they might not be able to pick deletions or duplications. Here, though this is an NGS based test, if you look at the table below, it shows that there is a micro duplication. Now this is the advantage because MedGenome has the bioinformatics pipeline which has evolved over years and they are able to pick up these micro duplications. But having said that, this is not the gold standard method to look for CNVs, one, and the accuracy for detecting CNVs for these pipeline in MedGenome is up to 85 to 90%. So that is a limitation. So once this was found, here you see the disease is reported, associated condition is reported, the zygosity is heterozygous, and inheritance, like for this disease, inheritance could be either autosomal dominant or recessive, but the classification which shows in red is uncertain significance, particularly because this is not a platform to report. So for the same patient, we did MLPA test, and here we got a more accurate report where for this particular loci, CFHR3 and CFHR1, the underlying exons and intronic region has been noted. The ratio that was obtained was between 1.64 to 2.4. So like at some, so overall there is a homozygous duplication or gene conversion that has happened, and this was the pathogenic variant which was underlying leading to predisposition for HUS. So again, as mentioned earlier, genetic characterization in these individuals also has potential to optimize the treatment, whether to go ahead with plasma therapy and so on. Again, in prevention, when giving eculizumab prophylaxis, either for primary manifestations or secondary complications. The same information can be utilized. And also evaluation of relatives at risk. So sometimes for most of the clinical specialists, it is about treating, managing the index case or the patient. But when it comes to genomics, the scope goes far beyond the individual. It is about the family. So here, if an index case is diagnosed, we have the molecular abnormality, we try to identify are there any other relatives at risk who need to be put on surveillance or put on monitoring, and in those cases if testing is indicated and should we do the test. But we should remember, like particularly in AHS, if we identify the variant in specific which is family specific pathogenic variant, it is only a risk susceptibility or risk predisposing factor, because there are many other parameters which again influence the onset of HUS. It is not causative. So eventually all it summarizes to is this is the concept that is coming up. So just some time back I was speaking with Dr. Jitu. The concept of having a multidisciplinary clinical setup where genetics is one of the component, and we have a team which takes care of such individuals. So now such types of clinics have come up for oncology, like oncogenetics clinic, cardiogenetics clinic, and even renal genetics clinic is being set up. So we have a lot of scope to improve upon in this area. So with this, I'll be happy to answer any questions. Thank you.
Thank you, sir. You didn't go from 12th standard to MBBS. I think you went from 5th standard to MBBS. Thank you. I do order a lot of genetic tests, but I'm not confident in interpreting them. So before I open it to the audience. So to conclude, if I think it is complement-mediated thrombotic microangiopathy, MLPA would be the first choice.
Yes, ma'am.
And if required, NGS.
Yes.
Am I right?
Absolutely,
Okay.
absolutely.
Okay. The point is, when you said once you get the report of variable significance and then you go through it. So the problem is when I ask for an MLPA or an HUS panel, it is not going to give me any results of variable significance.
MLPA will, yes, if you're ordering a MLPA test, the report will be either there's a finding or it's a normal negative report.
Correct.
Only in NGS,
Yeah.
VOS will be thrown up in NGS reports.
Yeah. So when I order an MLPA and then it comes out negative, I cannot stop at that point because
Right.
I'm very sure it's complement mediated
Yes.
thrombotic microangiopathy.
Subsequent.
And there is usually, even in adults, most of the times there is an associated genetic problem. So then I order the test again, it becomes expensive. So why don't I order the clinical exome or whole exome right away first? Second question, when you do the clinical exome, whole exome, and then you give this variable significance, and then there are nephrologists who are now practicing nephrology genetics, and then we consult them. They take that output and then put it back into some databases and are able to come up with more definition. So why are the primary labs not doing that?
Yes.
Because most of these databases are, we have to pay for it. So as a lab, you can pay for it rather than I pay for it to look at one or two reports.
Yes. Very, very pertinent questions, I think. So ma'am, coming to the first part, I think when we are doing a test, based upon like most of the genes, it is like SNVs which is predominant. If cost is not an issue, better to order MLPA and NGS together. Otherwise, HUS, you go for MLPA first. Anything else you're suspecting, go for NGS based panel first. Otherwise, combine it. So that's the dictum. Second part is once you get a VOUS from the lab. So ma'am, with due respect, there are a lot many labs which are floated. You ask for the accreditation of the lab. You ask which person is doing the reporting, and you ask how much database you have. Yeah, so that is there. So this is one. And third, most of the labs, they don't have in-house databases, so that's a big limitation. So there are private databases for which you can get a paid access, but unfortunately there is not much representation of Indian population in those databases. Now IndiGenome is coming up, maybe it will be available in some few months or few years. So we are looking up to that. So that might solve this issue. So that is a second problem. And third is most of the labs, once they are doing reporting, there is a standard, American College of Pathology has, if CAP, I'm talking of CAP accredited labs, they have given outset the protocols which need to be followed when you are doing a reporting for a NGS based or a Sanger based test. So if the lab is CAP accredited, all this gets answered. Otherwise that becomes a limitation. Now coming to the most important aspect, you said that the variant is reported as VOUS, but some expert colleagues, he puts it through the databases and then he gives the interpretation. So here, ma'am, the limitation is the labs, there's always a question because there are no set criteria which absolutely tell that it should be pathogenic or likely pathogenic. It's a scoring, and that scoring, if it is borderline, then it becomes very difficult. So then labs have to be very cautious. So if you even see the MedGenome report, when they are giving a VOUS, bottom below the table, they are giving suggestions or recommendations. So they are asking for parental testing, for testing of the siblings, additional affected or unaffected members to see the segregation of that variant in the family. So this can help us reclassify. That is one way of doing it. And second way of doing it is functional studies. And again, at times what happens, there are disease specific databases. Now that's a big challenge because those databases are not open databases. And in those, the rarer variants of common genes are usually present and information is available. What all labs we are looking at is the CleanVar. The limitation in CleanVar is whatever was reported say 10 years or 15 years back, now we are started to understand and identify that they were benign. So for most variants, now the recent report says benign, but reported 15 years back it says pathogenic. We know now it is benign by the present this thing. Ideally, if I am doing the reporting, I will not include that. But in some labs, there are non-medical people who are involved, or they have the bioinformatics algorithm which is not updated. It will pick up the conflicting evidence and it will categorize it as VOUS and it will be reported. So these are some of the limitations. I think you pointed it out rightly. We are still, to get mature enough to reach that stage, ma'am. Thank you.
Thank you. It was a very interesting lecture. I really enjoyed your presentation about how to do an MLPA and how to do a NGS, exome sequencing, all that. So I just have one problem with this CFHR1, CFHR3 mutations. Now this is very common in the population. So I find a lot of conditions where CKD presenting minimal C3 depression, all that they come up with the CFHR1, CFHR3 duplication, deletion. And it is reported sometimes as pathogenic, sometimes as uncertain significance. So personally, I don't find a correlation between this and disease in any patient. So far, I've seen a lot of patients I've seen, and none of them it correlates with disease. And many patients have transplanted and does not recur in them. So that's one of the things. The transplant should make it recur. Almost, I think, transplant is one of the places where it will definitely recur, but it doesn't recur. So I don't know whether it has got significance. And when I look at the database of patients who are diagnosed with HUS, all of them talk only about CFH. So when they have said there's a patient with HUS and CFHR3, that doesn't exist in the databases. Right. So major trials have not included CFHR1, CFHR3. CFHR5 is different, but CFHR1, 3, all that. So I don't know what will be, except in the context of an anti-CFH antibody. Now there, this has got significance. When there is an antibody, this genetic things make sense. 80% of those CFH antibodies have a genetic abnormality. Usually it's a CFHR1, CFHR3 or CFHR4 duplication or deletion in that situation. So that is one problem I have.
So that's the reporting molecular pathologist nightmare actually, because there is so much of polymorphism that has been reported. So many recombinations and gene conversions have been reported. So there was one slide where I tried to show the specific homologous regions for all those genes, and there is lot of overlap. So a lot of recombinations happen. So the reason is when these variants have been clearly catalogued in databases as disease causing, and they are matching when we do the analysis and we get the exact same variant, then it becomes easier, and that happens less often. So that's a challenge. So I think
I have some last two questions, sir.
Yes.
From a basic question. Suppose I'm suspecting a pregnant patient who delivered and she had AKI and she gone for cortical necrosis. Her complement levels were low. I'm ordering a genetic test like whole exome sequencing with MLPA, and the test report is negative. There is no VUS. How far I'm sure that no genetics is involved in that patient? That is number one. Number two, you told if you give the report of variant of uncertain significance, you told two things probably from your talk I can get. One is to do a functional study, and you mentioned in the beginning of your slides there is some role of epigenetics. Probably epigenetics we cannot pick up with your routine just whole exome sequencing, what modification that either demethylation or histone modification. Those things, if it has happened in probably in CFHR1 or 3, if there are epigenetic mutations in that, will it be a pathogenic one? What we are seeing it as now as likely pathogenic. So that is my second thing.
Very interesting question. So I'll answer the second question first, because I have not come across any methylation, acetylation or other.
What actually, frankly to speak, how
Yes.
lab is reporting, how they are classifying it as VUS, because now I can see there are some scoring systems you are saying,
Yes.
and probably some of your other, not by doctors, probably someone else will be scoring it. So how far we are reliable for that? And I'm just asking how to go out with functional testing and
Yes.
how to test for this epigenetics.
The problem with the complement disorders is functional testing is also not available.
Yes.
The phenotype is also not very classical.
Yes.
You can have various phenotypic manifestation. So we are very dependent on genetics in this particular group of patients, and we get a lot of VUS.
So Dr. Sabri, I have not come across any epigenetic phenomena being reported. I need to update myself, but I am not aware, because there are specific loci in the genome where imprinting, parental disomy will be presenting as a clinical abnormality phenotype.
Many a times if we check for the donors, they will be harboring the same mutation, and probably whether epigenetics has played a role in the patient which exaggerated that condition. That is what I just, probably a new thing which I have learned from your talk.
Yeah, so epigenetics is relevant, but for some other cases. For this, I need to check, because I have not come across. I'll reserve that statement and I'll cross check, because things get updated very, in days and weeks. So I always have to keep my, statement reserved. So I'll cross check on that. And coming to
that,
the,
I think at this point of time, Mendelian disorder has to be a genetic abnormality. We cannot say it's an epigenetic phenomenon. Maybe it may change, like you said, it may change in the next 10 years. But at this point on, it is the concept. I think we don't find a genetic abnormality. Only two reasons. One, it is not genetic disease. Second, our genetic tests have not picked it up so far.
now coming to the first part of the question, where you had a lady, you did all the tests and it was negative. So that could be limitation of the technology. There could be still other abnormalities. Most importantly are structural rearrangements. So that means the breakpoint is going through important gene, where you have half of one gene and half of another gene, and you have a hybrid protein that is being formed and it doesn't have any significant function. But once you do sequencing, only because of that breakpoint, it will not alter the report that you're getting, because genome is 100%, the sequencing is happening, it will not be able to detect that. So there are specific other tests which you need to do, long read sequencing, or specific you have to do linkage analysis targeting that breakpoints to identify that abnormality, only if the suspicion is high. The one statement
that is why we are ordering the test.
Yeah. So abnormality may still be there, but that could be the limitation of the technology. And one thing I mentioned was large deletions could have been there. But again, as I went through literature, for these genes, large deletions have not been shown to cause the phenotype. So that was something even like there have been no reports with large deletions in these genes being causative. So even I was like, I'm trying to understand why so.
Questions from PGs? PGs, any question?
Thank you, sir, for the talk. Mine is more of a technical question. When it comes to TMA particularly, time is an important constraint. So have you been able to reduce the turnaround time of these sequencing to less than 2 weeks? Because somewhere I had read that the minimum that you can do it is around 2 weeks.
Yeah.
But typically we wait for a month. And sometimes I agree that TMA, the initial treatment is almost similar, but then if we have the report earlier, it would definitely make a difference, at least in the future. So what's your comments on that, the technical aspects?
Yeah, thanks for bringing this up. So here we are talking of sequencing maybe ADAMTS13 and related differential those genes, and we are talking of turnaround time of 2 weeks. So just maybe 3-4 genes and 2 weeks. So I'll just give you one perspective. NICU, 18 sick babies, NGS was done, and I'm not talking of whole exome, I'm talking of whole genome with reporting. But that was a research setting. That happened in Stanford, 22 Jan. The fastest sequencing done with reporting was 4.5 hours. And all of those cases below 24 hours, a report was given in 18 out of those 24 or 25 cases. So that's where technology has gone. But that was Oxford nanopore based sequencing. Now that technology has bit of limitation in terms of accuracy. Right now it is not into diagnostics. So that was done in research and it was validated by other tests. Yes, coming back to a question, we can bring down the TAT, that should not be an issue, but the problem arises is the volumes. For doing for a few samples, the sequencing and entire thing, for lab it may not be cost effective, so that there are challenges like this which need to be addressed. And yes, maybe the more conversation we have with the lab, I think these issues can be addressed, or we can go for alternate techniques where we can bring down the TAT and cost as well.
Rapid turnaround, if we know a particular defect, it's more easier to do it in such situations, or even in the other broader context it can be done, like more of a clinical exome which is coming down these days. We are switching to a whole exome, but then if we are suggesting a few particular genes, is it better in such situations?
We need to look at ADMTS13 and are there recurring hotspots where the abnormality is happening. If we know that, we can design primer probes. Maybe if it is amenable to Sanger sequencing, we can give those reports maybe in 4 to 5 days. So we can bring it down, but provided these criteria is met. If you're looking at something unknown, then you have to do sequencing. Even for that can be brought down, but I think that's more between the lab, basically the wet lab. Bioinformatics we can push it, but the wet lab it requires time. So yeah, I think there's a lot of scope of improvement there. Yeah.
Just to add to that, suppose you're doing a complement panel, say 22 genes for that, and you do only exome sequence for the 22 genes. Will that change the time between a whole exome versus just this 22 gene sequencing? Will it be the same time?
Same time, because the entire pipeline for doing NGS is same. And basically what happens, labs, if it is an NGS sample, we are doing multiplexing. So multiplexing, you're pulling in samples. The moment your sample, the chip is full, you just run it. So it's about volumes. So if you have, or if you have targeted loci that you want to look at, maybe we can try microarray. But again, we'll have to go through those genes, and is there any specific Indian abnormality, molecular abnormality that is showing up recurrently? Can we improvise and provide an Indian panel? So those things. So this is the avenue of research. I think we can think about this.
I just want to highlight one more thing, is that the output depends upon the input. So unless you give proper clinical details and extensive clinical details, their output will not be good also.
So thanks for putting the cherry on the cake.
Thank you so much, Dr. Anup, for that insightful session. I request our chairpersons to kindly present a memento as a token of our gratitude to the speaker. I request Dr. Shabrina.
Moving forward to our next session on renal transplant in end-stage kidney disease patient with pregnancy, associated complement mediated HOS. Our chairpersons are Dr. Anand Chellappan, Assistant Professor at AIIMS Nagpur, Dr. Rajiva Lochana, Consultant Nephrologist at MMM Chennai, Dr. Tanuj Moses, Assistant Professor of Nephrology at SRM Medical College, Chennai. We request them to occupy the dais.
The speaker for the session is Dr. Raja Ramachandran, Associate Professor of Nephrology at PGI Chandigarh. Sir completed his DM Nephrology from the same institute. He has to his credit multiple extramural funded projects and numerous research publications. His areas of interest include glomerular disease and kidney transplant. Over to you, sir.
Thank you. I start. Good afternoon, ladies and gentlemen. I heard many of the questions that were being asked, so I think I will be addressing a few of them. And at the outset, I would like to thank Dr. Srijit, Dr. Shabri, and Team Jipmer for inviting me and asking me to present on this topic. So, I have no conflict of interest to declare, but, I'm not a basic scientist. Superadded, I understand it less. I primarily work on primary glomerular disease, and complement is my newfound interest. So I am in the process of developing a complement lab. So I've done a lot of mistakes. I will share many of them so that you don't repeat the same. So this was a history that I was being provided. A 27-year-old lady, postpartum day 2, developed acute kidney injury, which she also had systemic microangiopathic hemolytic anemia, diagnosed as a case of genetic complement-related thrombotic microangiopathy. This is a new classification by the National Kidney Foundation where you call CTMA. C means complement-mediated TMA. You put a G before them, genetic complement-mediated TMA. If you put N, it's a non-genetic complement-mediated TMA. The patient, underwent hemodialysis and plasma exchange, but then was found to have renal cortical necrosis and was declared end-stage kidney disease. She did undergo a genetic testing which showed abnormalities in the complement factor H gene and ADAM-TS gene. So, ADAM-TS, TTP, traditionally, the TMA is driven by the hematologist. That is why every time you listen, you should do an ADAM-TS 13, because it's the British Hematology Association which came up with this. With respect to thrombotic thrombocytopenic purpura, it's not that it is uncommon in adults. It can happen, but when it happens, it's generally less severe with respect to the kidney involvement, and what you call as Upshaw-Schulman syndrome. It's rarely presents with severe acute kidney injury. So with this, with the cortical necrosis, the patient didn't improve and was proceeding for a transplant with husband as the prospective donor. With this, the following were the questions. So, are you happy with the testing or you want to do functional testing? 1, what is the role of non-eculizumab therapies, that is plasma exchange, plasma infusion? 3rd, will you go for a deceased or a living donor? The 4th question is, what is the evidence with eculizumab and revilizumab with its cousin? Then how do you manage if you have a post-transplant TMA for the first time? Again, complement mediated, I'm not talking about a traditional ones. See, any presentation on TMA starts with alternate pathway complement cascade, but I think it's the melatonin for any presentation on complement, because once you put that, everybody goes to sleep. So if you look at the complement factor H gene, which is the most important one, it has a 20 short consensus repeat. Each short consensus repeat has about 55 to 60 amino acid. The one towards your left is the amino terminal end, and the one towards your right is the carboxy terminal end. So it's a carboxy terminal end which binds to the surface. So any defects in the carboxy terminal end, you generally have thrombotic microangiopathy. Any defect in the amino terminal end, you have C3 glomerulopathy. That's a simplistic version. You can have rare exceptions. So what actually happens is complement factor H, C3 is a highly unstable molecule. It undergoes spontaneous hydrolysis and forms C3b, which then forms C3 convertase. So what factor H does is it binds to C3b and prevents any further action. And factor I also helps in this. It prevents C3 and C5 convertase formation. So I think this is a case which is open. Anybody would take it. So we have 2 cases. One is a 22-year-old male with acute kidney injury with pain abdomen, both, hemoglobin anemia is there, C3 levels are low, C5b9 is 400, and the AH50 activity is 55%. The other case is largely similar, but blood positive, albumin was 1 plus somewhere, there was also 1 4 plus, acute kidney injury, C3 levels again borderline, 1500 is the C5b9 and 60% is the AH50 levels, and one did show genetics positive and one did not show genetic positive. Which among the two you think is a case of complement mediated HUS? Anybody? Second one. So it was not that, actually it's the first case. The second case was actually a rhabdomyolysis acute kidney injury. The first case is actually, a thrombotic microangiopathy. So its history is important, like you just said, like you garbage in, garbage out. So like you will have to have a good clinical history, so it is important. So with this I'll come to also the other aspect is the functional abnormalities. The functional abnormality we see, C3 was low largely in both the cases. The AH50 was clearly abnormal in case 1. In case 2, it was 60%, which is lower side of normal. C5b9 was exceedingly high in the second case. And what was the reason? Whenever you draw a sample for functional testing, you need to immediately store them in a freezer or on ice. So what we did was we actually didn't store them rightly. So whenever you take a sample and keep them at room temperature, it's going to break down. It's going to be at least 10 times the normal range. So everyone will have a high C5b9. So the learning lesson is history is important, and also collecting the sample for this testing is very important. So role of functional assay. So even in the best laboratories, only 60% of the patients with complement mediated TMA have genetic abnormality. So 40% are negative. So functional testing is critical and also helps in patients with genetic mediated TMA. The limitations is it is not freely available, and even if available, they are not well validated. Mark my words, validation is critical in complement space. So what are the tests? The genetic aspects, my predecessors spoke extremely well. I don't think I need to touch upon that. With respect to serological testing, you have a battery of tests, and you have newer tests like modified HAMS and also endothelial assays which are actually coming up. But for all practical purposes, the one which we can test is AH50 or alternate pathway functional assay, which are commercially available as ELISA, soluble C5b9, which is commercially available as an ELISA, anti-CFH. I know you have ELISA testing. We have also used that method of testing. I would discourage you all to use that test. That is not validated, and experts around the globe don't consider it. So I think the test that is acceptable is, you need to have in-house, which needs to be well validated, which is done by the All India Institute of Medical Science, the pediatric nephrology department. So in our case, it was a complement factor H mutation, and I would actually neglect the ADAM-TS part of it, because otherwise, it's going to be a very tortuous journey. So again, with respect to the Indian lab and the world reference with respect to the genetics, we had, when we looked into our pregnancy with cortical necrosis, we found that 85% of our patients had genetic tests, they tested positive. So we thought we made a new discovery, but then I thought we should confirm it with a world reference. So when we sent to a world reference lab, only 2 out of the 9, that is the agreement was less than 30%. So that means that, we need to be more careful in what we are doing. So if you want to make a comprehensive summary of the functional testing, I would say that whenever you draw a sample for testing, place it immediately on the ice. The tests are C5b9 and AH50. C3 I think is easily available, and we all do it. And we lost close to 100 samples because they were not immediately placed in ice. So it's a learning lesson. And where do you get an ice? You have that erythropoietin pack, right? You just take a rubber band and just you draw a sample, just place it on it and place a rubber band over it. So that's the best way. The second is ADAM-TS again is very important, and it needs to be from a very well validated lab. We did a clinical trial and we took a patient who had a creatinine of 2.5 with some seizures, and the ADAM-TS level were normal, and later we found that when we got a report from US back, it was actually a case of TTP. So again, whenever a lab tests for you, please ask them, have they validated from any international lab? Then the last part is genetics. We had an excellent talk, but I would just add that whenever you do a genetic testing, ask for rare data and just see like if they are using adequate controls. It could be very much possible that the control is having only one, so your normal will be duplication. So that's how it is. And in case of any mutations, you can ask for in silico modeling to know whether there is a protein loss. So with respect to the role of anti-CFH, that's the next question that I was being given, role of anti-CFH antibodies, how do you proceed with transplant? Most of the auto-antibodies to complement factor H in patients with TMA is towards the carboxy end. In patients with C3 glomerulopathy, it's equally divided in between the carboxy and the amino terminal end. In children, adolescent, I think it's the most common cause of thrombotic microangiopathy in India. You know, up to 80% of the patients present with dialysis requiring acute kidney injury, and up to, 1/3 of them progress to end-stage kidney disease. It is associated with homozygous deletion of CFHR1 to 3. The question that Dr. Balan was asking, if you suppose you take this room, 1/3 of us will be positive for heterozygous CFHR1 to 3. This is the data, it's not that I'm just taking a guess. This is the data which is published in PLOS 1. So heterozygous CFHR1 to 3 doesn't make any sense. Homozygous, yes, it is important, especially when you're thinking of them as a kidney donor. So the anti-CFH is precipitated by infections, most commonly respiratory tract infections and diarrhea. And in a small minority of cases, you could also have anti-CFI antibodies that we reported from the pediatric department of PGI. So the question pertinent is kidney transplant contraindicated, and is there any cutoff? Because it's an antibody, it's easily to pull a sweet spot. The third one is the nature of transplant. Will you go for a live or cadaver, and who will be the live? The fourth one is role of rituximab antibodies. There are various publications, but I think I selected this small series because it answers all the questions pertinent to this topic. One, there are 4 patients. Patient number 1 was a case of an adolescent who developed TMA, improved with plasma exchange immunosuppression, had a relapse, progressed to end-stage kidney disease. The patient was a cadaveric donor recipient. The patient had an anti-CFH titer of 505. The patient received, rituximab, a week after the surgery, 2 doses of 2 weeks after the surgery, and also received immunoglobulin 4 to 5 days after the surgery. And the patient was doing perfectly fine with normal kidney function. The second one, this is actually somebody with very low titer antibody positivity. Had a very successful transplant, although did receive rituximab and IVIG. Second one, was a lying-related transplant. The first case had a homozygous CFHR1-3 parents, so that was not taken as a live, and we went for a cadaver. The second one had a living-related, which was again CFHR3-1 deletion, but heterozygous. Had an antibody titer of about 1,500. The patient underwent, this was a live donor, so the patient underwent, some sort of desensitization protocol, received rituximab therapy, received plasma exchange, and then proceeded with transplant, doing fine with normal kidney functions. The third is a cadaver transplant who had high antibody titers, was high up in the list, was systematically desensitized. However, a day before the surgery, the patient had a titer of about 3,000. The patient underwent plasma exchange, post plasma exchange, it was about 1,000. The patient did receive rituximab, 3.5 months prior, and was again repeated about 2 to 3 weeks later. That is what the authors on personal communication told. Also received immunoglobulins. The patient was doing fine. The fourth case is actually a very low titer positivity, underwent a transplant. The patient did receive, rituximab 2 months before the surgery and doing fine. So with this, the learning lesson is anti-CF, which is not a contraindication. We do not know any specific cutoff. In the publication, they mentioned it should not be greater than 500. But when I asked on a personal level what Dr. Aditi Sinha, who is personally looking after this cohort of disease, he said that 1,000 is their sweet spot, where if it's more than 1,000, they go for some sort of desensitization. If it's less than 1,000, they proceed with transplant. Do not take live donors with homozygous CFHR1 and 3 deletion. They can develop antibodies with any stimulus. Rituximab and IVIG may be needed to deplete antibodies. The next is about the role of plasma exchange, plasma infusion, and simultaneous liver kidney transplant. There are signals to suggest that plasma exchange and plasma infusion helps. I'll show in the next slide. SLKT is curative. There is a strong, there is a strong scientific basis. You have CFH is aberrant, so you provide a new CFH. You provide the new CFH by adding a new liver. You remove the old liver or you put an auxiliary liver. I think that's up to the surgeon's competence, but it's a curative part. But only problem is whenever a patient undergoes a liver transplant surgery, there is lot of blood loss. So blood loss is a very strong stimulant for complement activation. So many of them would actually reject, the kidneys and the liver both may go away because of the complement activation. So that is why they started intensive plasma exchange. That's about continuous plasma exchange during the the surgical procedure. And then after that the survival improved from about 2/3 to about 75 to 80%. Still lower when you compare it with somebody with hyperoxaluria. So you need to do intensive plasma exchange during the surgery and immediately after the surgery. And the surgery is long. It's about an uncomplimented surgery is about 12 hours. So this is a nice report which is published from Dr. Balan's unit from Trivandrum, where the patient developed HUS and was on eculizumab therapy, but was difficult to find resources for the eculizumab therapy, and they went ahead with only liver transplant because the kidney function was reasonable. So the patient did undergo plasma exchange during the surgery, but what I learned is the patient had a lot of complications during the surgery. There was stricture and other things, and even post surgery there was rejection. That is, went through hell. But yes, it was successfully reported, but I think the patient is now no more. It's a very tricky issue, doing a liver transplant. I think with eculizumab available, I think it is not advisable to proceed with a liver transplant. So with respect to plasma exchange that I told, I will deal later. This is a study which is published from Europe, where about 21 kidney transplants, where 8 patients underwent a rigorous plasma exchange. They went 1 plasma exchange prior to transplant, 3 continuous plasma exchange every day for the first 3 days, then 3 times per week, 2 times per week, and then plasma infusion. With that, what they found was 4 patients did not require eculizumab therapy. The remaining 4, 2 of them required for TMA, 1 of them had proteinuria and probably some TMA, so they gave eculizumab. 1 had to receive eculizumab for allergy to plasma products. If you combine the survival rates, those who underwent these kind of a rigorous protocol, their survival was clearly better. It was about 7 years, 6 to 7 years, compared to vis-a-vis somebody who did not undergo this kind of a regime. And recurrence of the TMA was the most important factor that predicted, the graft loss, and a TMA relapse or not using plasma exchange was the one which resulted in a poor outcome. So you could use plasma exchange and keep eculizumab as a rescue. So I think my predecessor just briefly touched about the kind of living donors that we could take, because that is something which is important in this case that has been provided. So there are 4 scenarios in the ascending order of complication. One is scenario 1, you have like some patient like this. You have a donor who is not having any genetic abnormality, clean. Second one is the genetic abnormality. There's both of them, the donor and recipient, both of them are negative, but the recipient is suffering from TMA, complement mediated TMA. Scenario 3 is you have somebody who is having FSGS, you test them, you have some podocin or some other, just consider any mutation, but you test the donor and you find that the patient has got a complement factor H mutation. The fourth one is both of them test for the same thing. Scenario 1 is the safest, you can easily proceed with transplant. Scenario 2, where genetics of the donor and recipient both are negative, they fall in a moderate risk. Because we do not, 40% of the case, we do not know the genetic variants with complement mediated TMA. Coming to the scenario 3 is where you have a patient with unrelated to HUS, but you have a donor who carries that kind of risk mutation. I think here also it is contraindicated, because I have seen one patient which was referred to us with cortical necrosis, donor developing cortical necrosis, and it was later found that actually the donor carried the risk variant and she was donating to her husband. So it is important to know these facts. Then the fourth one is when both the donor and recipient carry the same risk phenotype, I think it's better not to go ahead with this kind of a donor. So if you go with an index case, like, leaving aside all the other part of the logistics, I think the husband donating to the wife although it is a high risk because the patient has just come out of pregnancy, sensitized to her husband, and she would have received lot of blood products as a management of HUS. But if you just take by the donor, I think this donor is an unrelated, so he's less likely to have any kind of mutation. If he tests negative, he can be a donor like scenario 1. So whether this index case that we has been provided can go for a diseased donor program. So I think it's very clear if you want to summarize everything, I'll say that in a non-eculizumab setting, we should not go for a diseased donor program. Live, you can still go with plasma in exchange with eculizumab rescue. Cadaver, you shouldn't be going. Reason why you shouldn't be going in a cadaver transplant is because the risk of complement activation is very high because of ischemic reperfusion injury, surgical stress. Infections are higher in cadaver transplant vis-a-vis donor, where the donor is highly controlled. Then the last is presence of donor-specific antibodies, where there is a large, because pregnancy plus multiple PRBC, platelet transfusions, plasma transfusions, they are likely to be sensitized. So, and again, when you go to a cadaver transplant, your objective, the objective of doing a cadaver transplant is to ration it to the most ideal recipient, unlike a living donor transplant. So, how do you risk stratify complement mediated TMA? The risk stratification, high risk is somebody who carries complement mutations or variations in complement factor H, or somebody who has got genetic rearrangements, or somebody who has got gain of function. Everything is loss of function mutations, excepting factor B and C3. They are gain of function mutations. So, 10 minutes. So, medium risk are those who do not have any mutations, or those who have detectable autoantibodies to complement factor H. Low risk are the ones who are MCP and who were historically anti-CFH positivity. The index case somewhere falls between the medium and high risk cases. So, what is the role of eculizumab in patients who are going for transplant? I think this is a study which has been commonly cited in most presentations. I think where, it is after 2002 they compared patients who received eculizumab and who did not receive eculizumab. Why 2002? It is not because of certain geographical events happened during that time. It's because in the last 22 years they believe that nothing much has happened in kidney transplant. It's largely stable, no new drugs, there will be no new additions in kidney transplant. And to cut the long story short, what they found was patients who received eculizumab did extremely well compared to those who did not. It was 81% and 33% in eculizumab and no eculizumab group. And if you go to the survival also, it is extremely clear, 90% survival beyond third year in eculizumab versus 60% in the non-eculizumab group. And recurrence was also close to 45% in patients who did not receive eculizumab. Complement factor H and variant of unknown segments were the most notorious one, which resulted in graft loss. And with no or low risk, the survival was 100%. Summary: CFH mutations and variant of unknown significance carry poor outcomes. Eculizumab clearly improves outcomes, and author's view was everybody should receive eculizumab before transplantation. So it's just like the Solaris company giving the recommendation. So it's like that. So another aspect is, can we withdraw the anti-complement factor? Because traditionally what we learn is to keep giving it lifelong, but it's not like that. People have tried to withdraw. There are at least 5 articles which have shown they have withdrawn. Largely 20 to 25% is the relapse rate. The relapse rate, most of them would have kidney dysfunction, but they are reversible with eculizumab use again. And most of them have a precipitating factor in form of infections. And relapse rate, what are the factors that predicts relapse rate? When you withdraw eculizumab in the presence of a high C5b9 or presence of complement factor H variants, these were the main 2 factors which resulted in recurrence of the disease, and most of the patients responded very well to eculizumab. But important thing is they need to be under a close follow-up. If you take our index case, that patient is having a complement factor H mutation, I think this patient needs to be on lifelong eculizumab therapy. So revolizumab is a cousin of eculizumab, where there are small minor variations in 4 amino acids. These 4 amino acids results in increased recycling. What do you mean by increased recycling? Revolizumab and the C5 binds together, it's a pH dependent release of the revolizumab happens, and it is again released back into the circulation. So the half-life increases. So instead of using every 2 weeks, you could use them every 2 months. The first doses are 0 and 15 days and every 2 months. So with respect to revolizumab, it is very good as an eculizumab withdrawal agent. Question number 2 is vis-a-vis eculizumab, how was it performed? There is no head-on comparison data, but if you compare the phase 3 data with phase 3 data of revolutimab with eculizumab, they are mirror image of the same. So, with respect to the next question that I was being asked is, what about the maintenance immunosuppression? I think with use of eculizumab or plaza infusion, I think it's largely used the triple immunosuppression with induction therapies. You can go for low dose induction, low dose TAC, because CNIs is one of those agents which can trigger TMA in these patients. So, before going to my last part, how do you manage TMA? This month we had a patient who was referred from an outside hospital to us. Patient was 22-year-old male, doing fine till day 5. Day 5 developed oligoanuria and underwent a kidney biopsy. Kidney biopsy clearly showed fibrinoid necrosis and all parts of thrombotic microangiopathy, did not have any features to suggest rejection like peritubular capillarities or C4D, did not have any CNI toxicity on the biopsy, and it was actually a recurrence. The very next day after the biopsy, the patient developed anemia, thrombocytopenia and schistocytes. We are yet to get the genetic testing and the functional assay, and was given 5 sessions of plasma exchange, but unfortunately he is bordering graft loss within 1 month of transplant. So the last slide is about managing post-transplant TMA. I think, resource surplus or in medium resource condition, you can go for eculizumab. If you have a patient who is going for transplant and needs eculizumab, you can use the national rare disease policy, where there is a national program where some of the hospitals are empaneled for eculizumab use. You can use eculizumab that way. Our hospital is one of that, and we have used it in one of the patient. Whenever there is a recurrence, you can send them to, there are at least 2 drugs that are being tested in India. One is anti-complement factor 5 inhibition, which is eculizumab-like from a different company, and other is iptacopan, which is factor B inhibitions. I think preliminary data suggests that both of them are doing well with respect to the control of the microangiopathy part. You could refer them for these centers, and or you're left with nothing but to do, once you diagnose, give post-transplant plasma exchange, give about 5 to 7 sessions of plasma exchange. Make sure that it's not only the albumin that you need to replace, you also need to replace them with FFP. So, as I said, the summary would be is, if you can encourage these centers to see, it's not that all the hospitals are going to be under the national rare disease policy, but your institutes can always make an attempt and write to the central government to say that we see so many cases and please include our center. I think they are including centers that way. Coming to the summary and conclusion part, the workup, it includes clinical, functional and genetic assay. When genetic is inconclusive, functional assay is very helpful. Functional assay is positive in all the cases. Make sure you send the samples in the right way. Second one is about complement factor H TMA. If the titers are less than 1000, you can proceed with transplant. You may require rituximab, IVIG and plasma exchange. The third one is pre-transplant care. In a limited setting, you can give plasma exchange and then go for live transplant. Cadaver transplant is a strict no without eculizumab, and in medium and high risk cases where you have genetic mutation, it's better to go with eculizumab. The management of post-transplant TMA, or what you call TTMA, it's poor prognosis. You will require a complement inhibition in these patients, because if you too much plasma exchange, that also predisposes these patients to infection and other things. So with this I will stop and I'll be happy to take questions.
Thank you, Rajesh sir. It's always a pleasure to listen to you. A lot of wisdom that we have gained from your talk. I have a set of questions. The 4 cases that you had shown of diseased, some of them were diseased transplant who had elevated titers. Were they just having anti-CFH positive, or they were a combination of genetic as well as the antibody? Because we find that in the Indian cohort, there are a group of people who have CFHR as well as the antibody positive. So more than 95% of the patients who are anti-CFH positive will have homozygous deletion of CFHR 1 and 3. So it's like that.
It's like all these patients. Like, it's synonymous. It's synonymous.
So when they are on the wait list, do you give any prophylactic rituximab to them, or how do we go?
That is, if you go to the case number 3 in that series, there where the titers was about 2000, there they are given rituximab and tried. Obviously in cadaver transplant you will not know when your number comes, but whenever you're top in the list, what they have done is they're given a shot of rituximab. The rituximab was not helpful in actually depleting the antibodies. What they did, they gave an intensive plasma exchange just before the transplant, did the titers, it was 1000, and then they proceeded with transplant with successful results.
So coming to the therapy part on eculizumab and revalizumab, what is the long-term safety like? Is revalizumab comparable to this? How are we dealing with those infections with organisms which we can see with eculizumab and revalizumab?
Yeah, so I had deliberately left that to discussion, so thanks for getting it. So with respect to using any of the complement 5 inhibitors, the primary thing is you use vaccination against Neisseria, and obviously it's an emergency use, so you can't expect to wait for 14 days for the response, and so you give antibiotics for 14 days. So, with this, most of the eculizumab and revalizumab data in the current era, the Neisseria infections are close to 0. Yes, there are, increased risk of infections. Probably they are less in the Western setup. If you use that in India, I think we'll see a new set of infection, a new crop of infections. So that is how I see it. But yes, this is what you practice.
The other thing which I would
long-term safety, so we do not know about revalizumab. With eculizumab, I think it's 10 years now, so we are reasonably sure that it's good. It's a good drug. There have been no signals, at least in the last 10 years. With respect to revalizumab, it has just come, so I think we'll have to wait for data.
Again, just a repetition of the previous session's question on functional assays that you were talking. As we know in genetic diseases, there are a lot of effect modifiers. Even the environment also plays an important role in expression of a particular gene. So can we say these functional assays are like a foolproof thing to say that somebody has this gene which is possibly implicated in a disorder? Or are we still, is there a pending grey area still? Even after the functional assays?
Yeah. So, what forced me to move into the functional assay is, the genetics was highly aberrant. We had problems. So that was the reason because functional assays like to yield you the exact. So if C5b9 is elevated in the face of a thrombotic microangiopathy picture, you can reasonably be sure there's activation of the complement cascade. Because C3 will not be low in all the cases. Only in 1/3 of the cases the C3 will be low. But C5b9 elevated, AH50 low. So these are all clear signals that suggest that these patients are, having a complement activation. Presence of genetics, that was I showed. Presence of genetic alone or pathogenic one alone will not tell you, because it could be, a different one. Although, now there are signals to suggest the case number 2 that even in rhabdomyolysis there is activation of complement. So probably that may play a role, but I do not know. But it was just to show that, this is how, why genetic testing was done in this patient. Is one of our JRs who saw this patient in emergency right away, 4+ albuminuria, just told get a genetic testing also. Our JRs Akshaya is there, Rahul is there, they're all the one sitting next to her, so they will advise genetic testing. That's actually good.
Since you are into the genetic testing, complement lab, and you were just alluding to what is the role of the C5b9 monitoring? Is there any role of monitoring these in these patients? Exactly, yes. So what is the frequency like, and how do you use it?
So when you use eculizumab, you can monitor them every 3 months. And when you give it for, how long do you give eculizumab before you plan a withdrawal, we do not know. But what they found was if the C5b9 was elevated at the time of eculizumab withdrawal, the risk of relapse is very high. It's close to 80%. So, if the C5b9 is normal and the patient does not carry any CFH mutations, you can go and attempt withdrawal of eculizumab therapy.
And so one final question. I'm really sorry. I'm a little selfish on this. I want to clarify a lot of doubts. So you said about the national policy on rare diseases. So
on national policy of rare disease.
Yeah, on rare disease, we have also received a fund for the same. But then these are lifelong therapies, right? So how do we? How have you approached and how do you give? Because it's a recurring therapy and the cost of therapy is high. So
what you do is it's not that. It's like the government does not say that it pays so much for HUS, it pays so much for rare diseases. Government says that we'll give you, say 100 rupees. You use it the way you want. So you very well know that, most of the diseases, rare disease, will require recurrent therapies. Like, it's not that you give it them for 3 months or 6 months. And the therapies are expensive. So before you complete your quota, you write another mail telling that, we have started, the patient is doing extremely well. So please provide us a next set of, because we cannot leave it halfway. So that is how we plan to do, it's up to the institute to take it up.
Thank you, Dr. Raja. As usual, a very gripping presentation, I can say. I have a question actually with the anti-CFH antibody. How frequently you monitor post-transplant? Because initially we had sent a couple of samples to Dr. Aditi Sinha's trial before she published in KI.
Yeah.
At that time she was doing it free and giving. Then after that, subsequently, it's actually not very expensive to do anti-CFH antibodies alone. So is it like a DSA sort of a monitoring, or as and when required?
You can see the best thing with you've done a transplant, patient is negative, patient is under immense immunosuppression. So it's less likely to recur. So you need not have to really go and check up on that. But yes, if you want to really check, you can do it every 3 to 6 months. With respect to anti-CFH testing, to my best, that is the only lab available in India. We don't test CFH by any other. There is no other place which is validated. See, mark my words, validated. We also use that ELISA kit. When we worked on C3 glomerulopathy, we used that kit. But that's not the right way, because I'm a member of that KDIGO complement. So that's what they say, that other than these validated testing methods, you should not use the commercial ELISA.
And how, after we transplant, how often we do the plasmapheresis? We just stop after the renal function is
No, they said that
or?
pre-transplant, one session 60 ml, then you do every day 60 ml for 3 days, then you do 3 per week for 2 weeks, then you do 2 per week for 2 weeks, and then you decide about giving plasma infusion. So it's really a rigorous, it's more like dialysis than more intensive dialysis kind of. So it's like that. You require huge volumes of plasma also, mark my words, like in these cases.
Thank you, sir, for that fantastic talk. Your slides again were stunning, sir. It was very beautiful. So I just had one small question. You said that there was lots of variation between the labs when we did it here and versus when we sent it outside, and we need to check if it's validated. Is there any way we can know if it's validated? So, is there some accreditation we should look for, or we just take it on good faith?
I have no answers to this, to be honest with you. So that's why we are just starting to do in-house. Because that's how it is. The best thing is we went back and told the company, they agreed, they said that, there may be an error because the set of employees have changed. So, so that's a standard thing then, but they agreed that there can be error. So that's a good thing,
Good.
The audience have some questions. You can take the questions. A lot of questions are there. The audience, we can take all the questions.
Thank you, sir, for a nice presentation. Sir, I have a case of a 30-year-old male who presented with malignant hypertension. He did not have any previous comorbidities or family history. He had a renal dysfunction. Creatinine was around 2.5. He did a biopsy, it showed renal limited TMA. There was no peripheral TMA. So we did his adenine statin activity, which was normal, and anti-factor H antibodies were negative. So how to manage this patient? How long? What is the end point of doing plasma exchange for renal limited TMA? And at what level I should be confident that I have ruled complement mediated TMA? We have sent for genetic analysis that will take a month. Short of
Yeah, I think it's a right question. I deliberately did not touch about malignant hypertension. So essentially, we all believe that malignant hypertension causes, thrombotic microangiopathy, and it could be of any etiology. It could be because of IgA or any other glomerular disease. But now we realize, or systemic sclerosis or anything like that. But now we realize that many of the malignant hypertension where we do not have an etiology could be complement driven. And how did they find it is complement driven? It is not only by genetic testing, but by doing these functional studies. So it's not that everybody could have microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia, easy target to treat. Platelets down, LDH down, platelets up, LDH down, so you stop treatment. But here you really don't know what you need to do. We only know that yes, it could be because of a complement-mediated disease. But whether to treat them with eculizumab or not, one group believes that you need to treat them with eculizumab because we don't have any data with respect to plasma exchange in this cohort of patients. We don't do plasma exchange to this cohort. So one group believes that we should give eculizumab, and if they're going for a transplant, we need to make sure that we give them eculizumab prophylaxis. Or one group believes that it could be just, it could be like not epigenetics but an epiphenomenon. You could have some environmental modifiers which probably resulted in this, and this patient can easily go for a transplant.
I think we are running short of time. So thank you so much, Raja sir. Thank you.
Thank you, sir, for the excellent presentation. We request the chairperson to present the memento to sir. We request Dr. Karthikeyan to present the memento to the chairpersons.
So I just made some reshuffling in the sessions because few of our speakers are having flight. So we'll keep the ball rolling. So we are now moving on to the session of interesting case presentation. Only one case will be presented for time being now, in the sense like Dr. Maitri Shankar, she will be presenting a interesting case, and the session will be chaired by Professor N. Gopalakrishnan and Professor Srijit Parameswaran. And after that, we'll have the session on drug safety in pregnancy and lactation by Dr. Jayasurya. So Dr. Maitri Shankar, she is an assistant professor in the Department of Nephrology, in the Department of Nephrology, Institute of Nephrourology from Bangalore. She is the associate program director of NSMC, and she is a Glomcon fellow instructor, and she is the secretary of WIN India Karnataka, and she is the member of ISN Education Board, SOMI team, ISN Young Nephrology Committee, and she is the editorial board of K Reports and Kidney Medicine Visual Abstract Committee. Over to you, ma'am.
Good afternoon, everyone. At the outset, I would like to thank Department of Nephrology, Jipmer, for providing me this opportunity. So I'm going to share the challenge of diagnosing and managing an ultra-rare case of postpartum TMA. So we had a 25 years old lady, P2L2. She was a booked case with regular antenatal visits. Her antenatal period was uneventful. She underwent LSCS at term. On postpartum day 4, she developed fever. Following that, she had anemia and thrombocytopenia. This was in a peripheral center. So she was referred to a higher center from there. She reached our center on postpartum day 10 with symptoms of nausea, vomiting. When we examined her, we saw that she was pale, she was in altered sensorium, and she had hypertension as well. So these were her labs when she reached us on postpartum day 10. She had anemia, hemoglobin had dropped, and she had thrombocytopenia. Renal dysfunction, her baseline creat was 0.5, which had increased to 1.58. Indirect hyperbilirubinemia, and LDH was elevated more than 3 times the upper limit of normal. Peripheral smear was suggestive of cystocytes. However, the autoimmune workup was negative. Serum haptoglobin levels were less than 15%. We had got an MRI brain because she was in altered sensorium, which was suggestive of breast. The complement levels and the sepsis markers were fairly okay. So clearly she satisfied the 3 components of thrombotic microangiopathy, that is thrombocytopenia, platelet counts of less than 1.5 lakhs. In pregnancy, in gestational, there's physiological gestational thrombocytopenia, so the cutoff comes down to 75,000, or we could even consider more than 25% fall from the baseline. End organ damage, in this case involving kidneys and the brain. Microangiopathic hemolytic anemia supported by anemia, cystocytes on peripheral smear, elevated LDH, reduced haptoglobin levels, and indirect hyperbilirubinemia. So this was again TMA in pregnancy. TMA in pregnancies are always difficult. They are difficult to diagnose, difficult to manage. There's a lot of overlap. So if you see the timing of TMAs during pregnancy, TTP can occur anytime during the entire period of pregnancy or also in the postpartum period, but predominantly it is in the third trimester and in the postpartum period. Preeclampsia and HELP syndrome, mostly beyond 28 weeks, but can occur from 20 weeks as well, and also in the postpartum period. Complement mediated TMA, 80% of the women present in the postpartum period. Adding to this, there are other TMAs also which are not related to pregnancy, such as drugs, malignancy, autoimmune diseases, and infection. So this was our plan of action. Clearly, if it was preeclampsia or HELP, she should have improved after delivery, which she did not. In fact, the disease onset was in the postpartum period, so we had to rule out preeclampsia and HELP. Sepsis markers were fairly all right, autoimmune workup was negative. So our differential diagnosis was complement-mediated TMA and TTP at this point of time. In complement-mediated TMA, obviously there is the overriding feature is involvement of the kidneys, acute kidney injury. In TTP, it is more of cardiac and neurologic involvement with mild renal symptoms. So we sent for ADAMTS13 activity levels, and then we initiated her on plasma exchange and steroids because this would help in both complement-mediated TMA as well as TTP. Our plan was, if this was to come back as less than 10 international units per deciliter, then the diagnosis of TTP is established. If ADAMTS13 activity is to come back as more than 20 international units per deciliter, then we would work up for complement-mediated TMA. So we sent for ADAMTS13 workup, and we initiated her on plasma exchange and steroids. She received plasma exchange and steroids for 5 days. The turnover time for ADAMTS13 activity levels are more, it is 5 to 7 days. So after that we received the ADAMTS13 activity level, which came back as 0. So clearly it was a case of TTP here. If you look at the incidence per pregnancies of TTP, TTP is very rare, being 1 in 2 lakh pregnancies when compared to preeclampsia and HELP, which is 1 in 1,000 pregnancies. I'm sure all of you are aware of the pathophysiology of TTP. There are these ultra-large von Willebrand factor multimers that are secreted from the endothelial cells. Usually it is the ADAMTS13 which breaks down these ultra-large von Willebrand factor multimers into small, spherical, inactive multimers. If there is absence of ADAMTS13, then these ultra-large von Willebrand factor multimers will cause platelet aggregation, microthrombi formation, tissue ischemia. And the RBCs which are in circulation, there is shearing of these RBCs leading to cystocytes on the peripheral smear. So based on the type of ADAMTS13 defect, we can classify TTP as either congenital or immune-mediated TTP. Congenital TTP is because of inadequate activity or inadequate production of ADAMTS13, and immune TTP is because of the production of pathogenic autoantibodies against ADAMTS13, or also because of the production of inhibitors which would increase the clearance of this ADAMTS13. Looking at congenital TTP, it is also called as Upshaw-Scullman syndrome. It is an autosomal recessive disorder because of inadequate activity or production of ADAMTS13. If you see here, just a moment, just switch on the laser pointer. Yeah. So if you see here, among all the TTP patients, adult onset TTP is most common, 95%. Childhood onset is only 5%. And among congenital and acquired, majority are acquired TTP, 90%, and congenital TTP is only 10%. So congenital TTP can also present in adulthood, but mostly in pregnancy, being the precipitating factor here. The treatment is almost similar, congenital TTP and acquired TTP. Only difference is that in acquired TTP, we have to give immunosuppression because it is due to the pathogenic antibodies or the inhibitors which are being produced. And in congenital TTP, we have to replace ADAMTS13. So we have fresh frozen plasma. We have fresh frozen plasma, and we have recombinant ADAMTS13 also. Infusions are available, which can be used for replacement. So the ratio gets reversed in pregnancy. Late onset congenital TTP becomes 56% in pregnancy, and immune-mediated TTP is only 44% in pregnancy. Looking at the epidemiology of immune TTP, it is primarily seen among young adults between 20 to 50 years of age, mainly females, African Americans, precipitated by certain conditions like pregnancy, autoimmune disease, malignancy, retroviral disease, drugs, and estrogen-containing contraceptives. So this we have to be very careful. We have to tell these ladies who are predisposed for TTP to avoid taking estrogen-containing contraceptives. And why is pregnancy a common precipitating factor? It is because of certain physiological changes that happen during pregnancy. There is increase in factor 8 and von Willebrand factor levels, and also reciprocal drop in ADAMTS13, as you can see here in the graph. The ADAMTS13 levels goes on decreasing maximum in the third trimester. Looking at the clinical presentation, thrombocytopenia is seen in 100%, but bleeding is usually not very severe or life-threatening. Thrombocytopenia is 100%, microangiopathic hemolytic anemia is also 100%. Neurological involvement is 70%. It can be as subtle as headache, or it can be as major as even coma. But you have to note that with aggressive therapy, complete neurological recovery is possible. So if someone has got a severe neurological impairment, that should not discourage you from treating the patient aggressively. And fever in 20%. Kidney injury is usually mild when compared to other causes of TMA. And also it is very rare that someone with TTP would go into kidney failure with current management strategies that are available. Other organ involvement is heart and GI tract. So the empiric treatment is for TTP is plasma exchange and steroids. TTP is usually the initial consideration because it is we consider it as a medical emergency, as it has a very high fatality rate of 90%. With treatment, the fatality rate comes down to 25%. So therefore, PLEX is usually started empirically even before the diagnosis of TTP is established. We don't wait for the ADAMTS13 reports to come in. Compared to all the TMAs, TTP is most life-threatening because of the involvement of brain and heart. So we have this scoring system which will help us in identifying the patient who would benefit from plasma exchange, and also the likelihood of that patient having TTP. Earlier it was the French score, now it is the plasmic score. So mind you, this is applicable only to patients who have a clinical suspicion of TTP. The score ranges from 0 to 7, and there are 7 parameters here. The earliest available labs should be used. A score of 5 to 7 has a very high sensitivity of TTP, and that would suggest a benefit from empiric plasma exchange. So this is the investigation flowchart. The first screening test is to send for ADAMTS13 activity, which came back as positive. So the diagnosis of TTP is established. Now we have to find out whether it is congenital TTP or immune TTP. So for that we have to send for anti-ADAMTS13 antibody levels. If that comes back as positive, it is autoimmune TTP. If it is negative, then we do genetic analysis, look for the mutations, and mostly it is congenital TTP. So these were the test results of our patient. ADAMTS13 activity was 0%. We sent for inhibitor levels, which came back positive. So we had a diagnosis of autoimmune or immune-mediated TTP. The initial treatment is plasma exchange. This is the mainstay of therapy, helps in removal of von Willebrand factor multimers, removal of anti-ADAMTS13 antibody, and also addition of ADAMTS13 enzyme. This plasma exchange should be initiated as soon as possible within 6 hours of diagnosis of TMA. If there's going to be any delay in initiating plasma exchange, you can always give fresh frozen plasma infusions. For every 4 hours of delay, 1 FFP infusion is recommended. And some technical details while doing plasma exchange. Even though there is thrombocytopenia, we can comfortably insert the hemodialysis catheter for plasmapheresis because the bleeding chances are not very high. Under ultrasound guidance by an expert operator, it is generally safe. And avoid transfusing platelets because that would again increase the microthrombi formation and tissue ischemia. Volume of replacement fluid is 1 to 1.5 times the patient's plasma volume, but it is usually done once in a day. But if the patient has got life-threatening neurological or cardiac involvement, you can perform it twice a day as well. How long to continue? Until the platelet counts remain more than 1.5 lakhs for 2 consecutive days. We can also use LDH levels to gauge response to PLEX. Immunosuppressive therapy, high-dose steroids indicated in immune TTP until the platelet counts are stabilized and plasma exchange is stopped. So once platelet count is stabilized for 5 to 7 days, we can slowly taper over the next 3 weeks and stop the steroids. Or you can also individualize based on the platelet count, ADAMTS13 test results, and the clinical symptoms of the patient. Rituximab is indicated in severe acute immune-mediated TTP with neurological or cardiac pathology. Refractory immune-mediated TTP, which is characterized by absence to response to the therapy by day 30. Relapsing immune-mediated TTP, a recurrent disease 30 days or longer after reaching treatment response. It is contraindicated in pregnancy and breastfeeding. Treatment of congenital TTP is just replacement of fresh flows in plasma until the symptoms resolve and until the platelet counts are normalized. Following that, you can reduce the frequency to once a week or once in 2 weeks or once in 3 weeks, depending on what the patient needs. Also, of late, recombinant ADAMTS13 is also available. This is a fully glycosylated recombinant human ADAMTS13 protein. It has good tolerance, safety, non-immunogenicity and efficacy profile, but the cost is definitely alarming. The histology of placenta gives us a lot of information. This is histology of a placenta, the gross of the placenta from an untreated congenital TTP in pregnancy. So here you can see that there are many infarcts of differing ages. So some are very recent infarct and some are very old infarct. So this clearly tells us that TTP is an ongoing process throughout the pregnancy. So thromboprophylaxis is very important. Once the platelet count reaches beyond 50,000, we have to start the lady on low molecular weight heparin. This was our patient. She presented to us on postpartum day 10. We gave her plasma exchange and steroids. So after 5 days, her renal function continued to worsen. It was like 3.27. So we had advised her for rituximab infusions as well, but then they went discharge. They got discharge against medical advice, and they didn't. I think they did not follow up anywhere else outside. They came back after 10 days, and this was her reports when they came back. So her anemia had worsened 5.4, platelet count were 52,000, and creatinine renal dysfunction had worsened to 8.41. Urine output, she was anuric and LDH was also elevated. So at this point, again, we initiated her on hemodialysis, gave her PRBC transfusions. She also received 8 sessions of plasma exchange, and we also gave rituximab. So following that, as you can see, her hemoglobin stabilized, platelet counts were also okay, and serum creatinine also started to improve. Her urine output improved to 2.3 liters. This is her latest labs on postpartum day 45. She has normal renal functions now, and we repeated the ADAMTS13 inhibitor levels, which came back as positive. She's on tapering dose of steroids right now. This is a new drug which is available, FDA approved, caplasizumab. It is an antibody fragment which binds to the von Willebrand factor. It blocks the interaction between the von Willebrand factor and the platelets. So this will prevent the formation of microthrombi. This is usually indicated in severe situations. Drawback is increased risk of bleeding. Contraindicated in pregnancy and breastfeeding. Again, the doses, the cost is alarming. It is rupees 23,900 for 1 dose. Can a lady diagnosed with TTP conceive? Yes, she can definitely conceive. Again, it should be planned and under guidance. Of course, Dr. Satish sir has very nicely spoken about all the maternal complications and fetal outcomes which are supposed to counsel to the patient. She will require multi-speciality care. If you see here, pregnancy following the diagnosis of TTP, under guidance, there are 0% chance of intrauterine death and 100% chance of live birth. So if it is congenital TTP, the guideline says that as soon as the pregnancy is confirmed, we have to initiate her on plasma infusion every 2 weeks, start on low dose aspirin and thromboprophylaxis, increase the infusion frequency to once every week from second trimester, plan delivery at 37 or 38 weeks of gestation, continue regular plasma infusion for at least 8 weeks postpartum, which is very important. We have to monitor her in the postpartum period as well. And of course, during pregnancy, we have to get regular fetal scans and measurement of uterine artery flow by Doppler. If it is immune-mediated TTP, the management is the same. Only thing is we also have to look for ADAMTS13 antibody levels. Every trimester we have to get it done. And if the activity of ADAMTS13 is between 10 to 30%, we initiate her on steroids and azathioprine if required. If it is less than 10%, initiate on plasma exchange. So take-home message, TTP is an ultra-rare TMA caused by severe deficiency of ADAMTS13 activity. Most often it is because of autoimmune antibodies, that is immune-mediated TTP is most common. It has a very high untreated mortality rate of 90%, so we have to initiate the patient on treatment as soon as possible. Plasma exchange is the cornerstone of treatment. Early and aggressive treatment is crucial, especially during pregnancy, to reduce maternal and fetal morbidity and mortality. And with current treatment strategies, TTP in pregnancy can be managed successfully with favorable outcome for both mother and child. Thank you.
Thank you. That was a very comprehensive account of ADAM-TS13 deficiency associated TMA. As you have mentioned, it is quite rare. Thing is that, at the point of presentation, we may not know whether it is immune mediated or there is a genetic predisposition. So, you are right in starting steroids. That is one situation because, the peripartum period, vulnerability for sepsis is high, infections is high. And blindly giving steroids, there should be a justification. But we can't really avoid that. If it is due to antibodies, it is we are justified in giving. How long did you give steroids?
Sir, we pulsed her for 3 days, and then we started her on 1 mg per kg body weight. 40 mg we give maximum, even if it is 1 mg per kg body weight. So at the time of the renal dysfunction was settling and platelets were stabilized. So following that, we started tapering. Now she's on tapering dose. We are planning to taper over 3 weeks and stop. She also received rituximab. So that is again 500 mg we give once a week for 4 weeks.
It was very comprehensive discussion of TTP. I just wanted to add one case we had. It didn't have any renal involvement many years back. The point I wanted to mention is that that patient relapsed after many years. It was a child who came with the TTP, no renal involvement. When we were involved because we were doing plasma exchange, the patient was given rituximab. That time assay was not available. Later on we got the antibodies done when the patient came with the relapse after. So it seems the patient we can't keep them on long-term immunosuppression. So this patient was not on long-term, the patient was given rituximab, patient went into remission, but after around 5 years the patient came again with relapse, was given plasma exchange. That time we got the antibodies done, and then the patient was given rituximab again, and the patient was kept on long-term immunosuppression. So it looks like long-term immunosuppression or recurrence can be expected. I don't know the data on
Yes,
that.
so
There's only one case which we have seen.
So if it is congenital TTP, they will require infusions. We have to keep substituting, depending on what is the requirement for that particular patient. Probably this is immune-mediated TTP. Maybe it requires workup to find out whether it is congenital or immune-mediated. Immune-mediated recurrence is 13% to 30% of the patients within 2 years. So it is like chronic relapsing immune-mediated TTP. It will relapse. So we have to keep monitoring the antibody levels at least once in 6 months, then slowly probably once in a year for those patients.
Yeah, so this patient had antibodies on the relapse. When she came with relapse after 5 years we found, and then the patient was kept on long-term immunosuppression. I think she was on Azoran. The patient was being followed up by pediatrics on long-term. Thank you, that was a very comprehensive discussion.
Thank you so much, ma'am. The topic for the next session would be ensuring drug safety during pregnancy and lactations. The chairpersons for the session would be Dr. S. Edunilavan, consultant nephrologist at Srinarayani Hospital and Research Center, Vellore; Dr. M. Venkatraman, consultant nephrologist at East Coast Hospital, Pondicherry; and Dr. Chella Jashwant, consultant nephrologist at Continental Hospital, Hyderabad.
We introduce our speaker, Dr. R. Jayasurya, consultant nephrologist at Apollo Multispeciality Hospital, Kolkata. Ma'am did her DM nephrology from Jipmer and is a pediatrician by training. She has authored many papers and books and chapters on the same. We request you to please come onto the stage and take over, ma'am.
A very good afternoon to all. The topic allotted to me is ensuring drug safety during pregnancy and lactation, best practices and guidelines. So, as we have heard in yesterday's lectures, complex physiologic changes occur in pregnancy, leading to extensive changes in drug metabolism and pharmacokinetics. So, toxic and teratogenic effects of each drug should be individually and carefully analyzed, and extensive risk-benefit analysis is necessary before prescribing drugs in pregnancy. So, this will be the overview of my discussion today. FDA classification of drugs in pregnancy and lactation and the updates on that, drug pharmacokinetics in pregnancy and lactation, and I will discuss briefly about the major drug classes which we routinely use in nephrology practice: immunosuppressives, antihypertensives, diuretics, RAS inhibitors, and anticoagulants in pregnancy and lactation. Coming to the first topic, FDA classification of drugs in pregnancy and lactation. This classification we are all familiar with. It was introduced way back in 1979, and drugs are classified from category A to category B, C, and D, and category X. So let's look into each of these categories. Category A is where adequate and well-controlled studies are available in pregnant women, and they have failed to demonstrate a risk to the fetus in the first trimester of pregnancy. Examples are folic acid, levothyroxine, and doxylamine. We can see that there are very few drugs in this category. Category B is where animal reproduction studies have failed to demonstrate risk to the fetus. No well-controlled studies are there in pregnant women, or animal reproduction studies have shown adverse effects, but well-controlled studies in pregnant women have shown no adverse effects. Examples are amoxicillin, loratadine, and ondansetron. Coming to category C, here we have animal reproduction studies. They have shown no adverse effects on fetus, or there are no animal reproduction studies and no well-controlled studies in humans. So most of the drugs which we commonly use in pregnancy are included in this category. Examples are CNIs, glucocorticoids, azathioprine, and rituximab. And most of the antihypertensives which we use in pregnancy are also in this category. Category D is where there is a definite positive evidence of fetal risk, but benefits may sometimes outweigh the risks, and we may even use these drugs in some situations. Examples are lisinopril, lithium, and phenytoin, and MMF and cyclophosphamide, and are in category D. Category X, there is a positive evidence of fetal risk, and risks clearly outweigh any possible benefit, and these drugs are absolutely contraindicated in pregnancy. Examples: methotrexate, simvastatin, warfarin, and leflunomide. So this FDA categorization gives us a guideline for the relative safety of medications, but more detailed information is needed to fully understand the efficacy and safety of medications to be used in pregnancy and lactation. So in 2009, FDA conducted a study to understand how generally healthcare providers make treatment decisions regarding the pregnant patients, and by 2015 they evolved a new system known as PLLR, Pregnancy and Lactation Labeling Rule. This was developed to minimize misinformation and to better assist physicians in choosing the drugs. So here in PLLR system, there are three categories given: pregnancy, lactation, and there is a third category which was not included in the previous FDA system: females and males of reproductive potential. So in this each category there are some subcategories given. Pregnancy category includes pregnancy and exposure registry, pregnancy exposure registry. Then there is risk summary, clinical considerations, and data. In lactation we have risk summary, clinical considerations, and data again. And in the third category we have advice on pregnancy testing, contraceptive advice, and infertility related advice. So this pregnancy exposure registry is included if there is a registry available, and includes contact information for patients on how to enroll. Risk summary, there is a summary of human, animal, and pharmacologic data, and statement if there is absence of data. Clinical considerations give benefit risk counseling, disease associated maternal and fetal risks, dose adjustments during pregnancy and postpartum period, and maternal and fetal or neonatal adverse reactions are also mentioned. Data includes a concise description of studies used to support the risk summary. So this system is a vast improvement compared to the earlier FDA category. Drugs submitted to FDA approval after June 30th of 2015 applies the PLLR rule, and FDA category is no longer applicable. But this system rarely gives yes or no answers, so extensive risk benefit analysis and clinical decisions should be done varying on case-to-case basis. So coming to the second topic, changes in drug metabolism and pharmacokinetics in pregnancy. So we know that many physiologic changes occur in pregnancy and they affect drug metabolism and efficacy to a great extent. important ones are increase in plasma volume, which occurs in pregnancy. There is increase in the extracellular water and total body water levels. There is increased volume of distribution of hydrophilic drugs. So this results in reduced plasma and tissue concentration of the same dose of drug. Also, there is increased total body fat, which leads to increased volume of distribution of lipophilic drugs. So there is increased cardiac output, increased renal blood flow, increased GFR, upregulation of certain renal transporters, and all these increase the renal clearance of drugs by 30 to 50%. Also, there is a reduction in concentration of transport proteins, mainly albumin and alpha-1 acid glycoprotein. So as that carrier protein concentration decreases, there is an increase in the free fractions of drugs. There are many GI changes with pregnancy related to the hormones. There is reduced splanchnic blood flow, progesterone mediated delay in gastric emptying, delay in intestinal motility, increased intestinal transit time. There is increased gastric pH, and all these factors reduce the drug absorption. Also, there is alteration. Some may increase and some may decrease in the activity of the drug metabolizing enzymes, cytochrome P450 enzyme and UDP glucuronide transferase enzymes, and these to a major extent affect the drug levels of in pregnancy and lactation. So to summarize, these are the changes which occur in drug metabolism and pharmacokinetics. There are changes in absorption, metabolism, distribution and elimination. In absorption, because of multiple factors ranging from nausea, vomiting, delayed gastric emptying and increased gastric pH, absorption decreases. Metabolism, there is enzyme induction or inhibition by the hormones, resulting in increase or decrease in drug metabolism. Distribution, because of increased total body water, increased body fat, there is increased volume of distribution of both hydrophilic and lipophilic drugs. Also, there is decreased protein binding. And elimination, increased renal blood flow and increased hepatic blood flow, resulting in general, increased renal and hepatic excretion. So moving on to the individual drug classes, firstly we will see about the immunosuppressants which we commonly use and their safety in pregnancy and lactation. We all know pregnancy is not a formal contraindication for women with autoimmune diseases, glomerular diseases and also for transplant recipients, but need to continue immunosuppressants is a major challenge because of the possible teratogenic and also toxic effects. So modification of medicines and also proper planning of pregnancy is most important. Firstly, we will see glucocorticoids. They act through genomic and non-genomic effects leading to powerful anti-inflammatory action. Glucocorticoids easily cross placenta and 90% of glucocorticoids is metabolized within the placenta by the enzyme 11-beta-hydroxysteroid dehydrogenase 2. So cortisol, prednisone and methylprednisolone are metabolized in the placenta to inactive products, but dexamethasone and betamethasone are less well metabolized. There is a possible increased incidence of oral facial clefts reported in newborns from mothers on steroids. The reported prevalence is 1.3 to 3.3 per 1,000 pregnancies, whereas the population prevalence is 1 per 1,000. So there is a slight increased prevalence reported. Another interesting phenomenon is early life programming. So exposure to cortisol in early gestation influence fetal growth and can lead to dysfunction of the fetal hypothalamic pituitary axis, resulting in permanent changes in the physiology of the fetus, and this can lead to later chronic diseases. But in general, only 3% of maternal cortisol is transferred to fetal circulation, so it is unlikely that moderate doses of exogenous steroids may interfere with early life programming unless there is an alteration in the drug metabolizing enzyme, the 11-beta-hydroxysteroid dehydrogenase 2, which can occur in preeclampsia. So steroids is categorized in FDA category C, where human risk cannot be 100% ruled out. Risk of toxicity with prolonged high dose exposure can occur, especially in preeclampsia. Dose of prednisone less than 20 milligram per day is generally safe for the mother and the newborn, and it is safe to use in breastfeeding. Moving on to cyclosporin, animal studies have shown some increased prenatal and postnatal mortality with use of cyclosporin, reduced fetal weight, skeletal retardation, low birth weight, Increased incidence of cesarean deliveries and hypertensive disorders of pregnancy are reported in mothers, transplant recipients who are on cyclosporin. The drug is very lipid soluble, it's extensively distributed in the body and highly metabolized. There is a high concentration seen in the placenta due to the presence of metabolizing enzyme. And transplacental passage of the drug is influenced by P-glycoprotein, which pumps out the drug out of the trophoblast cells and restricts the passage of cyclosporin across the placental barrier. Cyclosporin is FDA category C. Tacrolimus can cross placenta with in utero exposure of about 71% of the maternal drug concentration. Metabolism by fetus is limited. As in cyclosporin, there is an active efflux by placental P-glycoprotein. Low birth weight and preterm birth are reported. Both CNIs can cause reversible hyperkalemia and nephrotoxicity in the newborn. There is negligible excretion in breast milk. FDA category C again. Moving on to nucleotide synthesis inhibitors, azathioprine, MMF and leflunomide. Azathioprine is a prodrug of 6-mercaptopurine and only inactive metabolites pass into fetal circulation. So generally this drug is considered safe. No major congenital malformations are reported. It's safer than other nucleotide inhibitors like MMF. Mild chromosome anomalies are reported, but long-term consequences are not very clear. Mycophenolate mofetil and mycophenolate sodium. There is an increased risk of first trimester pregnancy loss, increased risk of congenital malformations, external ear and other facial anomalies, cleft lip, cleft palate, distal limb anomalies, heart, esophagus and kidney anomalies reported with MMF. It's FDA category D and it's not recommended during pregnancy. So before starting MMF, it is advised to ensure negative pregnancy testing in women of reproductive age. At least 2 contraceptive use should be advised, and if pregnancy occurs, mycophenolate should be stopped as early as possible and should be replaced by azathioprine. Paternal exposure is not associated with adverse outcomes. Leflunomide is FDA category X. There is definite teratogenicity reported. Metabolites are detected in maternal plasma for long time, so pregnancy should be planned at least 2 years after discontinuation of leflunomide, and in case of unplanned pregnancy, stop as soon as possible. HCQ, animal studies have shown some neurological disturbances, but there is no control data in pregnancy. It's FDA category C, and the drug can be continued throughout planned lactation. Coming to the other drugs, cyclophosphamide, again FDA category D, like MMF. We should have a negative pregnancy testing before using the drug. Use at least 2 methods of contraception during the drug usage. Miscarriages, preterm deliveries and teratogenicity is demonstrated. Case of malformations are reported in newborns exposed in the first trimester. mTOR inhibitors, sirolimus and everolimus, they are FDA category C. There is increased mortality of fetus seen in animal studies, and there is insufficient data on humans. Rituximab, it's again FDA category C, but it's recommended to avoid pregnancy until 6 months after exposure. There is no data on breastfeeding. Long-term data after in utero exposure is also unknown. Premature deaths, miscarriages and neonatal deaths are reported. Hematologic abnormalities are also reported. There are reports of neonatal infections, and occasional single case reports of clubfoot and cardiac malformation is also there. It can cause reversible B cell deficiency in newborns. Eculizumab, animal studies have shown that eculizumab crosses placenta and increase rate of development abnormalities and increase mortality. Rare cases of retinal dysplasia is also reported. If benefit exceeds the risk, as in some diseases like PNH, we can continue to use in pregnancy. There is negligible excretion in breast milk. Women of childbearing age, it's advised better to avoid pregnancy up to 5 months of use of eculizumab. Moving on to antihypertensive drugs, the 4 drugs which are recommended during pregnancy are labetalol, modified release nifedipine, methyl-dopa and hydralazine. We have already discussed these drugs in detail yesterday. Labetalol and nifedipine are preferable to methyl-dopa for mild to moderate hypertension. Oral nifedipine has been shown to have a better efficacy compared to oral methyl-dopa. Preeclampsia with severe features, there is comparable efficacy between oral nifedipine, IV labetalol and IV hydrolysine. There is an ongoing trial comparing the efficacy between oral labetalol and oral nifedipine. It's a giant panda trial. So coming to the summary of these drugs, labetalol is a mixed alpha and beta blocker. The doses are given. Neonatal surveillance for hypoglycemia is recommended, and it's contraindicated in maternal asthma and bradycardia. Nifedipine calcium channel blockers, 3 release formulations are available. Immediate release formulation, which can be used in severe symptomatic hypertension with in patients with difficult IV access especially. Intermediate release formulations, onset within 60 minutes, and extended release formulations, onset within 1 to 2 hours and acts for 24 hours. Side effects reported are maternal headache and tachycardia. Methyl dopa reduces central sympathetic output. It's a relatively safe drug, except maternal sedation is a common side effect. Hydrolysine is a vasodilator. It's indicated only in severe hypertension. It's more effective than labetalol, but the disadvantage is hypotensive effect is less predictable. And in some situations where all the first-line drugs are not effective, we may be forced to use drugs like nicardipine, sodium nitroprusside, esmolol and nitroglycerin, though the safety data is not very much. Moving on to RAS inhibitors in pregnancy, US FDA has issued a black box warning that drugs that act on the renin-angiotensin system can cause injury and death to the developing fetus, so discontinue as soon as possible once pregnancy is detected. This group of drugs is clearly associated with fetopathy, especially with second and third trimester use. First trimester association with toxicity is less certain, so cautious use is recommended in women of childbearing age and should be avoided throughout pregnancy. First trimester, even with first trimester exposure, congenital anomalies, cardiovascular anomalies, stillbirth, preterm birth and miscarriage are reported. But second and third trimester exposure, there are more common reports of anomalies, mainly impaired fetal or neonatal kidney function, oligomnios during pregnancy, and renal tubular dysgenesis is reported. Postnatal exposure from breast milk, usually the drug level is low in breast milk, but hemodynamic effects leading to neonatal hypotension, oliguria and seizures can occur. So proper counseling and appropriate contraceptive use is recommended for patients on RAS inhibitors, and the drug should be discontinued immediately in those who present in early pregnancy. Moving on to diuretics in pregnancy and lactation. Thiazide and thiazide-like diuretics, they are not associated with increased risk of fetal anomalies, but the concern is about the interference with physiologic volume expansion of pregnancy and possible reduction in uteroplacental perfusion, so thereby the use is limited. It's only indicated in hypertension associated with volume overload when other agents have not been successful in achieving the blood pressure targets. Loop diuretics, again not routinely used in the treatment of hypertension. In heart failure or chronic kidney disease patients with volume overload, cautious use is indicated. In postpartum hypertension, diuretics can be effective when hypertension is associated with edema. Antihypertensives during lactation, drugs with least transfer to breast milk should be the ideal drugs. Among the beta and alpha beta blockers, propranolol, metoprolol and labetalol, they have the lowest transfer to breast milk. Atenolol and acebutolol are extensively excreted in breast milk. Carvedilol and bisoprolol, no published data is available. Among calcium channel blockers, breast milk excretion is relatively low. AC inhibitors are transferred to milk at very low levels, so newborns may be susceptible to hemodynamic effects. ARBs, no information on breastfeeding. Diuretics may reduce the breast milk volume, so must be carefully used. Methyl dopa and hydrolysine are relatively safe for newborns. Methyl dopa can be associated with maternal depression. Moving on to the next class of drugs, anticoagulants in pregnancy and lactation. So management of anticoagulation in pregnancy is very challenging and needs close maternal and fetal well-being monitoring. The indications for anticoagulation during pregnancy are DVT and pulmonary embolism prevention and treatment, inherited thrombophilias, sickle cell disease, atrial fibrillation, prosthetic heart valve, and antiphospholipid antibody syndrome. Heparin and low molecular heparin, they are advised safe for pregnancy use. Heparin do not cross placenta. There is no risk of fetal anticoagulation, no increased risk of congenital anomalies. In general, low molecular weight heparin is preferred over unfractionated heparin except in the late stages of pregnancy. Also, UFH is preferred when rapid reversal is indicated and in patients with creatinine clearance less than 30. Low molecular weight heparin, it's more predictable response, no need for monitoring, easier to administer, and risk of heparin-induced thrombocytopenia is less. Warfarin, it's teratogenic, can cause fetal anticoagulation. Exposure during early pregnancy is definitely associated with embryopathy. Exposure during late pregnancy, fetal bleeding, including intracranial hemorrhage, is reported. Directly acting oral anticoagulants are not recommended during pregnancy as information on efficacy and safety is lacking. In patients with HIT, where we cannot use heparin and low molecular weight heparin, we can use danaparoid, fondaparinux, and ergotropan. These are relatively safe in pregnancy. In breastfeeding women, the drugs which can be continued are low molecular weight heparin, unfractionated heparin, fondaparinux, warfarin, and other vitamin K antagonists can be continued, and danaparoid can be continued. Oral anticoagulants are not to be used during pregnancy. Also, dabigatran is not to be used in pregnancy. So, to conclude, we can see that there is limited data on many of the commonly used drugs in pregnancy. As conducting a controlled trial on use of drugs in pregnancy and lactation and ensuring their safety is very decision should be made comparing after discussion with the patient with the risks involved and the benefits involved. And always we should compare between treatment related adverse effects versus adverse effects with no treatment, and then decisions should be made. Thank you.
Thank you for the comprehensive coverage of all the class of drugs which are commonly used in our clinical practice. I have a small doubt. Suppose a patient is on everolimus for TAC-induced TMA. So if you want to conceive, can see or continue the drug in pregnancy, or like we need to change the immunosuppressive?
If you see the FDA category, it's given as category C, but in general we prefer to continue on CNIs.
What about any preference of steroids, any class of, the individual drugs in pregnancy, like?
Between the classes of steroids.
In the steroid group, like if you have any preference towards methylprednisolone or
prednisolone is safe because the metabolism is high in the placenta, the fetal transport is less, so prednisolone is relatively safe. Dexamethasone is seen to cross placenta, but in for fetal lung maturity, obviously we use dexamethasone.
Yes. Thank you.
Thank you, madam, for the nice presentation. Actually, you mentioned in your slides that prednisone less than 20 milligrams is safe for both fetus and mother. In patients with rapidly declining renal function, we commonly tend to use higher doses like pulse methylprednisolone because all these immunosuppressions are class C drugs.
Yes.
And 1 in 1,000 pregnancies can cause cleft lip and cleft palate. Do you specifically mention it to the patient?
Yes, that is what I was mentioning. We should do a risk-benefit analysis. We should inform the patients also regarding the possible risks involved, and if the disease treatment indicates the use of the drug, obviously we should go for the drug, because the comparison should be between outcomes with no treatment and outcomes with treatment. So obviously the treatment will be better for the maternal and fetal outcome here.
Rest of the drugs, most of the side effects are like low birth weight and preterm delivery, which in a sense it is caused by the disease we are treating also.
Yes, exactly.
So we are escaping in that way, but
yes. So the disease treatment should be given priority because it may improve the outcome even better.
Thank you. Any other questions?
I said leflunomide, you said 2 years. We have to stop.
Sir.
That seems a little excessive, no? Why do we stop for 2 years? Even though the drug has a long metabolism, I don't know any drug has got 2 years.
So in the literature, it's mentioned that the drug level is seen in the maternal plasma up to 2 years. So it's
It's a
recommended.
long time. I think we should not be using leflunomide, no? At all.
One more question, ma'am. This rituximab, when you're giving, there is any cutoff till what gestational age you are giving?
I don't think there is definite literature, but late administration can be more associated with neonatal bone marrow suppression, because B cell deficiency infections and all are reported. But still, again, I think we should, if it's definitely indicated for salvaging the maternal kidney or for the maternal disease treatment, then we should go ahead.
Okay, thank you. Any other questions from the floor?
Thank you so much for the wonderful session, ma'am. I request our chairpersons to kindly hand over a memento as a token of our appreciation to the speaker. I now request Dr. Priyamvada to kindly hand over mementos to our chairpersons. Ma'am, please.
The next session on pregnancy in a renal transplant recipient will be chaired by Dr. Edwin Fernando, Professor and Head of Nephrology at Stanley Medical College, Chennai, Dr. Reddy Shivakumar, Assistant Professor of Nephrology at the Government Medical College, Vizianagaram, and Dr. Sahil Arora, Consultant Nephrologist at Sri Agrasen International Hospital, Delhi. I'd like to call upon our chairpersons to the dais.
We have Professor N. Gopalakrishnan, the Member Secretary of Transplant, Tamil Nadu, and former Director at the Institute of Nephrology, Madras Medical College, as a speaker for this session. We request Sir to kindly take over.
Good afternoon. At the outset, my profuse thanks for the organizing team. I've been enjoying session after session since yesterday evening. It's quite interesting. A nice opportunity to recapitulate and to enhance your knowledge. And it's an opportunity for me to share our experience with regard to pregnancy and kidney transplant recipients. Actually, when the first kidney transplant was done, Dr. Joseph Murray, if you go through his writings, his own reflections as to what all went through his mind, it's very baffling and very interesting. The first ever time the medical fraternity came across something very new, not just beyond medicine, a lot of ethical considerations and so on. You all know the first transplant took place in Boston, and initially few transplants were between the identical twins. The third transplant was in a woman. Actually, the recipient was Edith Hem, and the donor was her identical twin sister, Wanda Foster. That took place in 1956. If you have a chance, please go through the letter to the editor in NEJM, I don't remember the exact year, 70s, by Murray himself. The third transplant, but for the first ever time, I am transplanting between two young women. Both of them are married and both of them are childless at that time, right? What will happen to them? Will they become pregnant at all, both the donor and the recipient, with one kidney? Will there be a successful pregnancy at all? That was a mind-boggling issue that I am facing. But surprisingly, within a couple of years, 1958, Edith Helm became the first woman kidney transplant recipient to have a successful pregnancy. And she is one woman who lived for 55 years after kidney transplant.
And when she left, when she died, she was survived by 2 children, 1 son and 1 daughter, 4 grandchildren, and 4 great-grandchildren as well. And want of Asta, the donor also had successful pregnancy. She became the mother of 4 children. So that is a success story. Fine. All these things, my talk has become very simple now. Almost every component of it has been discussed in different perspectives. You all know CKD is a state of secondary amenorrhea, and even those who have menstrual cycles, most of the cycles are anovulatory. So there is very high incidence of infertility. But a successful engraftment of the kidney results in return of the ovulatory cycles within weeks after transplantation. And the resolution of the hypothalamic pituitary gonadal dysfunction happens within 6 months. So after 6 months, in any lady with, in the reproductive age group with regular menstrual cycles, we have to initiate the counseling with regard to the conception and pregnancy and so on. Fine. So this is very peculiar situation where you have to be, why I said it's a conception is required, a lot of discussion is required, because the pregnancy in a kidney transplant recipient is neither a zero risk affair nor a totally gloomy phenomenon, but it is very complex. You have to ensure the safety and well-being of 3 stakeholders: the mother, the fetus, and the allograft. I'm just picking up Dr. Piccoli's slide. It's a beautiful commentary in 2022 October issue at Kidney International. Please go through all of you. She applies the bioethical approach with relevance to this scenario of pregnancy and kidney transplant. We all know in bioethics, actually the 4 major principles are the benefit, no harm at any cost, justice, and autonomy. She tries to apply these principles for all these 3 stakeholders, particularly for the mother. She's always her passion towards the well-being, the emotional well-being of the patient with kidney disease. The lady with kidney disease is amazing, right? What is the benefit of a kidney transplant recipient becoming pregnant? It definitely, it has a say in her quality of life, achievement of motherhood goals, her role in family and society. I'm just surprised, She's a nephrologist in Europe, but the role in family and society is all the more relevant in Asian perspective, right? And we have come across any number of instances where divorces do happen whenever a lady is diagnosed with CKD. So that's what I'm so moved by this approach. And no harm at the same time. We all know there is a potential for the maternal issues like increased incidence of preeclampsia with short-term and long-term negative impact on renal and cardiovascular health. At the same time, every woman has got a right to happiness and reproduction. That's what she talks about. And the autonomy. The treating doctor should not sound so negative and nihilistic. All the facts are to be put forth to the family and to the recipient, and ultimately the woman, the mother-to-be, the kidney transplant recipient should have the autonomy. And some of these phenomena are applied to the graft, because of the graft, we have to think of the graft, because the graft definitely is subjected to stress, and there is the chance for the graft failure, and whether there is increased risk for acute rejection during pregnancy, that we don't know. And the baby, definitely the adverse outcomes on the fetal outcome is there, like particularly the prematurity and intrauterine growth restriction, and its long-term impact on the incidence of hypertension and chronic kidney disease, and then cardiovascular health later on. So all these things have to be factored in. So it is a very, very complex situation, and there are a lot of gray zones. It is not, you can't approach this problem with a simple binary of yes or no, right or wrong. In between yes or no, in between right or wrong, there is a huge gray area in every component of it. And if you go through the literature, there is positive literature, and again and again there is a repetition of references to one major meta-analysis and then few major studies, rest all individual opinions and small case reports and small case series and so on. So in most of my slides, I didn't even have the quotation of the reference, because that's the scenario. I take this opportunity to plead and request all of you, wherever you are working, please contribute. We'll all sit together. Maybe I'll request Dr. Srijit and team to initiate a registry. I'll request Dr. Shyam Bansal to help ISN, to render help from ISN side, and there can be a kind of a pan-India registry. The only way to move forward is collating the data from across the country, right? Fine. The most important aspect is that how to time pregnancy. When after a successful engraftment, when you can allow pregnancy to happen. So there is a difference between European guidelines versus the American guidelines. European best practice guidelines, they say 24 months. Please wait until 24 months. Simply, the reason is that there is increased likelihood for acute rejection initially. But American Society of Transplantation, subsequently KDIGO also has approved this. You do not wait 24 months. Pregnancy may be considered after 12 months, provided these are the requisites. That is very important. No acute rejection in the previous year. The stable graft function, by which I mean a serum creatinine of less than 1.5 milligram per deciliter, with no proteinuria and minimal proteinuria. Minimal proteinuria meaning less than 300 milligram per day. And no acute fetotoxic infections, particularly cytomegalovirus, and the patient not being on teratogenic immunosuppression, particularly MMF and sirolimus and so on. So these are the criteria, the requisites that have to be satisfied before you contemplate a pregnancy. And the most important thing is that MMF should be replaced with azathioprine. Again, there is some disparity between how early it has to be. 6 weeks according to some authors, but to be on the safer side, at least 12 weeks prior to conception. Same thing with the mTOR inhibitor, even though there is a conflicting report that mTOR inhibitor it's not that teratogenic, but it has to be avoided. And the other drugs that have to be avoided, just now we listened to lecture, belatacept, alemtuzumab, antithymocyte globulin, basiliximab, and so on. How about high dose corticosteroids? How about IV immunoglobulin? Because if you come across an acute cellular rejection during pregnancy, how do you treat it? As per the literature, high dose corticosteroids is very well tolerated. Only thing, infectious complications, you have to be careful. And there is no data on the safety of IV immunoglobulin or plasmapheresis, but as such, there is no contraindication for both of them. So even if you encounter an acute rejection, you can treat, right? And about eculizumab, just now we heard, I don't want to repeat that one. Why we are so touchy about MMF? MMF is known to cause multiple anomalies, intercranial anomalies and facial and cranial anomalies and facial anomalies like cleft lip palate, microtia, and hypertelorism. More importantly, there are some more anecdotal reports of even cognitive impairment in the children. But please mind you, the reported incidence is only 23%, even though we are so much scary about it. Why this 20%, 23% I have quoted is that we do come across certain situations, even though we plan and the pre-pregnancy conception planning and the discussion, counseling, everything happens, definitely you will come across a situation where unplanned pregnancy patient is already on MMF. What do you do? It is again, that's what I said, it's a very gray zone. And again, you have to counsel. But it is not mandatory that you have to go for termination of pregnancy because, there is no 100% teratogenicity of MMF. That's what is the argument of people like Piccoli. Fine. And the therapeutic drug monitoring is very important because, there is a change in GFR during pregnancy as well as the drug metabolism. There are a lot of variations, and we all know there is increase in the volume of distribution of the drug. And for instance, to achieve the same peak pregnancy trough level of tacrolimus, you require a increase in the dose to the tune of about 20 to 25%. So the recommendation is that you monitor tacro levels at least once a month during pregnancy. There are some authors who advocate even twice a month initially until it stabilizes, and then at least once a month. Fine. What is the impact of pregnancy on the graft? Does it lead on to acute rejection? There is no evidence to say that pregnancy per se contributes for increase in the rejection. Not at all. It is very interesting to approach this issue with a different perspective. See, even in a normal pregnancy, the fetus, the maternal immune system is concerned, the fetus is an allograft. But how pregnancy is successful, how the maternal immune system tolerates it, what is the mechanism? what is the main cell that mediates the tolerance of the fetus which is perceived as an allograft. Very interestingly, the important cell that causes this tolerance is natural killer cell. Normally we are scared of natural killer cell, right? Natural killer cell, even without DSA, even without donor specific antibody, can mediate antibody mediated rejection like phenotype in the histopathology, right? That's what we do come across. There are instances where C4D negative, DSA negative, ABMR like picture. We believe that it is mediated by NK cells. But the same NK cells in pregnancy behaves entirely different. These are called uterine natural killer cells. During every pregnancy, in the first trimester, there is exuberant proliferation of the uterine natural killer cell under the influence of progesterone and certain endometrium-derived IL-15 and other factors and so on. What do? These uterine natural killer cell is very important for the appropriate depth of placentation and even the spiral artery remodeling and so on. These natural killer cells, they engage with the fetal HLA-C molecule, and certain combinations of the natural killer cell and HLA-C is compatible with successful pregnancy, certain combinations are not. In fact, the natural killer cell has to be stimulated by certain non-self HLA-C. This stimulation of natural killer cell is important for sustenance of pregnancy. And what happens to these NK cells? If they persist, they can enter into the entire system and the allograft can be finished off. But during pregnancy, once that initial placentation is over, the number of uterine natural killer cells starts dwindling down, and towards the end of the mid-trimester it vanishes. So that is the beauty of it. So a little digression, sorry for that. Fine. So gestation per se does not lead on to acute rejection, that's what we know. And the reported graft loss or graft dysfunction during pregnancy in a kidney transplant recipient is primarily dependent on the pre-pregnancy serum creatinine and certain ethnicities, right? I'll discuss that part. The most important complication is the preeclampsia. We all know there is a very high prevalence of hypertension in our transplant recipients, ranging between 20 to 70%. That itself is a predisposing factor for preeclampsia. Now we know preeclampsia is a very, very big syndrome. No, it is not just only the abnormal placentation. There are two different phenotypes of preeclampsia. The one which happens early, it's called uterine preeclampsia. The one which happens later, it's called maternal preeclampsia. The maternal preeclampsia, in most of them, there is perfect artery remodeling and the invagination of the cytotrophoblast into uterine myometrium. All that happens perfectly, but still they develop late onset maternal preeclampsia because preeclampsia is a stress test on the maternal system. It's a stress to test what is the extent of vascular adaptation, what is the capability of the maternal system to go in for metabolic adaptation and so on. We know every lady who has received a kidney transplant already, she has suffered a chronic kidney disease, different stages, transformation to ESRD. So the entire process of CKD progression and ESRD status, there is a terrific endothelial dysfunction. After a successful engraftment, your creatinine might have become normal, your GFR might have been better, but what has happened to the endothelial dysfunction is permanent. So the adaptability of the vascular system to a fresh challenge of pregnancy, definitely it is not there. So there is increased incidence of preeclampsia, and there is a strong suggestion to go for aspirin prophylaxis, right? There is, as per some authors, the incidence of gestational diabetes is higher in kidney transplant recipients. The reason is obvious, because of the weight gain and then immunosuppressants, particularly glucocorticoids and CNIs, right? And there are many reports which quote that increased incidence of urinary tract infection among kidney transplant recipients, and the potential risk is the pyelonephritis. It can quickly degenerate into pyelonephritis because of the anatomy of the ureter and so on. And UTI doesn't stop there. It can precipitate a preeclampsia, it can precipitate a preterm labor and so on. So as per the European best practice guidelines, every month you are supposed to do midstream urine analysis. You have a very low threshold for going for urine culture and treat even asymptomatic bacteriuria. Whenever there is episode of infection, ensure eradication of infection, and once an episode of UTI happens, continue antibiotic prophylaxis for the rest of pregnancy. So these are the guidelines. And moving quickly on to the neonatal outcomes, Again, there is varying data. Initial US data are very scary. Up to 45% of the pregnancies in renal transplant recipients are unsuccessful, and increased risk of preterm delivery to the tune of 50%, and very high commonality of low birth weight and so on. Again, the risk factors are the higher pre-pregnancy serum creatinine and the quantum of proteinuria and the black race in American studies. A particular mention about cytomegalovirus infection. It's a common infection in kidney transplant recipient with high incidence during the first year. What is the potential impact on the fetus? You know, the chorioretinitis and deafness, the psychomotor retardation, and seizures, all that can happen. It can be quite deleterious. And all the more so, you can't give valgue encephalitis prophylaxis during pregnancy. Actually, we had one patient, a pregnancy. She didn't have any clinical phenomena of CMV disease, but serologically CMV was positive. We didn't know what to do. It is a very tricky issue. You have detected evidence for CMV serologically. So quantitative PCR was done, and it was showing very, very, very few copies, and there was a careful observation. We involved ID specialist opinion, and fortunately throughout pregnancy she didn't develop a CMV disease kind of. How about breastfeeding? It has to be encouraged. The concentration of steroids, cyclosporin, tacrolimus and azathioprine in breast milk is insignificant. It will not harm the fetus, so it has to be this thing. Now let me move on to the positive side of the pregnancy outcomes in the recent publications. So our postgraduates, please go through this paper again. It's a nationwide Dutch cohort, you know, and it was a spanning over four and a half decades, 1971 to 2017 data, and they have defined the combined adverse pregnancy outcome. APO stands for that, adverse pregnancy outcome. What do they mean by that? The conglomerate of birth weight of less than 2.5 kilograms and prematurity less than 37 weeks delivery, and severe hypertension, and more than 50% decline in the graft function during pregnancy. So this CAPO, what are the determinants? So this is probably the first ever large study which talks about certain important risk factors. Normally we think about, you know, the pre-pregnancy, serum creatinine, proteinuria, the race and so on. But here, the first ever time, they talk about the midterm percentage drop in the serum creatinine. Okay, we all know, like as I've already said, pregnancy is a stress test. The GFR has to increase. If it is not happening, there is it's worse outcome. But if it is happening, that is good. You can be sure that, you know, the outcome is supposed to be good. The pre-pregnancy eGFR and the midterm percentage drop in creatinine and the midterm dip in the mean arterial pressure. So if these things are okay, the things are better. As you can see here, live birth rate is 93%. Okay, and the mean gestational age is 35. Of course, prematurity is high, but the mean is 35 weeks. And the mean birth weight, even though it is low birth weight, it is not that bad, 2.38. So that's it. And I congratulate the yesterday's presentation of paper. Almost the same thing they have done. I think rightfully you have given the prize as well from Alapura. Like, I think that paper, fine. And see here, the same Dutch cohort. The outcome was poor in early decades, 1980 to 1990, 1990 to 2000. Subsequently, it has improved, right? And now before finishing, I'll just quickly share the MMC data. Women in the childbearing age group of 259, out of them 26 became pregnant. Okay? So, I mean, we have been extremely fortunate to come across very good outcome. Out of 26, the poor pregnancy outcome was only in 6, and the live births in 20. And again, this 6, actually the breakup is spontaneous abortion only in 2, intrauterine death in 1, and medical termination of pregnancy due to various reasons 3. So the remaining 20 successful pregnancies. Yeah, so this is how we define that the preterm delivery is 37 weeks, less than 37, anything less than 37 weeks prematurity. And poor graft dysfunction we defined as more than, rise in creat more than 20% from the lowest level recorded during pregnancy, and graft loss put together. And significant proteinuria meant more than 300 milligram per day. So these are the characteristics of our cohort. The mean age 30.5, mean dialysis vintage about 6+ years, mean age at transplant 22 years, mean duration of follow-up more than 7 years. So this is it. Yeah. The breakup of the native kidney disease, glomerular disease about 46%. Most of them have received kidney from the living donors, and this is about the data about induction immunosuppression. Immediate graft function happened in 93% of them. The pre-pregnancy comorbidities, hypertension is 28%. Probably this is the factor, the young age and the less prevalence of hypertension, probably that reflected in the good outcome. That's what I surmise. And this is the immunosuppression. It was well planned. Most of them have switched over to azathioprine already. Very few occasions we came across mycophenolate and sirolimus when the lady became pregnant. And 25 patients spontaneous conception, only one is assisted reproduction technology. That may be another reason why the outcome is good. The mean maternal age is 27 years. And the median time interval between transplant and conception, 4 years. That's why now the raw rejection and all that. And the infections, herpes zoster, which happened in one patient, and CMV and rubella serology, I mentioned about that in one, and HCV. Herpes zoster, again there was a concern to treat with acyclovir. It is again potentially it can cause acute interstitial nephritis and crystalluria and so on. Patient tolerated well. Rejection happened in only one patient, that too 25 days after MTP. It was a borderline anesthesia. We don't know whether it is the impact of pregnancy or it happened just like that. Okay. So these are the maternal outcomes. 27% of them went in for preeclampsia, no gestational diabetes, and UTI in one who developed graft pyelonephritis, cesarean section 42%, right? So the graft rejection, only one patient, so that turns out to be 3.8%. The impact of pregnancy on the graft function, definitely the graft dysfunction 15.3%. There is a significant difference between the preconception and post-pregnancy serum creatinine. And so the analyzing the factors, actually the preconception serum creatinine and development of graft dysfunction during pregnancy, these were the factors which decided the outcome. The more importantly, the negative outcome, they accounted for that. As you can see here, less than 1.4, more than 1.4. And graft dysfunction during pregnancy. So these were the predominant factors that decided. The prematurity was pretty high, 70%. The mean gestational age was 35 weeks. Low birth weight, again, it was very high, 85%. And incidence of the necessity for neonatal intensive care admission to the tune of 38.4%. And no birth defects and no neonatal or perinatal mortality. And the later follow-up, the difference between the mean serum creatinine between the cohort with good outcome and cohort with poor outcome, but actually you can't really compare with such a small numbers, 21 and 5 and all that, but still there was difference 1.2 versus 1.7. And prevalence of hypertension 42%. So please note, pre-pregnancy hypertension was 28%, but as years go by, but we don't know whether this hypertension is due to the pregnancy per se or other factors have contributed, but that is the fact. And prevalence of proteinuria in the long term again 38.4%. So the cesarean section I already mentioned, and this is the comparison with the Tamil Nadu data. In the general population data, again you can't really compare. That is a very huge number, and this is only 26. One difference is that in the low birth weight they're strikingly prominent in the kidney transplant recipients. And this is the comparison of the published literature. As you can see here, almost all these things are a similar number. And King's College London and graft dysfunction is 38%. And there's a big meta-analysis there the graft loss itself in 9.2%. Luckily, we didn't have that. And finally, one interesting phenomenon. Imagine a situation where an Rh negative recipient receives a Rh positive kidney donor. So there is a theoretical risk for development of anti-D antibody. But even if the infant, the fetus is Rh positive, there are instances, any number of instances happened. But luckily, hemolytic disease in the newborn is not reported in the literature. I think this we have to ponder over as to why is it happening. My profuse thanks to all the faculty and past and current residents of MMC, particularly Dr. Aarti. Initial more than 3/4 of the cases she only compiled and she presented in WCN also. Now she is a consultant in Hammersmith Hospital. And subsequently Dr. Sumati, she is around here. She has completed and she compiled the data. Thank you so much for the wonderful opportunity.
Any comments from the audience? Yesterday, Raja is not here. Raja was in fact telling that we should not get these transplant patients pregnant at all.
No,
I'm
no.
sure that...
I was not there.
No, yesterday he was actually vouching that we should not get these patients transplanted because their own data is not that very good, and many of the data presented yesterday, the outcomes are not very good. Of course, very, very nice to hear the excellent outcomes. I think all this comes with the excellent planning of the pregnancy and the regular follow-up and the excellent coordination with the obstetric unit that makes this happen well, and collating all the data was of course fantastic. Satish, you want to say?
How did you monitor the tacrolimus levels during pregnancies? How did you monitor that?
Actually, MMC tacrolimus levels, even in non-pregnant patient, we don't cross 10. Even in the first 6 months, we keep around 8, not more than that, and subsequently 5 to 6 only. The same levels, we didn't change it.
During pregnancy was a tacro monitored, that's what.
Yes. In some of them, the requirement of tacro dose was increased, but we didn't actually look into what percent of the patients required more. Definitely there is an increase in this.
Suppose the patient becomes pregnant, it is unplanned. So from your experience, what do you do with a woman if she comes with 6 weeks or 8 weeks?
we can continue, and we have to keep a very close watch and monitor with ultrasound and other things and all that. Suppose if the patient is very young, and there are methods of assessing the ovarian reserve and so on. I'm not an expert in that. If things are very good, there is a possibility that we can advise to go for termination and then plan and then go for. Suppose if already the age is not on her side, already 30 plus and so on. If you are not sure about the adequacy of ovarian reserve and so on, still it's worthwhile to continue pregnancy with all counseling and all that. As I already said, it's a very tricky decision, very, very tricky decision. It was good. Only one patient.
Any of them had a second pregnancy?
I don't think so. No.
We have one particular patient, a nurse, who actually became pregnant second time, delivered, doing extremely well. I think that's one of case.
No, the first ever kidney transplant recipient, she had 2 pregnancies.
Sir, any concern regarding graft biopsy, especially in the advanced pregnancy?
Definitely, you have to be extremely careful, and we haven't done. It's no contraindication, but in fact, the location of the graft is relatively easier compared to the native kidney biopsy, but you have to be extremely careful. There are very few situations will arise, right, And another point is that, like if you develop a rejection also, diagnosis is a little difficult. During second trimester, the creatinine will come down, and that may mask occurrence of the rejection process. And because of rejection, once the serum creatinine rises and the blood pressure increases, we don't know whether it's a de novo glomerular disease or occurrence of some native kidney disease or preeclampsia happening because of the hypertension. Because there is a lot of common, we have very few biomarkers for all these things, without biopsy. It's a tricky decision. In fact, very, very tricky this thing. Very small clues like even uric acid nowadays, people don't attach too much of significance for that, and so fortunately we didn't come across such very tricky situations. Probably, as I've already said, most of our patients, the planned pregnancy, few years, not just 1 year, 2 years. The mean itself is 4 years. The chance for acute rejection is less, and minimal immunosuppression, so infectious complications were less, and so that's what the reason for this thing. Maybe, as the guidelines say, if these women can go in for pregnancy soon after 1 year, you may have a lot of problems, because CMV is little more prevalent in our cohort, our patients. We are always scared of CMV. If you get CMV during pregnancy, you had it, how will you treat, and what will be the impact of the CMV on the fetus, and the valganciclovir and all, you can't give. Very, very difficult decision. With one patient itself, we had, the serology was positive and we didn't know what to do. And she was bent upon continuing pregnancy. And we got the help of ID, Ram Gopal. He came and we had a very lengthy discussion, and luckily nothing happened.
So, thank you, Gopal Krishnan. That was excellent, and I think the organizers have reserved the climax for Gopal Krishnan.
Thank you, sir, for the wonderful session. We now request the chairpersons to present the memento to sir. We request Dr. Swati to present the memento to chairpersons.
Now we'd like to resume a session on interesting cases. I would like to welcome the chairpersons for the session onto the dais. Dr. N. Gopalakrishnan, a professor of nephrology and member secretary of Transplant, Chennai, and Dr. Srijit Parameshwaran, professor and head of Department of Nephrology, Jipmer.
I would like to invite our speaker for the session, Dr. Sandeep Morkandikar, consultant nephrologist at Ruby Hall Clinic, Pune. Sir is an alumnus from Jipmer and did his fellowship in nephrology from University of Toronto. His areas of interest include kidney transplantation and clinical nephrology. Sir, please.
Thank you. I will not take that much time. I have already cut short my many slides. So it's a very interesting case, typical of kidney injury in pre-pregnancy. There was a lady who presented to us after almost 10 days, 15 days to our center. She was a 12th standard housewife diagnosed at pregnancy-induced hypertension at 34 weeks of gestation. She underwent almost LSCS for the severe PIH and fetal distress, and she was referred on day 10 to our hospital. And reference mainly was persistent high BP, low hemoglobin, and ongoing thrombocytopenia, which was not recovering even after the delivery. So when she presented to our hospital, definitely she had this high blood pressure and it was a suspicion of abrasive placenta, but unfortunately there was not there, and she underwent a clear-cut LSCS tubal ligation because this was a second pregnancy. It was a male child and nothing happened. And platelet count and hemoglobin started dropping day 3 after the surgery. That's the reason they referred to us what is happening to her. So this was a day 4, day 5, day 7. You can see the persistent decrease in the platelet count and slowly rising in creatinine, or a mild increase in the bilirubin as compared to the pre-transplant or before the pregnancy. So she was referred on the day 10. The 3-4 values which I like to highlight: platelet count 57,000, LDH was 9,000, almost 1900 units per liter. So we just took a history which is required for us. No infections, nothing was there. Other signs: lupus, any infections, fever. She was conscious, oriented, no headache, nausea, vomiting, breathlessness, or any other medications taken from the hospital, because she was transferred in hospital to our hospital directly. Obstetric history: she had a first child at 5 years back, at least 19 years of age, and it was full term and healthy. First and second were abortions. Third was an incomplete abortion, and both happened in the second month of pregnancy. So definitely I suspected possibility of lupus, but definitely we came to this. She was conscious, oriented. Systemic examination, nothing was there. No icterus, no pallor, or anything was there. So she was already on 4 antihypertensive: labetalol, Nicardia, methyl-dopa, and intermittent dose of Arcamin, depending upon how she was doing. She also received at least 24 hours of infusion labetalol when she came to our hospital. Definitely we started her on plasmapheresis given all the parameters we suggested of TMA, because already clear cut she had a consistent finding of thrombocytopenia, AK, and low hemoglobin. We continued with alternate day plasmapheresis, and before doing that we had sent a bunch of tests, like including infection, lupus, APLA, complement factors, everything. So of the all tests, what we saw that the platelet count was still 58, creatinine 1.9, LDH was 1900 that day, kidney size normal, few cystocytes in the peripheral smear, and LFTs were normal that time. So we started plex. First plex, the platelet count increased almost 78,000, and at the end of a third plex, which was done on alternate day, it increased to 1.2 lakhs, with creatinine coming to the 1.1, with the LDH level coming almost to the normal. Our normal range in the lab is 250. So it came to almost 235, so we stopped the plex. In this case, I never gave steroids because referred from a peripheral place, I was worried about any possible sign of infection that can manifest over a period of time, and I was very skeptical to give the steroids. When the investigator was sent, we can see that everything was negative. The only one factor which was like borderline low C3 was there, and the complement factor H antibody came positive. It was done in KM hospital, which is controlled by Dr. Valentine Lobo. He has 3 factors which he does on routine: ADAMTAS 30 activity, complement factor H antibody levels, and other and complements. So finally we just continued, we stopped the things, and patient recovered very well, discharged after 1 week of plasmapheresis, and I just put a diagnosis of pregnancy-related AKI, thrombotic microangiopathy related to complement factor H antibody. So I had multiple slides, but I cut down to only one slide to show what is the highest data. This is one of the highest case series published in CJASN, 87 patient with atypical HUS. Most common presentation is in the first pregnancy. Time-wise, most commonly postpartum, which is our patient is there. Almost 80% patient received plasma exchange. To a 41% received plasma infusions, 5% used eculizumab. And commonest gene was detected was complement factor H and I mutations. So on follow-up, she had been almost followed for last 2 years with me. Intermittently, she has stopped the antihypertensive medication, but she had landed twice in accelerated hypertension once she stopped the medication. The creatinine remains around 1.2 and urine ACR is at present less than 30. She is at present on beta blocker only at present, nothing else. So in conclusion, this is I think one of my first case of after passing from Jipmer, this is the first case of proven TMA where I was treated successfully and patient remain in remission. The only one thing which I have not done is complement genetic study because they are really costly and patient was really poor. Also the plasmapheresis funding was done via crowdfunding to her. Thank you.
Very well managed. As you rightly said, actually there is no need for, there's no indication for steroid here. She's very fortunate. Actually, the outcome of a TMA is not that rosy. Most of the times, what starts as acute kidney injury, they just progress to CKD and even ESRD status. Particularly, the TMA has got the propensity to cause even cortical necrosis. If it is associated with cortical necrosis, the outcome would be very poor. And fortunately, it happened, resolved. And the point to highlight here is that, like 15, 20 years ago, we all of us sincerely thought pregnancy per se causes TMA, snake bite per se causes TMA, acute pancreatitis per se causes TMA. Now we know in all these apparent etiologies, the underlying the genetic predisposition in the form of mutations in the genes regulating the complement pathway is there, and all the pregnancy and everything acts as a trigger. That's it. Only thing, she has to understand the implications of it. And
she stopped the medication twice. Now she understood that she has to take the medication.
And it's very surprising. And she has one successful pregnancy, right?
Yes, sir. One successful pregnancy. Yes, sir. This was the second pregnancy, sir. First pregnancy was successful 5 years back.
Yeah.
Thank you, Sandeep, for a very interesting case. We'll proceed to the next case.
Very rewarding.
Yes, absolutely. Gratifying. She came with the not so good, but hopefully.
I appreciate you initiated the efforts to crowdfund, help a patient and so on. After all, that's what it's like all about.
Yes, sir.
That gives a kind of roundedness to our life.
Yes, sir.
So what good we are in academics and all that activity, when you do such things, that you'll be really blessed. Yes. You and your team.
Yes. Thank you, sir. Thank you.
Thank you, Sandeep.
Thank you, sir, for the excellent presentation. We now request the chairperson to kindly present the memento to sir. Thank you, sir. Our next speaker is Dr. Arun Kumar, Associate Professor of Nephrology at AIIMS, New Delhi. Sir, kindly come onto the stage. Sir has completed his DM Nephrology from AIIMS Delhi and is a GLOMCON faculty as well as a coordinator in ISN Journal Club. Over to the case presentation.
For the organizers for having me here for these 2 days, and I think we learned a lot about everything in pregnancy and really nice case scenarios already. So this is some case which we had admitted last month incidentally, and when the concept of pregnancy and kidney diseases had come up, I thought that I've never seen such a case. It's the outcome is probably not that great, but still it was a case of, we had named it from capillary leak to renal wreck. So this patient, she was Mrs. R. She was a 26-year-old female patient who has been married for 7 years, was a homemaker and a resident of Bareilly from Uttar Pradesh. She had presented with a diffuse abdominal pain and distension for 2 days, worsening abdominal distension for the last 1 day, reduced urine output and worsening edema for 1 day duration. So she was a known case of polycystic ovarian syndrome who had already been treated with metformin, was being evaluated and managed for primary infertility outside, and she was on a controlled ovarian stimulation regimen where she had received FSH and HCG, and she had also received GnRS antagonist. The benefit of giving a GnRS antagonist is that it prevents the LH surge so that you don't have ovarian hyperstimulation. So she had already received this on day 12, the 12th July, and on 15th July she had gone for an oocyte retrieval, and 7 oocytes were retrieved. This would be important because the number of oocytes also give us the future risk of developing complications. On 16 July immediately she started developing abdominal pain, distension, and then had respiratory distress and worsening edema. She had gone to a local center where a paracentesis was done. Supportive treatment was given and patient was referred, and when she had presented to AIIMS, she was having shock. She was in frank shock, oligonuria and MOTS. So this had developed over a period of 2 days. So there was no other positive history, and patient did not have any other comorbidities apart from polycystic ovarian syndrome. She was clinically awake. So she was having pallor. There was bilateral edema extending up to the groin. She was tachycardic, 118 per minute, tachypneic, requiring oxygen support, and was also hypotensive with a blood pressure of 86 or 54 millimeters of mercury. This was in EM. Clinically, the bilateral basal breath sounds were absent, and she was having a tense abdominal distension with shifting dullness. And apart from that, there were no other clinical features. Evaluation wise, in ED it was seen that patient had a deranged renal function. Urea and creatinine was 108 and 4.8. TLCs were raised, platelets were reduced, there was hepatitis, OT and PT were raised with hyperalbuminemia also. Patient was also having acidosis, metabolic acidosis, reduced urine output, and screening ultrasound had shown ascites with a normal kidney size and increased echogenicity. So we had a young female, no comorbidities, who had presented with decreased urine output, anasarca and abdominal pain after oocyte retrieval. And investigations had shown renal dysfunction, thrombocytopenia, normal ultrasound and ascites. So our working diagnosis was in the form of acute tubular necrosis was the first thing. We thought because of the hypotension should have been for a longer duration. That was one possibility. She was having significant edema alone, so capillary leak syndrome, any of the causes can be a possibility. Post-procedural, she can develop ovarian torsion or ruptured ovarian cyst or hemoperitoneum, though the hemoglobin was still normal. That was, we had still thought of it. Acute severe pancreatitis, but the patient did not have any classical abdominal pain for it. MOTS sepsis is always high up. Tropical fevers like dengue hemorrhagic fever can present even without fever. Patient was having a thrombocytopenia with capillary leak syndrome, that is why. And TMA, we could never rule it out. So this was the initial DDs with which we had admitted the patient. The patient was maintained saturation on HFNC, and over the next couple of days she came to oxygen by mask, and then it was tapered. Inotropic support was there only for 48 hours. She was on a single inotrope. BPs were otherwise well controlled, and then she was better. She had significant ascites, so we had tapped her twice. Paracentesis was done, and we had removed nearly 2.5 liters of fluid under albumin cover. And apart from this, we had also maintained the blood pressures using crystalloids as well as intravenous albumin was given. And from the day 2, because patient had stayed oligonuria, patient was on renal replacement therapy, and which was repeated at regular intervals. So she required maintenance dialysis thrice per week. And the following investigations, when we did further workup, the complement levels were normal. Procal was around 3. Dengue autoimmune markers were negative. LDH was high, but it was probably because of the renal dysfunction what she had. It was not on the rising trend, and peripheral smear did not show any cystocytes. With regard to the ultrasound, there was echogenic kidneys with ascites. The Doppler was overall normal and bulky ovaries. As you can see, the kidneys they were of normal size, but they were echogenic, but otherwise they were okay. No obstruction otherwise. Patient had ascites. Right ovary and left ovary, they were around 6.5 centimeters, and they were showing multiple follicles. So this was the only finding. So patient stayed oligonuria was requiring hemodialysis support. Almost all the parameters with only broad spectrum antibiotics and supportive therapies within a week, and patient was only normotensive, BP did not shoot up at all, and the supportive therapy was continued for 2 weeks, but she tended to remain oligoanuric. So our diagnosis right now at this point, when we have ruled out all the other causes, was critical ovarian hyperstimulation syndrome. The renal part was still a doubtful, so we thought it can still be an acute tubular necrosis or probably some TMA which we have missed. So this was the DD with which we had proceeded with the renal biopsy. The renal biopsy showed global tough necrosis along with the necrosis of adjacent tubules and vasculature. There was one vessel, I have not shown that in the biopsy, but that was not showing any TMA. So it was only a complete cortical necrosis. On further evaluation, APLA workup was negative, ENAs were negative, anti-CFH we are having in-house, so we could get it done. So that was also negative. We didn't think of a genetic analysis because of cost constraints, and probably if the patient is planned for transplant, we'll think of it. The diagnosis was overall an acute cortical necrosis following a severe or critical ovarian hyperstimulation syndrome. Usually we see RCN with obstetric complications more commonly, and whenever patient is having oligoanuric and has a setting of hemorrhage, sepsis and DIC, we think of it. Though CCT can suggest the confirmatory diagnosis better with a biopsy, which we should do in our center. Capillary leak syndrome, there are multiple causes. Whenever a patient presents with an edematous, sudden onset edematous illness with multiple fluid accumulation, we should think of HLH, viral hemorrhagic fevers like dengue hemorrhagic fevers, autoimmune diseases like lupus, Sjogren's, snake vein animations, and following some drugs like gemcitabine and monoclonal antibodies. What usually happens is that normally the endothelium has a good barrier. Whenever there is any capillary leak due to any of these aforementioned causes, then there is a leak of protein and the fluid into the interstitium, which in turn results in hypotension because of intravascular fluid loss, which can cause a prerenal AKI. Also the cytokine storm which happens in these syndromes, it can directly cause renal injury also. In addition, patients can develop pleural effusions, ascites, gastric edemas, and also muscle edema, which can also predispose to rhabdomyolysis, which can also cause further renal injury worsening. With regard to ovarian hyperstimulation syndrome, patients develop it either in the early course within the 4 to 7 days or more than 9 days when the patient becomes pregnant usually, and the hyperstimulated ovary usually releases RAS, renin-angiotensin activation is there, and there is also release of vascular endothelial growth factor, which in turn causes a cytokine storm, which in turn causes a capillary leak syndrome. And our patient was having a critical OHSS, so in this patient is going to have a tense ascites because of hemoconcentration, high hematocrits and WBC counts and oligoanuric. This is very rare in the sense that only 0.1 to 2% of patients with ovarian stimulation tend to develop it. The risk factors being age less than 30 years as an R patient, low body weight, our patient's BMI was 18.4. Patient was a polycystic ovarian syndrome patient. However, there was no prior history of increasing estradiol levels, and the number of oocytes retrieved were also less compared to the risk for OHSS, and patient did not have pregnancy. So the risk factors were not more for our patient. Overall, I think we had a discussion on OHSS in the morning. AKA can happen because of multiple reasons, usually because of intravascular volume depletion and compartment syndromes. And management, we have to rely on volume resuscitation with crystalloids. A bolus approach can be used rather than giving continuous fluids in order to prevent volume overload, because the fluids what you give is going to leak into the interstitium after some time. Vasopressors to maintain, and intravenous albumin is the role. Usually we don't give hydroxyethyl starch because the risk of AKA is more with HES. There is one study which had shown there is some benefit over albumin, but we don't use it in acute kidney injury usually. Steroids and IVIG have been tried in a couple of cases. There have been some mouse models also, and also IVIG has been studied in 2 case reports, but overall it is not recommended for critical OHSS even now. With regard to data search, I found that there were 2 cases, both from India. One was a letter to the editor and another from in the Assam Journal of Internal Medicine, where they had reported ovarian hyperstimulation syndrome causing diffuse cortical necrosis. Basically, I have not seen a patient with OHSS having renal cortical necrosis. So it's a severe presentation of a relatively common condition. Nearly 1/3 of patients with ovarian stimulation will have some degree of hyperstimulation, but critical cases are rare, and that too with cortical necrosis are even more rare. So it is a potential complication which we'll have to look out for. Like in our patient may not have the classical risk factors. So that is why a close monitoring would be needed in most of these patients. And for now, a timely paracentesis under albumin cover is something which would be useful for our patients. So I do understand that patient did not have a did not have a good outcome, but this is something which we should be understanding, that patient may present in this, and we'll have to do a biopsy in these cases. Thank you.
Nice presentation, Arun. Actually, it is a learning point for me. Actually, it's very surprising that we have other causes, less common causes for cortical necrosis. So normally, cortical necrosis is a pathology of the tropics. Whenever you talk about tropical necrosis to any visiting dignitary from the Western world, they are awestruck. In fact, they even collect our slides of cortical necrosis to project to their students. It has happened for MMC. But broadly, we have come across cortical necrosis only two situations. One is the obstetric background. There are so many causes, starting from abruptio, preeclampsia, and all those things, IUD, and all that. One is obstetric background because there is understandable, there is a hypercoagulable state of pregnancy. The other one is snake bite. Of late, we have started coming across in acute pancreatitis. And in pediatrics, they say very rarely they come across cortical necrosis in infantile severe diarrhea. But beyond that, the other causes is very, very less, unless there is a coagulating tendency in that recipient patient. However, what will be the severity of hypotension shock, I think causes cortical necrosis. It is a very nice exercise, and congratulations to you, like you have kind of salvaged her life out of such a critical situation. Please publish this one. I am sure you will do.
Yes, sir, we'll try.
Nice case, Arun, unheard of in my this thing. But why do you think she developed the cortical necrosis? Because ovarian hyperstimulation syndrome is likely to be more common, but this patient had cortical necrosis. So what do you think?
So I think, like in most of the postpartum cases also, when they develop cortical necrosis and we have done genetics, it is either a variant of uncertain significance, or we don't get anything in genetic analysis. So I guess like this, I don't have any explanation for this patient per se. Probably if the patient is planned for transplant, I would want to do a genetic analysis, at least MLPA, before I proceed for transplant. But apart from that, hypotension was not severe for the patient. Patient did not have any other thrombotic, because usually ovarian hyperstimulation patients are more prone for thromboembolism also. But the patient did not have any thrombotic tendencies otherwise also in any other vessels. So very less likely if there is any particular explanation which I can give for the cortical necrosis. That is why we are quite surprised. We had expected only a severe ATN. That was our expectation, and because there was a couple of reports of thrombocytopenia, we thought probably there will be some TMA which can be present. But
very interesting, and too much of a cost to pay for trying for pregnancy. So thank you, Arun. That was a very, very interesting case. Thank you.
Thank you, sir.
Thank you, sir. I request our chairpersons to kindly hand over a memento or to the speaker. Moving on to the last session for the day, introducing our next speaker, Dr. Rajiva Lochana, consultant nephrologist at Madras Medical Mission, Chennai. Ma'am is an ERA EDTA fellow, GLOMCON fellow, and has gone on to pursue a fellowship in AST accredited multi-organ transplant as well. Over to you, ma'am. the last session for the day. Introducing our next speaker, Dr. Rajiv Alochana, consultant nephrologist at Madras Medical Mission, Chennai. Ma'am is an ERA EDTA fellow, GLOMCON fellow, and has gone on to pursue a fellowship in AST accredited multi-organ transplant as well. Over to you, ma'am.
Mac connector. Mac connector.
Sorry for that. I thank the few people that are waiting between me and going home. I'd actually practice saying me and lunch, but okay. So, my case is, oops, she's pregnant. So I managed this case as a transplant fellow, and special thanks to all my mentors there. So the lady in question is a 23-year-old married for 3 years, a smoker, unknown kidney disease, diagnosed with CKD at the age of 16, peritoneal dialysis for 2 years prior to transplant, and no blood transfusions or miscarriages. So pre-transplant workup, so she was already on the deceased donor list. So every 6 months they were doing a single antigen bead, and it was always negative. ANA, ANCA, anti-GBM, complement, serology, everything was negative. Overall, she was fairly a good patient to be transplanted, and her pre-transplant UPT was also negative. Now she underwent a deceased donor transplant in 2017. Her donor was a 45-year-old male who had died of subarachnoid hemorrhage with a cold ischemia time of around 8 hours. She was inducted with 5 mg per kg of thymoglobulin. Even when I was there, I was quite surprised at the high doses that they use. And generally, the protocol there is to give IV methylprednisolone for a week or so before starting TAC in view of DGF. She started on MMF and tacrolimus subsequently, and her creatinine was 0.9 after 2 weeks and was doing well. And then we removed the PD catheter. 3 months post-transplant, everything was hunky-dory. Creatinine was 0.7, there was no proteinuria, and she was on very baseline medications and cotrimoxazole prophylaxis. They actually do not give CMV prophylaxis. It's more of a preemptive sort of preemptive sort of management, where they keep checking the CMV PCR and then only they give the treatment. And serum BK, which was being monitored monthly, was negative. DSAs were negative, and TAC level was kept at around 9. Then 6 months later, when she came for a regular 1-month transplant clinic follow-up, she had delayed her appointment by 2 weeks. She complained of fatigue, nausea for 3 weeks, good urine output though, no hematuria, no fever. Examination-wise, she had pallor and mild tenderness at the allograft site. Her blood pressure was slightly on the higher side, and she had a half a kg of weight loss. So when we did, urgent labs were ordered, and her hemoglobin was 9. Her urine analysis was active, and she had proteinuria. Proteinuria had not come at that time. It was around 3 grams. Creatinine was 4.5, and otherwise it was Urine culture was sent, it was negative. A tox screen was sent, which was negative. Coagulation profile was normal. LDH was within normal limits. LFT was normal, and TAC level had dropped to 4. So at this point, the initial differential at this point was, is it an ABMR or an ACR? So we urgently sent her for an ultrasound, which showed no graft hydronephrosis, good arterial and venous blood flow in all the poles. RI was 0.6, and incidentally, the radiologist called us saying that she is pregnant. So approximately 14 weeks of gestation. So then everybody panicked. We recalled her to the ER, but she came after 2 days comfortably, and her repeat creatinine at that point was 5.5 milligram per deciliter. An urgent allograft biopsy was done with no complications. As expected, there was glomerulitis, there was PTC2, C4D was positive, significant interstitial inflammation, and it was basically hell broken loose. C4D was positive, it was an ABMR with an ACR. Class 1 and 2 antibody was remeasured, which was negative. Obstetric psychology, all nephrology team was obviously involved. And she was counseled for MTP at this point because she was only 6 months post-transplant, she had an acute graft dysfunction, and she refused. And then she herself said that she had stopped MMF for 2 weeks after reading up about the drugs during pregnancy. So she didn't tell us, and then when we found out and were surprised, she told us she stopped MMF. Now, the possible reasons for rejection have been the low TAC levels, she had stopped MMF, probably non-adherent because she was pregnant, low absorption of drug, she was nauseous, she was not eating, and her anti-HLA antibodies, so there was no DSA. So was there any non-HLA antibodies, or as Gopalakrishnan sir elucidated, is there an NK cell involvement in this rejection? See, is rejection that common during pregnancy? In fact, pregnancy is actually a state of immunological tolerance. There's an immunodepressant activity, and to some extent it is protective for the renal allograft. But there is a possibility that there is an antigenic stimulus provided by the fetus which may trigger graft rejection. In fact, all the reports that are there are actually postpartum with a higher risk because they return to a normal immunosurveillance. So generally the risk of rejection is higher postpartum. So the rate is actually not increased during pregnancy or 3 months postpartum, and is around 14.5% maximum, which is pretty much comparable to the non-pregnant transplant recipients. Now, what are the risk factors for rejection during pregnancy? One is a higher serum creatinine, more than 1.5 pre-pregnancy, any prior rejections, and definitely the variable immunosuppressive drug levels. So there was one review which showed that one meta-analysis where the average rate of pregnancy rejection during pregnancy is around 9.5 to 10%. It's actually highest in Asia, and graft loss is around 10% once they have developed the rejection. And definitely in patients who have developed the rejection, the postpartum creatinine is much higher than the preconception creatinine. So how do you diagnose rejection during pregnancy? Sometimes it is difficult. There may be these minor variations in creatinine, and that can be confounded due to the hyperfiltration related decrease in the creatinine during pregnancy. And I think the previous session somebody asked, yes, it is safe to do an ultrasound guided allograft biopsy, and the rate of complication in pregnancy is around 7%. It's just in one paper, and with highest risk between 23 to 28 weeks. And results of a kidney biopsy, however, can change the way you manage this patient 66% of the times. So what did we do? She refused MTP, so we stopped the MMF. She had already stopped the MMF. We added azathioprine, gave her IV methylprednisolone 1 gram for 3 days, aspirin, labetalol was added for BP control, cotrimoxazole was continued, amlodipine was continued. During the IV steroid, she had slightly high sugars which were managed with insulin. Again, she was counseled for MTP, and she was started on folic acid and calcium supplements. She was advised dialysis. Again, she refused. So, even in Sir's series, I think some people were already exposed to MMF. What is the risk once they have already been exposed to MMF? It's around 26.7%, and they can have all sorts of structural abnormalities, much lesser in sirolimus if it is there pre-pregnancy. Then we started her on alternate day plasmapheresis with 100 mg per kg IVIG post plasmapheresis for 7 sessions. Increased the dose of oral steroids. We adjusted the tag to keep it to 8, and weekly fetal Dopplers and obstetric reviews were done, and the urine output was maintained throughout pregnancy, thankfully. So after 7 sessions of plasmapheresis, at which point she was around 17 weeks pregnant, creatinine was 1.6, her proteinuria had come down, and her blood pressure was fairly okay on 2 drugs. Now the same regimen was continued from 17 to 29 weeks of pregnancy with weekly monitoring of all her functions. So immunosuppression wise, in an ABMR during pregnancy, we don't have that many options. Tacrolimus, yes, it's safe during pregnancy. Steroids, the commonest used drug during an rejection. Azathioprine is safe but not a great drug during an ABMR. There's no data on ATG and rituximab, but I think eculizumab is fairly safe during pregnancy. So how do we interpret TAC levels? I think this question was also asked during the last session. The TAC levels, actually the unbound fraction of TAC significantly goes up during pregnancy. So if somebody has anemia or if the albumin is low, generally the unbound fraction is much higher. So what used to happen was, they used to regularly monitor if the levels is say 4 or 5, at say 3 years post-transplant 5 is definitely alright. But do you increase the TAC level? Generally the unbound free drug goes up significantly and you can have TAC toxicity. So in fact what we did of increasing that TAC to 8 was actually not pretty much warranted. The unbound drug which is available for cellular diffusion is actually more important for preventing the rejection. So practical point is, try to maintain it at the level you generally maintain it during that time, because anyways your unbound level goes up by almost 100%, and start seeing for features of TAC toxicity. If you have them, slowly decrease it. So I think it should be individualized to the patient's hemoglobin as well as symptoms. IVIG during pregnancy. This was another question. Can we give IVIG during pregnancy? So IVIG is already being used in pregnancy for certain rare scenarios. There is not much data of ABMR during pregnancy, and the long-term immunologic effects on the fetus and neonate are poorly understood. Now she was 32 weeks pregnant. She came to the ER this time with eclampsia. She had skipped the antihypertensives for 2 days. Creatinine was still 1.5, and an emergency C-section was done, and she delivered a preterm IUGR baby. So acute rejection versus pre-eclampsia, if there are any postgraduates around, rejection is generally a higher creatinine, pre-eclampsia is generally a higher degree of proteinuria, there's a higher graft loss, poorer long-term graft survival, and a preterm delivery is much more in acute rejection than pre-eclampsia. And generally, it may generally be a double trouble. You have acute rejection and worsening of hypertension, like in our case, where she had eclampsia also. Newer markers like SFLTs and cell-free DNA may help us distinguish between these two categories. So postpartum 1 week, at this point she was almost 9 months post-transplant. She had a good blood pressure. Creatinine was 1.6, DSA was negative. She was still on AZA, TAC and Vicelone, and child was in NICU, was doing better. So what next? She was again counseled for contraception. She refused. Restarted on MMF after stopping azathioprine. A repeat kidney biopsy was performed, which did not show any rejection at this point. The child was discharged. She was not breastfeeding, and we had actually sent the blood to Mayo Clinic, which was doing a research project at that time, and it came out to be anti-endothelial antibody positive. So what did I learn from this case? This patient is actually lucky. Not many patients could have been managed like this. Most of them would have either lost their graft or may not have made it through the pregnancy. Importance of pre-transplant contraception. The armamentarium to treat acute ABMR in pregnancy is limited to steroids and Plex, and there's definitely a high risk of maternal and fetal complications. Thank you. This was the team which helped me take care.
Thank you, Dr. Rajiva. First of all, apologies for the delay in the program schedule. We started a little late in the morning because of some technical issues, so apologies for that. The number of audience is also less, but you have compensated with a very challenging case scenario, which I think would have helped a lot of more people. I hope somebody is listening on the live YouTube stream also. One point which you mentioned about the TAC, I think I missed something. You mentioned that the TAC C0 is to be kept within the normal range, but then there was some mention of not to change the dose unless there is a 50% reduction. So what does it mean that suppose you are keeping around say 6, we need not change the dose unless the TAC level goes below 3, or is that what it means?
Yeah, sir, because generally the unbound levels in almost every pharmacokinetic study has been done. In pregnancy, it goes up by almost 100%. In this lady, her HP was actually only 8.5 and her albumin was like around 3 or something. So when the albumin also goes down, TAC being very highly albumin bound, protein bound, the unbound fractions of the drug is going to be very high. So there is no need to increase it more and more, just to try to keep it around 6 or 7. If it's around 5, just keep it there and see how it goes.
No, but we need not increase the dose unless the TAC level goes
False,
by
yeah.
more than 50%.
50%, yeah.
Okay, all right. Thank you. The other thing, the patient seems to have been aware of her pregnancy even though she didn't. So this patient seems to be someone who don't believe in sharing information with the treating team, because she seems to have found that she is pregnant or suspected pregnancy, and she read up and she stopped MMF, but then she didn't. You had to discover it on ultrasound.
Yes, actually, that particular transplant clinic day, I only saw her, and she was very kind of, she was not answering too many questions. All she said was, "I'm feeling sick." That's it. And the more you force them, they are not too forthcoming. And I being a fellow was scared to push it further. Like probably here, I would have been a little more forceful in asking the questions. But then ultimately, I know it was quite a miss in terms of the history. I agree.
No, I didn't mean it that way. I was thinking the patient's attitude seems to be a little different. That no, she is aware. She read and
She
then
was
she
aware,
stopped
sir.
MMF.
After we admitted her, she told us that she stopped MMF for 2 weeks. Yeah. Yeah, first admission. Yeah.
So she definitely knew, and she read up and then she stopped MMF, but then she didn't tell the doctor.
Actually, young persons, whenever you go for transplant, I think I keep telling that, but we haven't really implemented. Thorough psychoanalysis of the potential transplant recipients is very important. We need to devise a kind of a scoring system for adherence, non-adherence, and obviously the way you have presented her, she's not in the real fit state of mind, refusing for biopsy, refusing for dialysis, refusing for contraception, and stopping medicine on her own. I think the psychoanalysis of the recipients is very important. In MMC, this is the problem we have. 28% of our patients are non-adherent, in spite of getting the immunosuppression totally free of cost by the government. It is not the cost factor; it's beyond that, and that's it. And because of the very heavily crowded and overburdened workload, clinical work, it's very difficult for us to spend a lot of time with the individual patient also, and I don't know how she is now.
So I did email them regarding her. So I think last year she lost a graft. So this is around 4 years after thing. So I don't think overall it was a very bad run. It was around, I think, 7 years of good graft function. I mean, slowly, progressively losing graft function. But I would just attribute it to her non-adherence also, because she got really lucky here. Non-adherence. And when she was answering, she looked, that's why we sent a talk screen, because we thought she was on some sort of a drug. The way she was answering, the way she presented, she told us later that she's pregnant. So all this, that's why we sent a talk screen, but all the cocaine, everything came negative actually.
Good
Thank you, sir.
clinical presentation.
Thank you, ma'am. We now request the chairperson to present the memento to. Thank you all for the wonderful session. This brings us to the conclusion of this event. We request Dr. Sabarina to give the vote of thanks.
Good afternoon, everyone. I think first of all I should thank Professor Srijit Parameswaran and Professor Priyamada ma'am to give us an idea that we should start a CME on some theme. Then actually we decided and we found this topic somewhat unique. So we thought we will arrange a small CME. Then gradually it built up and it became like the talks and the discussions went on, and we started calling faculties across India as well as from outside India. And it's all because of his motivation, this constant support from the beginning till now. That is what I can say. And I should thank sir for guiding me in all the steps. So whatever I ask, he replies very politely, and he gets it done. And sometimes he constantly reminds me that some small works that usually we miss, he remembers it and he reminds. So I think I have to thank him for giving me this opportunity to take this event. And this is my first probably the CME that I'm taking as organizing secretary. And I have to thank madam in many ways, who has supported us in giving ideas about the topics, how we can frame. And she contributed a lot to the quiz questions too. I should thank Dr. Swati, who is actually a backbone, and as well as she has taken the major role as a quiz master in this CME, and she has worked a lot, and I know that she has some sleepless nights too for this quiz, and it's very tough to prepare in a one single focus topic. And I should thank Dr. Karthik, who was always on my side whenever I had some sort of some things that I cannot solve. He actually solves it in a very good way. And I have to congratulate all the residents who came up. Probably in the last 2 days, they were actually the entire support, and they are the backbone of this event. I should thank all of them. And I have to specifically thank the transplant coordinators, staff nurses, and most importantly, speakers and international speakers who accepted our invitation and who have come across from all over from India, from across all the parts of India, and who has participated in these events. And the residents, the numbers were great. The registration went beyond 200, and that I think that shows the importance of this topic. Thanks once again for having you. I mean, for all of you being here with us and make this CME a grand success. Thank you.
We request everyone to stand up for the national anthem.
Whatever I was just sharing personally with Dr. Srijit, I thought it's worthwhile to express my reflections on this. Such single thematic CMEs really, on a personal note, I think most of you will agree with what I say. The learning is much more than a big mega conference, and very focused and very thoughtfully designed program, and innovation, and the case-based scenarios, the way the brochure was prepared, starting from the logo, every aspect of this academic meet I thoroughly enjoyed. On a personal note, I learned so many things. I go back with enriched knowledge, not only just recapitulation of what we already know, but it's like sharing of ideas and a wonderful platform. The hardcore nephro academics, and again, pulling such a big crowd in the modern days is very difficult, because almost every day there is some program and lot of online platforms as well. In spite of that, the registrations crossing 200 is something phenomenal. My heartiest congratulations, and thank you all, and may God bless you. Looking forward to more such these things, and again I reiterate my request. Your unit can be the starting point for creating a national registry for pregnancy among transplant recipients. In my capacity as the chairman of the scientific committee of ISN, we are in the process of initiating registries, and the ISN is very particular about it, and we can work upon the logistics and how to go about and so on. I'm going to request all the departments across the country to have one topic as the registry point, and there'll be the kind of fulcrum for that, and ISN will be supporting kind of thing. Okay. One of the aspects of this kidney disease and pregnancy, you can take up and have a discussion. Once again, my heartiest congratulations to all of you. Thank you so much.
We request everyone to join for lunch being served on the ground floor. Thank you.